Good morning, all the delegates. Good morning to all my faculty, esteemed faculty who has joined, and from all over India and abroad. I welcome you all to the Orchestra of Hormones, jointly done under the President of FOXI, Dr. Shanta Kumari, jointly done under the Endocrine Committee of FOXI and International Academic Exchange Committee of FOXI, with the FOXI itself. The FOXI is welcoming you all to this Orchestra of Hormones, and the play of the hormones. Without that, there is the body won't work. So without wasting much amount of time, I welcome you all to the Endocrine, the Lifeline program, and I hand over the first session to Dr. Jigyasa to start the topics.
Hello and good morning. Without wasting much of time, I'd like to invite. Yes, ma'am.
Just a minute. Can we have Dr. Jigyasa's CV, please? Dr. Jigyasa is a very active person, and she's been working very actively for our endocrine committee and for FOXI itself. And she is the MOC for today. And over to you, Jigyasa, please.
Hello and good morning. Without wasting much of our time, I'd like to start our session by inviting Dr. Neera Agrawal, madam, who will chair the session of Dr. Amaya Purandre, sir, who will speak on MNT in GDM. Madam is graduate and postgraduate from KGMC, Lucknow, and she has been organizing secretary of Bareilly chapter of UP and past president of the same zone. She is North Zone coordinator of Safe Motherhood Committee and has been invited as speaker at national and state levels. Madam, over to you.
Thank you, Jigyasa. Very good morning to all of the organizer and all the faculties. I'm really proud that she has given me an opportunity. I'm thankful to Rakhi for inviting me and being a part of this Orchestra of Hormones. It's very important. Nowadays, we are seeing rising incidence of all hormonal imbalance. First of all, I'm thankful. And today I think Dr. Amaya is the opening batsman for this Orchestra of Hormones. Medical nutrition therapy is a key complaint of the disease, diabetes, education and management. MNT is defined as nutritional based treatment provided by a registered directive nutritionist. It's very important. Today we are going to deal with, and Dr. Amaya is a young, talented FOXI office bearer, and he is second vice president AMOGS 2020 and joint secretary 2019 FOXI, chairperson food, drug, medical and instrumental committee from 2015 to 2017, and he is the recipient of so many awards, and at present he is working as a consultant in Permanent Hospital and KJ Sunawala Medical College. Welcome, Dr. Amaya, for such a nice and important talk on the MTP medical nutrition therapy in case of GDM. As we know, it's a rising incidence in pregnancy. In day-to-day practice, we are seeing so many cases of the diabetes also. Thank you and welcome, Dr. Amaya. Now over to you.
Thank you, ma'am, for those kind words of introduction. And thank you all the office bearers of FOXI for inviting me to participate as faculty in this very important CME, and as well as giving me the opportunity along with Dr. Krishnendu Gupta, Dr. Rakhi Singh and Dr. Vajra Baste to be one of the coordinators for this important CME. I have been given the topic of medical nutrition therapy in GDM. FIGO has very clearly said that hyperglycemia or GDM should be considered a global health priority because it is one of the most common medical conditions that women encounter in pregnancy, and 1 in 6 live births occur to women with some form of hypoglycemia, which amounts to 85% of which are due to GDM. Now, why is this so important? Because they very clearly say that it is a leading cause of maternal mortality and morbidity, as well as perinatal and neonatal morbidity, and later on even long-term consequences for mother and child. More importantly, it's on the rise globally, and therefore we need to move towards achieving the SDG goal 3, which tells us very clearly that if there is a link between hyperglycemia in pregnancy and poor pregnancy outcome, the future risk of diabetes, both in mother and child, a focus on prevention, screening, early diagnosis, and managing hyperglycemia in pregnancy is needed globally. And that is why I think MNT is very important. We all know that unfortunately, India is the diabetic capital of the world. 1 in 6 adults with diabetes in the world come from India. And more importantly, 1 in 4 live births, as per the latest census, are affected by hyperglycemia in pregnancy. You can see here that not only is the elderly more affected, but it's even the younger generation which is getting more affected, irrespective of sex, with diabetes. So that is why MNT is very important. Now, whenever we are managing GDM, there are 3 important aims. 1, good and optimal antenatal care should be given, if possible, with a GDM-trained healthcare provider. There should be frequent follow-up, and from the patient side, she must be taught and she must be motivated. And of course, she must execute self-monitoring of blood glucose universally for all patients with GDM. There are 2 cornerstones of managing GDM, we all know. I'm going to be talking about the lifestyle issue, that is nutrition and physical activity, because they are key to reduce future obesity, type 2 diabetes, and cardiovascular disease. And if this unfortunately fails, then we have to move on to the pharmacological management, that is using either the oral medications or insulin in the appropriate cases. Edison said that the doctor of the future will no longer treat human frame with drugs, but rather cure it and prevent disease with nutrition. And I think he was probably talking very aptly about medical nutrition therapy. To put it scientifically, medical nutrition therapy in pregnancy is described as a carbohydrate-controlled meal plan that promotes adequate nutrition with appropriate weight gain, normoglycemia, and the absence of ketosis. So therefore, nutritional intervention for pregnancy complicated with diabetes is consistently considered a fundamental treatment modality. This has been proposed way back in 1998. And hence, it's the first-line therapy in all women diagnosed with GDM. However, there is a paucity of data to provide evidence-based recommendations for most nutrition interventions, but the impact of nutrition practice guidelines show improved metabolic control for both type 1 and type 2, and a positive impact on the metabolic goals of GDM. So MNT is the primary therapy for close to 30 to 90% of women diagnosed with GDM. The challenge, however, is to balance the need of a healthy pregnancy with the need to control glucose. So what are the goals to achieve normoglycemia? The targets are simple: fasting glucose below 100, 1 hour below 140, and 2 hour postprandial below 120. This has been proposed by the ADA in 2015 and is accepted globally as the standard of targets. Now, providing the required nutrients for normal fetal growth and maintaining optimal maternal health is the primary goal. But in addition to that, we must prevent excessive maternal weight gain, particularly in women who are overweight or have gained excess weight during pregnancy. And last but not the least, most importantly, we need to prevent ketosis. We have a 5-pronged attack, which is a part of MNT, and that includes nutrition therapy, physical activity and exercise, self-monitoring of blood glucose, nutrition education, and pharmacotherapy. Let's begin with nutrition therapy. Nutrition intervention for GDM is recognized, as I told you, as the cornerstone of therapy. In patients who have received nutrition therapy, they have found fewer patients require insulin, a decreased HbA1c, lower serious perinatal complications, and less macrosomia. Now, however, it has to be individualized food plan to optimize glycemic control, and it should be based on personal and cultural eating habits, physical activity, blood glucose measurements, and the expected physiological effects of pregnancy on the woman and her fetus. These are the standards of weight gain in pregnancy, which are recommended by the IOM in 2019. But do the IOM and other recommendations for weight gain and caloric intake apply to the woman with GDM? There is no indication that the normal weight gain, a normal weight and the underweight woman with GDM should not follow the IOM weight gain guidelines and caloric intake. These women need to gain the usual amount of weight and not restrict calories to ensure a normal infant birth weight. However, if the woman is overweight and obese who produces larger infants independent of weight gain, there is no consensus at present regarding calorie and weight gain recommendations. But restricting calories has been a strategy for controlling weight gain, glucose levels, and avoiding macrosomia. Successful pregnancy outcomes have been reported when the caloric intake has ranged from 1500 to 2800 calories per day. These are the various trials which have shown that restricting calories has got its own advantages. However, one must keep in mind that in some of these studies, there was an increased risk of ketonemia and ketonuria. And hence, severe caloric restriction, that is, if the woman is restricted to less than 1500 calories per day or close to a 50% restriction, it increases the risk of ketonemia. In type 1 diabetes, where high levels of third trimester ketone bodies impair the mental development of the offspring, this must be always kept in mind and must be avoided. And hence, modest caloric restriction, that is ranging between 1600 to 1800 or close to 33%, is probably the golden figure, as it does not lead to significant ketonemia. Daily energy intake of about close to 2000 calories in all BMI women with GDM has reported to reduce weight gain, maintain euglycemia, avoid ketonuria, and achieve average birth weights of about 3.5 kgs. And to put a rule of thumb, the caloric formulas that have been suggested are about 35 to 40 for underweight, 30 to 35 for normal weight, 25 to 30 for overweight, and 23 to 25 for those with pre-gravid weight or who are obese. We now move on to the three important macronutrients in our diet: carbohydrate, proteins, and fats. And this is the percentage that is recommended in GDM as far as these three contents are concerned. We all know carbohydrates are an important dietary source of energy, vitamins, minerals, and fiber content, the main nutrient that affects postprandial glucose levels, and it can be manipulated by controlling the total amount of carbohydrates, the distribution of carbohydrates over several meals, and the type of carbohydrate. The glycemic index is very important as it can provide additional benefit to total carbohydrate control. Foods with low glycemic index produce lower post-meal glucose elevation, while those with high glycemic index show higher postprandial glucose elevation. Less than 50 and more than 70 are important cutoffs as far as the significance of glycemic index in GDM is concerned. But what we know is that if low glycemic index diets are followed, it is associated with less frequent insulin use and low birth weight than in controlled diets. And hence it is the most appropriate dietary intervention to be prescribed in patients with GDM. Pregnancy, however, does not change the GI values of specific foods, and each woman needs to determine which foods to take, to avoid, and to consume in smaller portions at all meals or during specific times of the day for the duration of her pregnancy. And that is what is called as carbohydrate counting. It works as follows. A dietitian determines a person's dietary needs. Individual is given a daily carbohydrate allowance. It is divided into a pattern of meals, and it can be expressed in grams or as the number of carbohydrate portions allowed per meals. This is how it is actually used in practice. 6 meals daily, 3 main meals, 3 snacks, and you can see that each one, there is a breakup that is done by a dietitian. What we need to remember is 175 grams of carbohydrate per day should be provided, which is higher than the 130 grams per day recommended for non-pregnant women. This is as far as fats are concerned, and they are to be distributed amongst the saturated, the polyunsaturated, and the monounsaturated fatty acids. Fibers are an important part of the diet. Soluble fibers lower serum lipid levels and reduce glucose exertions. Low glycemic foods have higher fiber content, and 28 grams of fiber per day is recommended. It also reduces constipation. It increases satiety, lowers the absorption time, and lowers the glycemic index. We have both soluble and insoluble fibers that are available. Physical activity and exercise is an obvious adjuvant therapy to nutrition therapy in women with GDM, and light and moderate intensity activities such as walking for about half an hour per day can be safely encouraged, and it causes modest improvements in glycemic control with this particular intervention. This is what has been proposed by FIGO, and they say that about half an hour per day, or you could do even brisk walking or arm exercises while being seated in a chair after every meal. And with women who are physically active prior to pregnancy should be encouraged to continue their previous exercise routine. Nutrition education is very important, and women with GDM must be counseled and educated about the importance of diet, as it empowers them to choose the right quantity and quality of food. This can be achieved through by teaching portion sizes or using the plate model as we are aware of, and a culturally appropriate food pyramid or a color coding of the food. Micronutrients are very important in pregnancy, and there is no indication that women with GDM should not follow the same guidelines for micronutrient intake as we give to all our other pregnant women. Now, moving on to the next aspect, which is very important, is that of blood sugar monitoring. Blood sugar control is evaluated in 3 ways in GDM. One is the HbA1c, second is the self-monitoring of blood glucose, and continuous glucose monitoring. Now we have mobile apps which help us with the help of artificial intelligence. HbA1c correlates with the risk of congenital malformations and not any other adverse outcomes. It tells us the average glucose levels in the prior 3 months of measurement, and therefore is best used for pregnancy planning and prenatal follow-up in patients with diabetes in pregnancy. It does not replace the OGTT for diagnosis and may be used to verify the reliability of the self-monitored glucose levels. The self-monitoring is done by a handheld glucometer. It checks the capillary blood glucose, but it may miss any glucose values between hyper and hypoglycemic events. But it is important that we use it because it helps us greatly in achieving tight glycemic control and reduce pregnancy complications. Of course, now we have the subcutaneous sensor which is available. It helps us to precisely detect glucose fluctuations and modify treatment, but it may not be universally available or affordable and does not have any clear-cut benefits in GDM as compared to the self-monitoring of glucose. How should the self-monitoring be done? It should be done at least 3 to 4 times a day, fasting, following at least 8 hours of overnight fasting, and postprandial 2 to 3 times a day, 1 to 2 hours after the onset of meals, rotating meals on different days of the week. It should be done in all pregnant women with diabetes at least once daily with documented relation to the timing of meal. It is absolutely essential to emphasize to the patient of GDM that she needs to keep a glucose diary or a diabetic diary with her and note down these readings. So to conclude, friends, nutritional counseling and physical activity are the primary tools in managing GDM. Women with GDM should receive practical nutrition education and counseling that empowers them to choose the right quantity and quality of food. Nutrition recommendations include managing weight gain, control of caloric intake, modifying macronutrient composition and distribution, and providing vitamins and minerals to meet the pregnancy's need. The food plan, therefore, should be designed to fulfill optimal nutrient requirements, achieve glycemic goals without weight loss and ketonemia, and be culturally appropriate and individualized to take in account the patient's body habitus, weight gain, and physical activity. Nutrition intervention should emphasize healthy food choices, portion control, and cooking practices, and women should be repeatedly advised to continue the same healthy eating habits even after delivery to reduce the risk of future diabetes, obesity, cardiovascular disease, and even cancer. GDM diagnosis should be done by blood tests in a standard accredited lab. The handheld glucometer with properly stored test strips can be used to measure plasma glucose in primary care settings particularly in low resource countries where lab facilities may not exist, and it should be done at least 3 to 4 times a day. I was, as Joint Secretary, a part of the seventh conclave, which we had initiated in the TOG, and Foxy came up in 2019 with algorithms for managing hyperglycemia in pregnancy. It looked at 4 important things. What do you give to the woman in diet? How much does she exercise? How does she self-monitor glucose? And what is the pharmacological treatment that is offered? Using this stepwise program, I think we will be able to conquer diabetes in pregnancy in the future and ensure that our women have a sweet and healthy diet. Thank you.
Thank you, Amaya, for such a nice and elaborative talk on MNT in GDM, because as we know, incidence is increased as people, they are not taking care of their diet as well as exercise, because dietary habit is really bad. Nowadays, increased carbohydrate and all in pregnancy. As soon as pregnancy is established, patient start consuming that. It's a thing we can have so many things in during pregnancy. And moreover, what happens once they are diagnosed GDM, we advise them, but after the delivery, they forget. Because next time when they come with the higher levels of the levels, because they forget after delivery what is going to treat. So our aim is to counsel and to teach them and to have them proper nutritional diet, so they can have proper and I think fruitful in their proper life. Thank you, Amaya, for such a nice lecture.
Thank you so much. Thank you, Rakhi, once again, and all the organizers and President Foxy and office bearers.
Thank you, Amaya sir, for clarifying the role of MNT in GDM. Thank you, Neera madam, for chairing the session. After diabetes, other important endocrine disorders are thyroid disorders, and our next session is on thyroid as an emergency, which will be spoken by Dr. Shaila Sheikh. And to chair her session, I'd like to invite Dr. Shailja Bidri madam. Madam is
the CV of Dr. Shailja Bidri, please.
Hello.
Hello.
Hello, Raki.
Welcome, ma'am.
Hello. Good morning to everybody. Hello.
Madam is presently working as professor and unit chief of OBGY department at BLD Medical College, Vijaypura. He is socially very active and has conducted many camps, received Senior Scientist Award by BLD. Over to you, madam, for further conduction of the session.
Good morning, everybody. It is my proud privilege to introduce our eminent speaker, Shaila Sajid Sheikh. She is endocrinologist, consultant endocrinologist at Prince Ali Khan Hospital, Saifi Hospital and Okat Hospital, Mumbai. Principal investigator in International Clinical Trial 34. Member of Executive Committee, ESI Diabetic India. Treasurer of ESI Maharashtra, member of Scientific Committee CAD, awarded Top Doctors Mumbai by TOI Group from 2017 to 2020, and author of International Hajj and Diabetic Guidance and IDF and DRA Guidelines 2021, published many papers and review articles, and speaker at national and international level. I am welcome Dr. Shaila Sajid Sheikh for the speak. Hello.
Yes, thank you.
It is my great pleasure to say thanks to Dr. Rakhi, my friend. Thank you.
Thank you, ma'am, for being there.
You could hear?
Yes.
I welcome Dr. Shaila Sajid for the talk.
We cannot hear her.
Hello.
Shaila ma'am, cannot hear you.
Wait,
Not
Gautam,
audible.
please stop screen. Gautam, please stop.
Shaila ma'am, you're not audible. Raki, can you call her, please?
2 minutes, ma'am. 2 minutes.
Aruna, this is a recorded presentation, so it's a problem with the transmission.
Okay. Rahul,
Good. Hi, good afternoon, everybody. At the onset, I would like to thank the Foxy team for inviting me and making me a part of this meeting. It's an absolute pleasure being over here. To be very honest, the topic which has been assigned to me is thyroid emergencies. But we are now in an era where, we have such easy availability of thyroid function tests. We are more aware about thyroid abnormalities. And not only are we more aware of thyroid abnormalities, even our patients are more aware of thyroid disorders. And so to a very, very significant extent, I would say thyroid emergencies have really reduced. It is, I think, in the last 5 years, I've seen one case of a thyrotoxic storm, to be very honest with you. We do see patients coming to us with severe hypothyroidism, but we may not necessarily see them with myxedema coma. But having said that, I think it's very important for us to be aware about the thyroid emergencies. And why am I saying be aware of the thyroid emergencies? Because if you do not have a high index of suspicion when a patient comes to you with a thyroid emergency, the mortality, mind you, can be very, very alarming. So what is apparently a simple problem, which if it gets converted into an emergency, can become a very major problem for you. And that is something we don't want. And that is a reason I think it is very important that we are at least aware about what these emergencies involve, in what potential situations we should be thinking about thyroid emergencies, and what we can best do to deal with them, to treat them, so that our patients do not have to go through that increased morbidity and associated potential mortality that comes with these diseases. When you look at some of the thyroid emergencies, yes, you would think in terms of undiagnosed hyperthyroidism, patients coming to you with apathetic thyrotoxicosis, which again is very difficult to diagnose, because when patients come to you with apathetic thyrotoxicosis, these patients are basically going to come to you with very few symptoms. It is seen more in the elderly patients. It is seen more in patients who are on other medications, who have other comorbidities, and patients will not classically come to you with any of the symptoms that you see in your patients of thyrotoxicosis. Patients, for example, may just come to you with uncontrolled atrial fibrillation. And this uncontrolled atrial fibrillation may precipitate a significant episode of cardiac failure. And that's when you look at this patient and you investigate, you realize, and along with this, the patient would have some of the other signs of uncontrolled hyperthyroidism. And that's when you would realize that this patient most probably has actually apathetic thyrotoxicosis. As I said, myxedema coma is uncommon, not very, very common at this point of time. But yes, we would talk in terms of that. Thyroid storm is another area which we need to be aware about. And of course, airway compression or superior vena cava syndrome from a goiter or tumor. These are some of the potential emergencies that you could possibly be seeing in clinical practice. And I'm going to talk about a very, very common case scenario. You have this 29-year-old pregnant female patient who you are seeing for the first time, who's admitted to the hospital with altered level of consciousness. She has a GCS score of 9/15 when she's evaluated in the hospital, a BP of 100/54. Mind you, a pulse which is very, very low, a pulse which is only 32 per minute, a temperature is 35, and a respiratory rate which is on the lower side. On examination, this patient has a dry, cool skin, coarse hair. I mean, a classical, when you look at some of these patients, you can almost make out from a mile, this patient could be hypothyroid. Periorbital edema, prolongation of the recovery phase of the knee and ankle jerks, muffled heart sounds, a lot of edema, no focal neurological deficit, no real trauma. Patient does not give you any history of any sepsis, no history of any kind of precipitating illness which has happened over the last month, no anaphylaxis, no poisoning. But the patient's relatives do tell you that she's been gaining weight which was out of proportion to the pregnancy over the last 2 months. She was becoming very lethargic, very slowing down. We just put it down to pregnancy. There's loss of appetite, a lot of lethargy and body pain, which again often is put down simply to being one of the changes of pregnancy. ECG, mind you, was very alarming, a heart rate of only 30 per minute with T-wave inversion. The rest of the labs, other than some amount of hyponatremia and hypokalemia, were quite okay. But what was alarming were the thyroid function tests. TSH of more than 100, a T4 which was undetectable. When we went back and asked the history to this patient, and not to the patient actually at that point of time, when we took into confidence the patient's mother told us that she was hypothyroid. She had stopped her medication since 6 months because she was married 6 months back, and she was fearful about taking thyroid medication. She didn't continue it during pregnancy also, assuming that thyroid medication, or as we all have this mindset that no medication is allowed during pregnancy. And this is where she finally was. So I think a lot of awareness needs to be also created in our patients' minds that no, thyroid medication has to be continued during pregnancy. A lot of my patients, even today, in spite of all the education, in spite of all the reach out programs that you and me have, still have this concept that, madam, is it safe to take thyroid medication during pregnancy? Am I allowed? I've been told no medication during pregnancy. Will this harm my baby? Will this cause problems for me? Will my baby be fine if I continue taking medication? And they need to be reassured. They need to be told again that this medicine is mandatory for you and your baby. On the contrary, I'm going to be increasing your doses when you come back to me with a pregnancy or when you are pregnant. What we do in clinical practices in patients who are hypothyroid and in the reproductive age group, irrespective of when they come to us, at this point of time, even in our unmarried patients, we do casually mention, you have to continue this medication even when you get married and even when you get pregnant. We just increase the dose during pregnancy also. So somewhere we all the time reiterate to our patients that you will have to continue thyroid medicine, not only lifelong, even during these very, very important phases of your life when you are pregnant, very, very important phases of your life. It is very important that you maintain your thyroid levels within the target range that is set for pregnancy, as well as within the target range that is set before and after pregnancies. If we keep on repeating this message, hopefully we will be able to avoid situations like this. And as I said, though it occurs in less 0.1% or less cases and very rare under the age of 50, it is something which we need to keep in mind. Some of the causes, most of these patients will come to you with primary hypothyroidism, but sometimes, rarely, you can also have secondary hypothyroidism. What would differentiate primary from secondary hypothyroidism would be your TSH would be normal or marginally high in your patient with secondary hypothyroidism with very low T3, T4. Your other pituitary hormones, for example, your cortisol would give you ancillary evidence as to whether you are dealing with central hypothyroidism, secondary hypothyroidism, or with primary hypothyroidism. One thing which I would like to put across over here is when you are having a patient of suspected secondary hypothyroidism, it is very important that you first correct the cortisol axis. You cannot correct this patient's hypothyroidism before you correct the patient's cortisol axis, because potentially you would be worsening the situation. So you need to correct the hypocortisolism, give this patient hydrocortisone, and subsequently also correct the patient's hypothyroidism. And we often do this in clinical practice even before we get reports. If you're suspecting secondary hypothyroidism, we take a random sample for cortisol, give hydrocortisone to our patients, and then correct them for hypothyroidism. And of course, tertiary hypothyroidism, which is less than 1%. And we all know this can be associated with multiple endocrine failure syndromes also. So if some of the cardinal signs which you would look into if you see your patient who's coming to you with hypothyroidism, with hypotension, bradycardia, pericardial effusions, low voltage ECG, prolonged QT intervals, or inverted or flattened T waves, as we are seeing over here. Very, very categorical improvement in the ECG. An ECG with heart rate of 50 beats per minute does improve once the patient becomes euthyroid. Also, you would realize that some of the precipitants of myxedema coma could be anything which you routinely do not take too much of cognizance about. For example, it could be cold exposure, it could be an infection, it could be trauma, it could be CNS depressant agents which are used, it could be just a cerebrovascular accident or congestive heart failure. And the typical presentation will be all that your patient came to you with, be it hypothermia, hypotension or bradycardia, hypoventilation or respiratory failure, ileus or depressed mental status, or coma. And that's the reason we are saying that you should keep a very, very careful watch on your patients to understand better where your patients are as far as myxedema coma goes. If you look at some of the contributing factors to the coma, other than the hypothyroidism, it could be hypercapnia, it could be hypoxia, it could be hypothermia, it could be hypotension, hypoglycemia, hyponatremia, some drugs, plus or minus sepsis. So all these are going to contribute to the myxedema coma, and all these could be present plus or minus in your patients, in the sense that some patients may come to you with greater degree of hypothermia, some patients may come to you with a greater degree of hyponatremia. If a patient comes to you with altered state of consciousness and hyponatremia at basic investigations, it is mandatory that you check this patient's thyroid status and the patient's cortisol status before you do anything else for the patient, other than, of course, taking corrective measures in place. So when you're looking at labs, you would, of course, ask for all the routine labs, but you would also ask in addition for that your cortisol and your T3, T4, TSH. As I said, you would correct this patient's cortisol status. You would give hydrocortisone 100 to 250 milligram IV. Again, individual clinical decisions. We in practice use 100 milligram 8 hourly in our patients. Cautious slow rewarming is done in the ICU setup. Our problem, though, all the textbook will say that you need to give IV thyroxine. IV thyroxine is not available in our country at this point of time. So what we practically do is insert an RT and use thyroxine through the RT. T3, if available, we do use in our patients, but again, availability of T3 can be a significant challenge. So most of us work with using T4 in our patients, of course, along with IV fluid rehydration. Of course, search for and treat the precipitant cause. And most other medications we need to understand, because drug metabolism is impaired and decreased, you need to use lower doses and, of course, very, very close follow-up of your patient. This is again a silhouette of a patient of hypothyroidism whose pericardial effusion practically reversed once thyroid therapy was started for the patient. Now, what about the other end of the spectrum? What about thyroid hormone excess? We all know thyrotoxicosis is a term which is used for increased levels of circulating thyroid hormones, whatever the source may be. It could be your struma ovary, it could be your exogenous thyroid hormone, it could be anything which is finally leading to increased levels of circulating thyroid hormones. Hyperthyroidism is a disorder in which the thyroid gland itself secretes too much hormone. And in clinical practice, one of the easiest clinical marker to really help you as to whether you're dealing with hyperthyroidism or some other form of thyrotoxicosis, because thyrotoxicosis, for example, can also be caused by thyroiditis. And in the present situation, in the present COVID era, it is very, very important at times, especially with our patients coming to us with thyroiditis. We need to be able to differentiate whether you're dealing with hyperthyroidism or thyroiditis. And to make this differentiation, your radioactive iodine uptake test is what helps you make this distinction. Helps you distinguish between hyperthyroidism and other forms of thyrotoxicosis. So a thyroid storm, very honestly, friends, is, yes, a medical emergency. Again, it's life-threatening, decompensated dysfunction of the body's metabolism, as I said, rare. And most importantly, these disorders, again, there's no clear-cut clinical feature, which I would say, okay, now it's a storm and now it is just simple thyrotoxicosis. So a lot of clinical judgment goes into deciding where you are going to be calling this continuum as being a thyroid storm. This is mostly the addition of adrenergic hyperactivity induced by non-specific stress in the setting of untreated or undertreated hyperthyroidism. Most cases are because of Graves' disease, which would be very self-evident in your patient. Your patient would have a goiter, would most probably have some eye signs, maybe some cutaneous signs, or it could also be because of a toxic MNG. As I said, some of the rare causes are acute thyroiditis and, of course, factitious. Mortality, old references do quote 100%, but at this point of time, with much better care, though I do not have absolute numbers, but the data says it should be less than 5%. Two important features which define a thyroid storm is high fever, very important, and an abnormal mental status. Patient would be agitated, confused, maybe in psychosis, maybe in coma. There could be tachycardia. Patient could have a significant tachycardia. Patient could be having a lot of GI symptoms, vomiting, diarrhea, come to you with dehydration. 20% of your patients come to you with jaundice and all those associated signs of Graves. These are some of the precipitating factors which we see, of which infection is the most common. You generally see in patients coming to you with infection. Some patients have come to us with decay. And you realize that these patients are actually in a thyrotoxic storm. Some of these patients, when they've received radioactive iodine, we've seen a patient receive radioactive iodine and come to us in a thyrotoxic storm because of the sudden release of thyroid hormones which took place. So we have a number of factors, as I said, which do precipitate a thyroid storm, which again we need to keep cognizance about. And we need to differentiate this from all these other medical issues which can come to us, present to us very, very similarly. But as I said, with the present era of lab diagnostics, it's much easier for us to pick up a patient with thyroid storm, and it's much quicker when we are picking up our patients. We do not see some of the typical signs that we were seeing in our patients with thyroid storm, be it your white pulse pressure, be it marked tachycardia, be it your loud S1 and S2 valve sounds, and of course, some would have a high output CHF. As I said, some patients could come to you with unusual presentations, be it status epilepticus, be it a non-embolic cerebral infarct, be it abdominal pain and fever. And we have seen one patient also come to us with rhabdomyolysis. Routine labs, other than in addition to which you would definitely do your FT3, FT4, TSH. And as I said, sometimes you would not be able to distinguish on the basis of lab reports. So don't go by lab reports, go by the clinical picture. Look at the clinical picture and decide what's happening to your patient. When you look at therapy, rapid cooling definitely with all these various measures that you have. If dehydration, you would definitely treat with IV fluids, but you may have to actually treat with inotropes rather than too much of fluids. You would use your beta blockers, propranolol and labetalol. You may or may not use diltiazem plus or minus digoxin depending upon how you plan to control the ventricular rate in patients with AFib. Most importantly, as an endocrinologist, is we use hydrocortisone, and hydrocortisone reduces the peripheral conversion of T4 to T3. And in a patient with thyroid storm, it is PTU, which is the drug of choice, which we use in a dose of almost 600 to 1200 milligram oral by the nasogastric tube. Sodium iodide, 1 gram IV, 1 hour after the PTU, and of course, find the precipitating cause. In patients where there is an issue of liver function tests, where you cannot use your routine antithyroid medication, which are relatively contraindicated, we do give lithium carbonate 600 milligram orally, followed by a dose of 300 milligram thrice a day. We all know the reason we use PTU instead of methimazole during our patients with thyroid storm is because the advantage of PTU is that it inhibits the conversion of T4 to T3. If we plan to give iodine, it would be given only after you've blocked from PTU, because otherwise you may provide more substrate and you would actually increase the thyroid hormone levels. So when you're using iodine for inhibiting the secretion of T4 and T3, we need to be very, very careful. And as I said, lithium can be used in patients allergic to iodine. Follow up on doses of meds for thyroid storm. As I said, you would continue PTU, monitor for later agranulocytosis or liver dysfunction. Please keep this in mind when you're using PTU. Most of us, once the patient is being well treated as far as the thyroid storm is concerned, shift our patients to methimazole. And of course, you would use 50 to 100 milligram of hydrocortisone in these patients till they are stable. We have used plasma exchange or plasmapheresis in our patients when they've not responded to initial treatment. You can think in terms of PD or charcoal hemoperfusion, and of course, emergency surgery for partial or total thyroidectomy. I know I've overshot time a little, so the last slide of the day, when you're looking at a patient with thyroid disease who comes to you with sudden airway distress, there can be two situations. This could be a patient who's not been operated, and there could be a situation where this patient has already undergone surgery. And most commonly, the post-operative issues we see while the patient is in hospital, which could be related to the surgery, which could be the wound hematoma, which could be laryngeal edema, bilateral vocal cord paralysis, or tracheomalacia. Pre-operative, you see these issues because of tracheal deviation and compression, intrathyroid bleeding, tracheal invasion, as we know by anaplastic malignancies, bleeding into the trachea, and of course respiratory failure from pulmonary mets or thyroid cancer. This would be the last slide of the day. Sorry for overshooting time. And the only thing which I want to put across is keep a high index of suspicion. Remember, yes, we are in an era where we are seeing less and less thyroid emergencies, but all the same, we do not want to miss that rare occasional patient who comes to us with a thyroid emergency simply because we did not keep it in mind. Thank
you. Thank you, madam, for your more informative and more elaborative talk on emergency in thyroid. Day-to-day practice, many times you'll see the patient with hypothyroid unnoticed. They'll have a recurrent pregnancy loss and other problems. Nowadays, it has become mandatory, but very difficult to convince the patient that you have to continue the tablet during early pregnancy. So nowadays, it has become a compulsory for all the patients who are coming for a ANC in early pregnancy. You'll get it on the TSH level at least to know the hypothyroid state and avoid the complications. We want to give a healthy baby. Thank you for your more elaborative and more information, madam. Thank you.
Thank you, Shaila madam, for informative session. And thank you, Shalja madam, for chairing the session. For our next session, which is on pancreatitis in pregnancy by Dr. Abhay Dalvi, sir. Can I have the CV slide of sir, please? And we'd like to invite Dr. Aruna Suman madam for chairing the session.
Okay.
Madam is Associate Professor in OBGY Department, MG, MH at Petla Burj, Osmania Medical College, Hyderabad. She is Vice President OGSH and presently working as Joint Secretary of FOXI of 2021 and 22. Over to you, madam.
Thank you. Thank you, Dr. Jignasa. Can I have sir slide, CV slide, please? Rahul, yeah. It's my honor to introduce Dr. Abhay Dalvi, Consultant Global Hospital, Mumbai. His areas of interest is advanced minimal invasive and endocrine surgery, former professor and lead lab surgery, Seth GS Medical College, Mumbai, honorary fellow, College of Surgeons of Sri Lanka 2021, President Association of Surgeons of India 21, President Indian Association of Gastrointestinal Endosurgeons 2015, President Maharashtra State Chapter 2013. I welcome you, sir. Please take over. He's going to talk on pancreatitis in pregnancy, acute pancreatitis. Welcome, sir.
Good morning. First of all, thank you, Foxy, for inviting me to deliver this lecture, Pancreatitis in Pregnancy. Through my 41 years of career, I have seen only 2 patients with acute pancreatitis requiring real good treatment. Luckily for me, I could save both the mother and the child or the fetus through the treatment. Just a minute, there is some. I have no disclosures at all. First and foremost, let us go back into our undergraduate and postgraduate days. We learned anatomy, we learned physiology. It was all about developing circuits. Then came post-graduation. We started coordinating with our specialty and developed goal-oriented neural paths. All of you all developed gynecology and obstetrics as your path. I developed surgery as the path. And in the process, I have forgotten obstetrician and gynecology, where you must have forgotten surgery. We selectively forget anatomy, physiology, pathology, pathologic anatomy, pathologic physiology, and remain with your specialty. And it is so true to me. So just to go back and revise, and I'm going to keep this very simple. Pancreas is an organ which is deep into the retroperitoneum in the upper abdomen. It is surrounded by important organs. Acute inflammation can affect all these surrounding organs and give rise to symptoms. Chronic pancreatitis has systemic problems. Acute inflammation adds to morbidity and mortality, while chronic inflammation can be managed medically very easily. So what are the types of pancreatitis? Acute pancreatitis could be mild, that is interstitial. It could be acute, and it could be severe acute. It could be lethal in severe form, both to mother and fetus. The incidence of mortality is very high, about 30 to 60% as reported from literature from China, whereas it is down to about 3 to 4%, the data from UK and the US. Chronic pancreatitis is more of chronic problems that need attention in pregnancy. Exocrine insufficiency leads to steatorrhea, and endocrine insufficiency leads to diabetic mellitus. While each discipline on the treatment team has a role to play, it is true that teamwork, collaboration of cohesiveness results in better outcome. And who are the players? Obstetrician, gastroenterologist, endocrinologist, and surgeon comes last in the treatment of acute, especially acute pancreatitis, and as well chronic pancreatitis. I will dwell on chronic pancreatitis first because it is easily manageable. It is nothing but progressive inflammation and necrosis of pancreas leading to destruction and exocrine and endocrine problems. Such a pregnant patient will come with pain, cramping, bloating, weight loss, and steatorrhea. Frothy stools, as the complaint would be. The best way to know this patient has chronic pancreatitis, apart from investigations, is to do what is known as fecal fat estimation. And if that is more, you know that this patient, though may not be diagnosed by sonography or CT scan, is suffering from chronic pancreatitis and will require some supplements. What are the supplements that are done? Usually it is pancreatic enzymes that are given and treatment of diabetes. Depending on symptomatology, the dose adjustment is required. Vitamins and essential trace element replacements are also advisable in pregnancy for benefit of not only the mother, but also the fetus. Gastroenterologists and endocrinologists play a very important part in treatment of chronic pancreatitis in pregnancy. Acute pancreatitis is a more sinister problem. It involves a sinister response from surrounding organs and also a systemic response. What are the organs that respond? It's the stomach, which lies anterior to the pancreas, leads to pain and vomiting, which can be mistaken, especially in the second and third trimester also, knowing very well that it is hyperemesis gravidarum is most common in first trimester. It can so happen and misdiagnosed in second and third trimester. One can have altered liver enzymes and jaundice. Coagulopathy is also known. Superior mesenteric vein or portal vein thrombosis is the cause for this. And unexplained distension and constipation because of transverse colon getting affected. So all these factors should be put in mind that obstetrician should think that this patient may have acute pancreatitis. And all the responses are dependent on severity of pancreatitis that occurs. What are the common causes? Gallstones, more than 50%. In fact, in our literature, it is more than 70%. And this is related to progesterone release, weak contraction of the gallbladder, leading to calculi formation. And that is the cause for increased incidence in multigravida as well. This is very common in second and third trimester where progesterone release is at the peak. The other causes which are mentioned in literature are alcohol, hypertriglycemia, and other rare causes. And that is where importance of multidisciplinary approach comes into picture. What does acute pancreatitis do? As I said, it affects surrounding organs and masks other symptoms, and systemic infection, affection that occurs and goes into what is known as a SIRS. Clinical scenario of system failure comes into picture. Remember, severity of acute illness is never estimated on day one. Day one is the one where if you diagnose correctly, then only you can treat these patients. The more the time goes, the more the severity increases and the patient as well as the fetus lands into a problem. What we don't know and what we don't see as an obstetrician: extreme pain in epigastrium radiating to back, I'm saying it again and again, is a symptom of pancreatitis. Most of the times I've seen people treating these patients as gastritis or something of that sort, but not diagnosing pancreatitis. Acute pancreatitis to me should be kept if the patient says there is epigastric pain and there is a back pain. The second important thing is the patient is sick. Apyrexial flushing of the face in the initial period is the key to diagnosis of acute pancreatitis. Most of the patients of established pancreatitis will have fever, but initial phases, there is flushing of the face that one should diagnose. Pain disproportionate to signs. The patient will have a very soft abdomen tending again to you to say that this is nothing but gastritis related to pregnancy. Then come on examination, tenderness, guarding, rigidity. If at all it is there, it is more sinister. The pancreatitis is going to be more severe. WBC counts are unreliable because in pregnancy itself, especially in second and third trimester, you may have a raised WBC count. Investigations on day one, USG, CT, etc. are not helpful because they do not tell you the severity of pancreatitis, because necrosis sets in only on second, third, fourth day. And it is good that you investigate these patients properly with a CT scan on the 5th or after the 5th day. Again, moral of the story, suspicion is the key to curtail morbidity and mortality. What do you do? First, you suspect that this could be acute pancreatitis. Second, send serum amylase and lipase, which will be raised. Third, CRP may be helpful apart from routine CBC, etc., which tells you that there is some inflammatory thing going on in the body. Investigate these patients with USG, CT, MR following the rules of the game and reach the cause that this is nothing but acute pancreatitis. Use multidisciplinary approach. Moment you suspect and get a report of raised amylase or lipase, please involve gastroenterologist, surgeon, and maybe intensive care person to save both mother as the child. What are the interventions permitted in pregnancy? Ultrasonography is a very poor predictor because in severe acute pancreatitis, you have paralytic ileus and colon, especially the transverse colon, comes in the way of actually delineating the pancreas. CT or MRI, as I said, wait possibly for 5 days and take advice of a specialist when to go ahead with this investigation. Both of these, CT or MRI, especially MRI without contrast, is advisable, gives true picture of severity, telling you what is necrosis, how much is the necrosis, and what is the treatment that should be given. avoid maternal and fetal complications. And remember, CT scan in pregnancy is not contraindicated. The dose, radiation dose that the CT gives is much, much less than what can harm the fetus. Now, what I've just put these pictures to just show you what happens. The first picture on the left side is absolutely normal pancreas. But as it starts getting inflamed, you will see the surrounding areas which are fluffy. That is known as stranding that occurs. Then comes necrosis and collections around the pancreas. And this is the one which has air specks, which indicates that there may be infection which is setting in, and one should be worried because this is the one which is going to increase morbidity as well as mortality for both mother and the fetus. Mother should get priority over the fetus. That is the rule of the game. Most of the acute pancreatitis would resolve in 48 to 72 hours if it is a mild attack. Then you have necrosis without symptoms, indicated by procalcitonin levels are indicative that this is a patient who is likely to develop infection. As I said earlier, raised WBC as well as CRP are only indicators, but they may be raised in second and third trimester and have no value whatsoever in treating acute pancreatitis. Necrosis with air specks without symptoms is a debate by itself in a non-pregnant group. So leave it to the gastroenterologist or the surgeon to manage how to go about managing this patient. But if the patient has necrosis with symptoms like fever and organ failures, etc., you've got to be aggressive for saving mother as well as the fetus. As I have already said, mother always gets priority over the fetus. What are the problems exaggerated in pregnancy? There is excessive fluid loss that occurs because of acute pancreatitis, and urine output greater than 0.5 ml per kg per hour should be maintained with IV fluids. You may land up giving a lot of fluids to this patient in non-pregnant as well as pregnant group. Keep the patient pain-free. Analgesia can be given depending on what analgesics you prefer and are not contraindicated in pregnancy. VTE prophylaxis. Monitor pre-existing hemorrhagic conditions. Now, if at all your patient has coexisting hemorrhagic conditions like preeclampsia or something like that, then it can be withheld, but otherwise VTE prophylaxis is advisable. Monitor calcium levels in this patient. And in case the patient requires magnesium, it is not contraindicated. You can give it in this. It is not going to affect calcium levels of acute pancreatitis. And again, I am going back on the record, involve others. Gastroenterologists will not know what is happening in pregnancy. So inform him about your role of pregnancy related matters, and he will inform you how to go about this. Surgeon comes into picture only when intervention is required. Role of obstetrician, suspect and diagnose, involve others, whether to deliver. Gestational age and severity of pancreatitis are the ones which will decide. Multidisciplinary approach. No response of to treatment within 48 to 72 hours of treatment is the indication to delivery. And vaginal delivery is not a contraindication. You can safely go ahead even in acute severe pancreatitis. What is the role of others? Radiologists, MRI without contrast allowed. CT scan is permissible. Cholecystectomy can be done during pregnancy. As soon as the attack subsides, the patient can be subjected even to laparoscopic cholecystectomy. The recent reports from the United States of America says that it can be also done in first trimester, leave alone second and third trimester. Endoscopic retrograde cholangiopancreatography, which may be required for CVD stone causing acute pancreatitis, can be done with precautions. Radiation exposure should be managed by the endoscopist who is treating the same. What are the controversies? Steroids have been suggested in one of the 2021 literature in the obstetrician and gynecologist journal. It is suggested that it would support lungs during acute pancreatitis of the fetus. But let me go on record that it's completely contraindicated in infected or necrotic pancreatitis or patient with systemic response syndrome, which can be lethal for the mother. So I congratulate the Orchestra of Endocrines. Thank you very much. The reference that I have given downstairs is the journal that I've relied upon. I thank Dr. Shanta Kumari, the president of FOXI, Rakhi Singh, the convener, Jigyasa, who has been corresponding with me all the time, sometimes really threatening me, and also others who have joined this. Thank you so much. God bless.
Thank you, sir, for being there, taking out your precious time for us. Dr.
Thank you,
Arun.
sir, for the excellent talk. Covering from basics to advances, you have given a clear picture of pancreatitis in pregnancy. We had 3 cases, and with multidisciplinary approach, we were able to manage without mortality and morbidity. Thank you so much.
Thank you.
Thank you, sir. And sorry for the inconvenience which I caused you. And
No, not at all. It was a pleasure, Jigyasa. It was a pleasure.
thank you for being so clear and crisp. Thank you, Aruna madam, for chairing the session. And thank you, Rakhi madam, for giving me the opportunity. Now for the next session, I'd like to invite our next member of committee, Dr. Meenu Handa madam. Madam is active member of Endocrine Society working as North Zone Coordinator. She is Senior Consultant and Clinical Head of Fortis Bloom IVF Gurgaon, Joint Secretary Haryana, ISAR and IS, and had received many awards in her credit. Over to you, madam.
Thank you, Dr. Rakhi Singh and Dr. Jigyasa for these kind words. And now as we move on from one brainstorming session to another, we are going to go ahead with our first talk by our chief guest, Dr. Raymond Lee. And sir's topic is on aging and hormones, are we oncologically safe? And for the first talk, I would like to invite our chairperson for today, Professor Krishnendu Gupta, sir. Could I have Sir's CV, please? Sir is our FOXI representative to AOFOG 2020-2022. He's a chair of Sexual Reproductive Health Committee, AOFOG, from 2019 to 2022, and also the co-chair of Women's Social and Sexual Rights Committee, SAFOG, 2021 to 2023. Sir's also been our Vice President, FOXI, 2011.
Thank you, Meenu. I think we will move forward.
Over to you, sir.
Short of time. I think, thank you very much for this opportunity, Rakhi, and of course to our dear President FOXI, Dr. Shanta, and the entire team, Dr. Madhuri Patel, and the entire FOXI organizing committee, and of course the coordinators along with Dr. Bashub Mukherjee, Ameya, and my dear friends. So it's really a great honor for me to have a speaker, none other than Dr. Raymond Lee, who's a very dear friend, and we work together in AOFOG as well. And as you are aware, Dr. Raymond Lee is a specialist in obstetrics and gynecology and subspecialist in reproductive medicine. He's a clinical associate professor, Department of Obstetrics and Gynecology at the University of Hong Kong, and honorary consultant at the Queen Mary Hospital and Kwong Wah Hospital, Hong Kong. And he's an honorary medical consultant in the Family Planning Association of Hong Kong as well. And in addition to all this, he also is a chair of the Reproductive Endocrinology and Infertility Committee of AOFOG. And that's how we became great friends. And of course, we have a common friend in Dr. Jaideep Tank as well. And I think it's lovely to have you here. And his clinical research interests are reproductive endocrinology, subfertility, and family planning. So when Rakhi was looking for someone to speak on hormones, I said, wait a minute, give me an opportunity, and I'm going to contact Dr. Raymond Lee. And I'm so happy that Raymond agreed. Thank you, Raymond. And the floor is yours. Please go ahead with your presentation.
Thanks very much, Mr. Gupta, for the kind invitation to join this very wonderful conference. The topic that I'm given today is aging and hormones. Are we oncologically safe? So without further ado, I will start the talk, ladies and gentlemen. Now, hormone replacement therapy, HRT, or many people would like to call it menopausal hormone therapy, MHT nowadays, is an effective treatment for problems related to estrogen deficiency, related to the perimenopausal and the postmenopausal period in women. There have been much controversies over the use of HRT, particularly since the publication of the Women's Health Initiative, the WHI studies, first published around two decades ago. In the subsequent years, much has been learned from new evidence, which came up to some extent, has helped clarify some of the concerns, particularly on the risks associated with HRT. So in the next 20 minutes or so, I'm going to go through some of the new thoughts and the consensus about the cancer risks associated with HRT. All of us would know that the main indications for HRT nowadays would be, first, to treat significant climateric symptoms. Second, to treat women presented with a premature ovarian insufficiency before the age of 40 or hypogonadotrophic hypogonadism due to other causes. For HRT, the main constituent would be estrogen, which is logically would treat the estrogen-related the symptoms or problems related to estrogen deficiency. However, estrogen alone preparations can only be given to hysterectomized women. For women who have an intact uterus, we have to give progestogen to protect the endometrium. So for progestogen, it can be given sequentially, that means cyclically, for around 12 to 14 days of the cycle. And by such doing, the woman will have a scheduled bleeding every month. Or alternatively, the progestogen can be given continuously. This will give rise to non-bleeding cycle because of the endometrial atrophy. Then the woman will not have any bleeding at all. For the estrogen component, majority of the hormone replacement therapy regimens makes use of the natural estrogen. For example, conjugated equine estrogen derived from horse urine, that is the plamlin, or nowadays actually more people would like to use the bioidentical estrogen called 17-beta estradiol. Okay, so this is the natural, the native human estrogen that is secreted from the ovary usually. And as I'm going to elaborate in the subsequent talk, right, seems to be associated with the least risks. For the progestogen component, progesterone, of course, we know this is the natural progestogen existing in human, but the progesterone molecule itself cannot be taken orally because of the low bioavailability. So to increase the bioavailability, we have to micronize it when this is used pharmacologically. Or actually, there is another synthetic progestogen called ditrogesterone, which is the most bioidentical progestogen that we can use in HRT preparations. Of course, there can also be other kinds of synthetic progestogen that can also be used in the hormone replacement therapy regimens. The topic that I'm given today is mainly on the risks of HRT. So these are the most well-established risks of HRT, including carcinoma of the breast, venous thromboembolism, stroke, and gallbladder disease. And out of these, breast cancer is one of the most commonly investigated or the most concerned sort of risks associated with HRT. The risk of HRT actually was being aroused, the concerns about the risk of HRT was being aroused when the first report on WHI was published in 2002. And in this trial, in the combined estrogen and progestogen arm, we noticed that there was a significantly increase in risk of breast cancer. But on the other hand, there was a reduced risk of colorectal cancer, and there was no significant effect on the risk of endometrial cancer if the combined regimen is given. On the other hand, if you're talking about the estrogen only arm of the WHI trial, actually the risk of breast cancer was not increased. And same applied to colorectal cancer as well. So first of all, I'm going to talk about breast cancer risks. Since the first publication of the WHI trial, it has been around 20 years, almost 20 years now. And this is a recent report reporting the long-term follow-up data on this WHO cohort. And actually, this paper was just recently published last year, which reported the breast cancer risk. Okay, and just look at the orange lines, which refers to the combined arm. Okay. The dotted line refers to the placebo group, whereas the solid orange line refers to the treatment group. And we see that the treatment group, well, obviously would have an increase in risk compared to the placebo group in the combined treatment arm. Okay. If you look at the estrogen alone arm, that is the blue lines, okay, this solid line refers to the treatment arm, whereas the dotted line refers to the placebo arm. And what we can observe very obviously is a reduced risk of breast cancer in the treatment arm compared to the placebo arm. So the effect basically is opposite, right? Whether we're adding progesterone or not adding progesterone. So actually, we now understand that progesterone probably is the more important component leading to the risk of breast cancer associated with the HRT. This is another important trial, the French E3N cohort study, which involved more than 80,000 subjects. It was published more than 10 years ago. And from this trial, we also see the same trend that, well, if we talk about the estrogen alone arm, actually, although the relative risk was still more than 1, the 95% confidence interval crossed 1. So there was no significant increase in the risk statistically. If you look at the combined arm, right, estrogen plus progesterone, it all depends on what kind of progesterone that you're talking about. Say if you're adding dydrogesterone to estrogen, then basically the risk is not increased either. But for most of the other synthetic progesterone, actually there was a significantly increase in the relative risk of breast cancer. For the transdermal preparations, well, actually there was no change in the findings. So we understand that for whether we give the oral or transdermal preparation probably, it doesn't really matter in terms of the breast risk. When talking about the breast cancer risk, you should not forget about this paper published in Lancet just 2 years ago. This was a very famous paper. Every people knows about this came. So this was a meta-analysis on the worldwide epidemiological evidence. And indeed, this shows that for the estrogen only arm, probably the risk seems to be lower compared with the combined estrogen and progesterone arm. And we can also see the trend that the risk of breast cancer increases with the duration of use and is also higher in current users compared with the past users. And for this chart, again, it shows that for the estrogen alone arm, probably the risk is smaller compared to the combined preparations. And actually, for vaginal estrogen, well, this is a separate issue, right? If you use a vaginal estrogen, basically the risk is minimal and insignificant. Okay, and for tipolone, which is a synthetic compound with both estrogen and progesterone property, but this compound also produces a significant increase in risk of breast cancer. However, there are also some drawbacks in this Lancet paper. If you look at the studies being included, neither the WHO RCT nor the large E3N observational cohort study were included in this meta-analysis. And according to the most of the recent WHO data, the estrogen-only HRT arm produces a significant decrease in the risk of diagnosis of breast cancer, and there was a significant reduction in breast cancer mortality compared with placebo. And for the combined arm, although there was an increase in risk of breast cancer compared to placebo, there was no significant difference in breast cancer mortality as well. Okay, and for the easterly end observational study, it actually suggested a lower breast cancer risk in users of micronized progesterone and dydrogesterone compared to users of the more androgenic synthetic progestrogens. Okay. So the findings from the meta-analysis published in the Lancet are actually in keeping with the current knowledge of the increase in risk of breast cancer and HRT. So actually it tells us nothing new, right? And we understand that the risk increases with the duration of use, particularly if the HRT is used for more than 5 years. However, the absolute risk attributable for to the combined HRT is small. It's less than 1 additional case per 1,000 women year, and it decreases progressively after cessation of the treatment. And the risk primarily is associated with the addition of progesterone to estrogen therapy. So this is the conclusion that we seem to be able to draw from most of the studies. There's also a recent paper published in BMJ just last year, which reported 2 nested case control studies in the UK general practices, contributing to 2 databases, the Q Research and also the Clinical Practice Research Data Link. This actually included quite a large cohort of women, more than 90,000 women, aged 50 to 79, with a primary diagnosis of breast cancer between 1998 and 2018, and actually more than 450,000 matched female control. So it's a huge study. And again, we see the same trend. For the estrogen only arm, it seems that although the risk of breast cancer is still there, but it seems that the magnitude is much smaller compared with the estrogen and progesterone combined arm. And actually, for the combined arm, we can see that the risk increases with the duration of use. And comparing the recent users and the past users, again, it seems that the recent users seems to have a high risk compared to past users. So the risk is actually being attenuated upon discontinuation of treatment. So this is the overall conclusion from this meta-analysis. And if you talk about number of excess risk, okay, in those recent estrogen-only users is around 3 to 8 per 10,000 women years of exposure. 3 applies to those younger women, whereas the 8 applies to those older women. So the risk also increases with the age of the woman, as what we generally expect for all kinds of cancer. And for the recent combined HRT users, the excessive risk is 9 to 36 per 10,000 women years. Okay, for past users of estrogen-only regimen, the risk is not increased actually. And for the past users of the combined regimen, the risk is small. Okay, it's 2 to 8 per 10,000 women years of exposure. So actually the absolute risk, excessive risk is still small. Another question is regarding the use of HRT in BRCA mutation carriers. According to the recent systematic review published just this year, which only found 1 case control study and 1 retrospective cohort study to address the risk of ovarian cancer, and 1 case control study addressing on endometrial cancer risk. Okay. Based on this very limited amount of data, it shows that the use of HRT does not seem to have a relevant effect on cancer risk in BRCA mutation carriers. Okay. We know that for BRCA mutation carriers in general, we've discussed about risk reducing bilateral cervicovectomy when the woman reaches, say, age of around 40 or so. Okay, and this decision should not be withheld to avoid subsequent HRT in this population. Okay, so even if this group of women undergoes the prophylactic bilateral cervicovectomy for the cancer risk reduction after the surgery, right? This is safe for this group of women to receive HRT, and adequate HRT after risk reducing PSO should be offered to avoid the chronic diseases, for example, bone loss, as well as cardiovascular risk resulting from the low estrogen levels. And the use of HRT in this scenario does not really negate the protective effect of the bilateral circumflexectomy. In this scenario, what formulation would be the safest? Well, we still need further data to look at whether there's any differential effect of the different formulations in this particular circumstance. Next, I'm going to talk about the use of HRT and the risk of other cancers. If you still remember, for the initial WHO study, they also reported a reduction in colorectal cancer risk. And for the colorectal cancer risk, there was a meta-analysis of 15 observational studies reported 2 years ago. And compared with HRT never user, the poor relative risk of colorectal cancer in HRT user, in current HRT user, was not significantly different. And for the ever user, well, it was lower in the users. Okay, with the upper limit of this 95% confidence interval just reached 1. And for the former user, again, there was no significant difference. Okay. In this meta-analysis, it shows that the longer duration of HRT use was associated with a lower colorectal cancer risk, with the poor relative risk of 0.75. Okay. As shown in this picture, it demonstrated the risk in the different subgroups. And for the French E3N cohort study, most of the women would take estradiol and non-MPA progestogen. So this differs from the WHO study. Okay, and nowadays generally we think that these more bioidentical hormones may be safer. So what happened to the colorectal cancer risk? Okay. For the E3N study, it shows that the ever use of HRT, all types and routes, was not associated with the change in risk of colorectal cancer. And ever use of estrogen alone was associated with the reduced risk of colorectal cancer. On the whole, there seems to be a beneficial impact of HRT on colon cancer risk, but data are inconsistent with regard to estrogen alone treatment. Okay. However, HRT should not be used solely for the prevention of colorectal cancer. For lung cancer, data on HRT and lung cancer are inconsistent and do not point at a clear association of HRT in the pathogenesis or outcome of pulmonary malignancies. Neither of the two WHO clinical trials in the estrogen alone arm or the combined arm demonstrated a significant increase in lung cancer incidence among hormone users compared to placebo. What about the gynecological cancers? Now, for endometrial cancer, all of us know that unopposed estrogen is associated with an increase in risk of endometrial hyperplasia and cancer. This is a well-known fact. So, in women who got an intact uterus, we have to add progestogen either continuously in a combined regimen or in a cyclical manner. And this has been shown to reduce the risk of endometrial hyperplasia or the cancer associated with the estrogen therapy. The adequate doses of microdosed progesterone appears to be 200 milligrams per day for 10 to 14 days in sequential therapy, or 100 milligrams per day for continuous combined therapy, where the estradiol dose is 2 milligrams orally or 50 micrograms transdermally or less. If the higher estrogen dose is used, then we have to use a higher dose of progesterone for endometrial protection. Okay. For ovarian cancer, there was a meta-analysis of 52 studies published a few years ago in Lancet. It shows that there was an increase in risk of ovarian cancer by some 1.2 to 1.4 fold. However, if you read the recommendation from the International Menopause Society published the year after, they said that the validity of the evidence has been challenged because of a few reasons. Firstly, there can be possible confounding factors in those retrospective analysis. And there was an unknown number of ovarectomized women who actually would not be at risk at all. Okay. And there was actually discordant findings among the 52 studies. So overall, the conclusion from the International Menopause Society Guideline Group. They recommended that based on the evidence to date, the association between HRT use and ovarian cancer is still unclear. For cervical cancer, in the double-trial RCTs, the HER studies, and some long-term cohort studies, there was no increase in risk of cervical cancer with the use of HRT. And according to our common understanding, cervical cancer is not a hormone-dependent cancer anyway. So all these are talking about the incidence of cancer. So what about the mortality? Okay, according to the most recent WHO report on the mortality figures, among postmenopausal women, hormone therapy with the CEE plus the MPA regime, that is WHO regime, for a median of 5.6 years, or with the CEE alone of a median of 7.2 years, was not associated with the risk of all-cause mortality, cardiovascular mortality, or cancer mortality during a cumulative follow-up of 18 years. And this is demonstrated in this the table very nicely. For overall cancer mortality, there was no increase in risk at all. For breast cancer mortality, for the combined group, there was no significant increase. And for the estrogen alone arm, actually, there was a significant decrease in the breast cancer mortality. Okay. For colorectal cancer, there's no significant change. And for other cancer mortality, again, there was no significant change at all. So, ladies and gentlemen, I would like to summarize my talk in, with the following points. Firstly, HRT is associated with established risk of breast cancer. The risk generally is lower with estrogen alone, but of course, it should not be used for women with an intact uterus. Okay? And for those with an intact uterus, we have add progestogen, and the use of bioidentical progestogen would be associated with lower risk. For bioidentical progestogens, basically it includes either the micronized progesterone or dydrogesterone. Okay, and the lower risk is also the risk is also attenuated after discontinuation of treatment. On the whole, HRT seems to be associated with a reduced risk of colorectal cancer. Unopposed estrogen is associated with a well-established risk of endometrial aplasia or cancer, but the risk can be avoided by adding progestogen with adequate dose and duration. There was no definite evidence of association with risk of lung, ovarian, and cervical cancer. And there was no apparent increase in the cumulative cancer mortality in the long term. So thank you very much for your kind attention.
Thank you very much, Dr. Raymond, for this very, very wonderful presentation. It was educative, and I'm sure that everyone logged in, got the kind of feel of what the current research and what the findings are with respect to, HRT and the risks for cancer. And that's why I think Rakhi has very aptly named it, Are We Oncologically Safe? And I think that you have covered all the aspects very beautifully. And thanks very much once again for joining us all the way from Hong Kong, although online. Thank you very much. We'll move over to the next one.
Thank you, Raymond sir, for being there and for a wonderful talk. And thank you, Krishnendu sir, for helping us out. Thank you.
Thanks a lot.
Thank you, Dr. Raymond Lee sir, and for such an enlightening talk, and Professor Krishnendu Gupta sir for chairing this session. Thank you so much. We now move on to our second talk, and by Dr. Jaideep Tank. Sir's topic is on EDC impact on endocrinology. And for this talk, I would like to invite our chairperson, Dr. Bipin Pandit sir. Sir is the Vice President, FOXI 2021, the past President, Mumbai Obs Gynae Society 2018-19, past Joint Secretary, FOXI 2015. Over to you, sir.
Can't see Bipin, Minu.
Yes, sir. Just.
Dr. Basant, can you do that?
I'll take over. Just show me Jaideep's CV, please. It is a pleasure to introduce none other than Dr. Jaideep Tank. What's written on the slides is a lot, and what you would have already heard. He's was the Secretary General of FOGSI not much long ago. He is the project lead of the FOGSI USAID projects of 2020 to 24 and the past president of the Mumbai Obs-Gyn Society. He holds several posts in, he used to hold a post in FIGO till very recently. He was a chair of the Safe Abortion Committee, and he is the deputy secretary of the AOFOG, awarded FRCOG honoris causa just last year, and also has been holding several responsible positions besides his clinical commitments. Jaideep is a great friend, is a wonderful orator, and is a lovely person once you come to know him much better. So he's going to take us through EDC, how it disrupts the endometrial milieu. It's not a topic which you hear every day, but it's definitely much in the news and something coming up. And who better a person to hear something recent and new and modern than Jaideep. So Jaideep Tank, we want to hear from you on the EDC, how it disrupts the endometrial milieu and how it's so involved in endocrinology. Thank you for joining us. Thank you for being here, Jaideep. It's always a pleasure.
Thank you so much, Basab. I hope I'm audible and my slide is seen. My first slide is the flyer.
Yeah, yes. It is seen.
Yes, sir.
So thank you so much, Basab, for that, as always, very warm, kind and generous introduction. It is indeed a pleasure to be a part of this CME, very aptly titled the Orchestra of Hormones, Endocrine Lifeline. And before I begin, I must congratulate Rakhi. Rakhi has been doing such a tremendous job as the chair of the endocrinology committee, and it's, to a certain extent becoming a little difficult to keep up with her activities because there seem to be so many of them. Every time I open my WhatsApp account, there seems to be one new flyer from Rakhi. So congratulations, Rakhi, on all this absolutely brilliant, innovative and wonderful work that you're doing as chair of the endocrinology committee. Let me also acknowledge the president, Dr. Shanta Kumari Madhuri, the secretary general, my very dear friend Basab, who is the vice president of FOGSI, and of course, Dr. Bipin Pandit. Kudos to the organizing team and the coordinators, my dear friend Krishnendu, Ameya, Dr. Varsha, and the chief guest Kamal, and another good friend of mine, Raymond, who heads the endocrinology committee or the reproductive endocrinology committee of AOFOG. In fact, when Rakhi told me to speak on this topic, my first reaction was, Rakhi, please, if you don't mind, excuse me from this topic, because this has always been a fairly contentious topic. And one of the reasons that it's been a contentious topic is that the impact of EDCs on endocrinology or on our body in general is not immediate or obvious. It's an insidious impact which takes place over a period of time. And therefore, when I started reading about this topic, to a certain extent, it was a bit scary, if you ask me, because it seems that almost everything that we do affects our hormones quite adversely. Before I actually begin to speak about the topic, and I can assure you that this will not be a very long presentation, let me request everyone who is here to please support me as I stand for the presidency of FOGSI for this current election year. It is also a pleasure to be speaking in the same session as Raymond and Nandita, and in a session chaired by Krishnendu, Dr. Bipin Pandit and Basab. I oftentimes feel that when we talk about the environment and its impact on so many things, climate, our bodies, hormones, etc., it's a bit like going down a rabbit hole. I'm sure all of us have read the story of Alice's Adventures in Wonderland, more popularly called Alice in Wonderland, written by Lewis Carroll. And we know that when Alice went down the rabbit hole, after she saw a rabbit who said, "I think I'm late," it seemed that the whole world changed. In fact, I like this quotation from the book which says, in another moment, down went Alice after the rabbit, never once considering how in the world she was to get out again. And when we talk about the environment, and as I said, its impact on so many things, it does seem that we have gone down the rabbit hole, never once considering how we are to get out of it again. It is a truism, however, that when you talk about the environment, because of the long period of time that it takes for the problems of the environment to have an effect, you are sometimes left a little struggling to look for evidence. However, as Carl Sagan said, the absence of evidence is not the evidence of absence. And truly speaking, these are some issues where associations and causalities are not always clear. Something may be associated with something in science. However, to find a direct cause and effect relationship is not always easy. And therefore, when you look at these kind of problems scientifically, you must look at them in the perspective of these four factors. You must look at risk, which is the probability that an agent will cause a disease or an adverse effect at a given level of exposure. The problem always remains as to what is that given level of exposure. And I'll refer you to those classic studies where tar was applied repeatedly on the skin of rats in massive doses before it actually produced cancer. Differentiation, which means the process by which a multi-phase cell changes into a different, more specialized cell. Hazard, an agent that can cause disease or an adverse effect. And then, of course, you have the carcinogens, where it has been proven that this agent is capable of causing cancer in living tissue. Having set the background or the context for anything to do with environmental issues and chemicals and its effect on our body, let's move on to define EDCs. They have been defined in various ways. Very simply, you could say that endocrine disrupting chemicals are substances in the environment that interfere with the normal function of the body's endocrine system. And more specifically, they are a man-made compound. And the word man-made is quite important there. Notice that it leaves out woman-made compound that interferes with one or more steps in the signal transduction pathway of natural hormones in the body, responsible for maintenance of any of these things like homeostasis, reproduction, development, and or behavior. We are, of course, concerned with reproduction here, and EDCs are actually supposed to be among the most hazardous toxicants known. They can affect immune function directly via action on immune cell surface receptors or indirectly through other physiological mediators. In fact, because prolonged immune dysfunction and prolonged effect on hormones elevates the risk of several endocrine disorders, EDC-mediated toxicity is a significant human health concern. So how do EDCs act in endocrinology? As we already said, they interfere with the synthesis, storage, release and transport, metabolism, etc. of endogenous hormones. The scary part is that EDCs are actually encountered in everyday life in a myriad number of ways: plastic food containers, water bottles, etc. And there is substantial evidence now that EDCs actually impact human and animal reproductive health. In fact, there is some evidence to show that in the female, EDCs are associated with subfertility, aberrations in the reproductive cycle, etc. And in the male, EDCs have been implicated in male subfertility, cryptorchidism, and hypospadias. The problem has always remained as to how will you characterize EDCs, and at what point will you say that these EDCs, which are literally present everywhere, are now known to be harmful. So this is a very nice paper which talks about the consensus on the key characteristics of EDCs as a basis for hazard identification. And I think it's very important that there be standardized ways of identifying and quantifying the risk which EDCs add to our lives. Otherwise, we would simply be living in fear of the unknown and some things which seem to be omnipotent. So the key characteristics of EDCs and the representative standardized tests that address them are outlined in this table. This paper is available open access. Even if you can't read the entire table, don't worry. You could simply do a Google search for this paper and download it. And some of the key characteristics of EDCs include the fact that they interact or activate hormone receptors, antagonize hormone receptors, alter hormone receptor expression, right down to altering the fate of hormone producing or hormone responsive cells. We therefore now have a fairly good idea of how EDCs actually impact the way the hormonal milieu of the female body and the way it affects reproduction. And these are the ways we can now use this knowledge. We can do all these things and then arrive at the best way to decide how we will avoid EDCs. As Kirsten Fednick said, that we have very tight windows of when our brain and liver are made, and when a hormone disrupting chemical gets in the way, it can change the way these processes happen, and unfortunately the change is often irreversible. I have always had an issue with talking about the environment because it seems that most of what is suggested may not actually be actionable. And therefore, when I was going through the literature, what I did was try and look for some things which we can talk to our patients about and which would be practical and applicable in daily life. So if we want to avoid EDCs, one of the first things we need to do is actually wash your hands frequently. And we should do that by avoiding fragranced and antibacterial soaps, and always wash your hands before eating. In fact, you could say that this has been a welcome side effect of COVID, where we have now, practically been washing our hands almost every 15-20 minutes or half hour. Even though they are linked to hormone disruption and cancer, flame retardant chemicals are actually used in many common household products. And the research shows that these chemicals escape from electronics, couches, and baby products and collect in our household dust. Therefore, when you clean the house, it's a good idea to clean by dusting with a damp cloth or using a vacuum with a HEPA filter in case you have access to it, because these two things will trap the small particles of dust instead of blowing them around the house and just moving them from one place to another. And by doing so, you will also reduce your exposure to other chemicals that can accumulate in your house. You should try and, as far as possible, avoid products which have fragrance in them, because quite clearly the fragrance doesn't add anything to the efficacy of the product. So for example, it's a good idea to choose fragrance-free creams, cleaning products, and laundry detergents. And for freshening your indoor air, it's a good idea to open the windows, use fans, and empty stinky trash cans and litter boxes instead of just trying to cover them up. If you are fond of fragrances, you could think of using natural odor busters like fresh flowers or citrus peels, etc., rather than using a product which has fragrance in it. It is a truism that we are indeed surrounded by plastic. It's literally everywhere. It's wrapping our food, bottling our condition, encasing our phones. And we know that some plastic contains hormone disrupting chemicals. We can't possibly eliminate all plastic, but we can take some steps to reduce our plastic use. For example, we can swap plastic food storage containers with glass or stainless steel, replace plastic baggies with reusable lunch bags, and so on and so forth. Again, the key is to have things and understand things which are actionable and easy to do. We should, as far as possible, try to avoid canned foods because these cans are likely lined with BPA, and BPA is actually a fairly serious endocrine disruptor. Of course, certain pesticides have also been linked to hormone disruption, and it would be a good idea to eat organic food as much as is possible. Children, of course, don't need cosmetics. However, there's a glut of kid-related cosmetic products which should ideally not be used. While cleaning, many of us actually introduce indoor air pollutants into our home in the form of harsh chemical products. It is in fact difficult and often impossible to know what chemicals any given product contains because it's not always put in the list of ingredients on the product, because the companies think that would be giving away a secret formula. And therefore, it is a good idea to simply clean, as I said earlier, using a damp cloth or a vacuum. So let me end by saying that it's always a good idea to be a part of the solution and not part of the pollution. Thank you, Rakhi, again for inviting me for this Orchestra of Hormones. And as Mozart said, the music is not in the notes, but in the silence between. I will end my presentation by again reiterating my request to all of you to please support me as I stand for the presidency of FOXI. I actually have a website. I believe it's the first time that a website has been developed for a FOXI election. It's called isupportjaideeptang.com. And when you go on the website, you can register your support for me. And I'm really humbled, happy, and honored to share that literally thousands of FOXians have already registered their support for me. There is also a video blog session where a whole lot of my presentations have been put up. Or you could opt to join the Telegram channel and follow whenever I speak in webinars, which I keep on updating. Thank you very much again to the organizing committee for having me here. It's always such a pleasure and privilege. Thank you.
Thank you, Jaideep. It's wonderful hearing you as always. And this is for a different topic, which we do know so little. And yet you made some clarity about whatever confusion there already is. I'm sure we'll be hearing more about EDCs in the days to ahead, but thank you for guiding us through us and getting us this through. Hand over back to Minu for the rest of the proceedings. Thank you.
Thank you, Dr. Basab. Thank you, Dr. Jaideep, sir, for decoding such a complicated EDC for us. Thank you so much. We now move on to our third talk by a dynamic Dr. Nandita Palshetkar, ma'am. Ma'am's topic for today is Hirsutism Practice Essentials. And for that, I would like to invite our chairperson, Dr. Basab Mukherjee. Sir is the Vice President, FOXI. He's been the FIGO Coordinator, South Asia for Safe Abortion Committee.
Yeah, we'll leave it there. We'll move on to the talks because academics is...
Right. So over to you, Dr. Basab.
We need Dr. Nandita's CV. Dr. Nandita is one of the most lovable past presidents of FOXI. I think that is summarizing her. She's one of the most beloved among the last few FOXI presidents who we have had, and she's a darling to everybody. Dr. Nandita, she's so knowledgeable. Yet everybody loves her. She's got 65 orations delivered, and so many more to come. I think we'll celebrate the 100 once she crosses that. That will be really a big show. She's been a PG teacher. She's the medical director of Bloom IVF. Of course, the past president of FOXI, the president-elect of ISAR, the president of IAG in the past, Mumbai Society, and AMOGS. So she's got all the feathers which you have in her cap. She's had several awards received, and we are so proud to be happy to be hearing from you, Dr. Nandita. Thank you for accepting this invitation from the Endocrinology Committee and from FOXI to come here and deliver your talk. Dr. Nandita will be taking on the next topic. Yeah, so thank you very much, and it will be a pleasure to hearing from you over the next 20 minutes.
Thank you so much for that Dil Se introduction. That was really beautiful. Thank you. At the onset, I'd really like to thank, I think, Shanta Kumari, her whole team, and Rakhi for inviting me. Aruna's really been very instrumental in helping me come here and deliver the talk. So, Aruna, thank you. And of course, Shanta. And today it's something close to my heart. I've always been with Rakhi. Endocrinology is something I adore. Being a reproductive endocrinologist. 1 minute. Now, let me just reduce everything. Yes. Okay. So today my topic is very, very simple, Hirsutism. And there are a lot of changes in this topic today, and a lot of new things have come up. 2018, there was a beautiful, guidelines given by the Endocrinological Society. And I really want to say thank you to Professor David Herman, Chicago, who has helped me with this talk. So thank you very much. And, let's begin with what is Hirsutism? Actually, a few definitions, and then I will talk about it practically. Excessive terminal hair, actually, that appears in a male pattern. All the hair, androgen-dependent areas which happen, that is the sexual hair, not the normal hair in women. And I think that is very important. To understand this, I have this beautiful diagram, the prepubertal vellus follicle. Normally, we have vellus hair, which is there. And the effect of androgen, you can see, when the androgen acts on this vellus follicle, it can either convert it into hirsutism, that is converted into a terminal hair follicle, that is sexual hair, or it acts on the sebaceous glands and makes it into a sebaceous follicle, and you land up with acne. So hyperandrogenism can cause these two things. Whereas in the scalp, the testosterone has a different effect. The androgens have a different effect, and there's involution of that hair follicle, and there's balding. So this is something that we must understand. This is the very basic of hair growth. And how do you identify a patient who's got hirsutism or this? How do I get rid of all these things over here? No, 1 minute. Sorry. This band which is there. Anybody can guide me? I don't know. Anyway, okay.
Not seeing a band here.
No, I am seeing the band, so it's interfering in my reading of the slides. Okay, no problem. So let's look at the Fermin-Galway score, which was modified. Initially, it was of the 11 body parts. Now it is only of the 9 body parts. And these are the different body parts that we have. And the score is 1 to 4. And 1 is no hair and 4 is completely hairy, the male type of hair, like a beard or, chest hair, etc., etc. So what has happened is a score of 8 or more is classified as hirsutism, but that is okay for Caucasian women. For Asian women, actually, what we take, Asian, Eastern women, it's a score of 4 and above is hirsutism. I've been talking to a lot of colleagues of mine, and we've been discussing this, and it is true that in Indian women, the score is much lower. So what about the other definitions that are there? Local hair growth. The other day I got a girl with only hair on her chin. And she said, no, it's very traumatic. Is it hirsutism? But that is local hair growth. That is only localized hair growth in the absence of abnormal total hirsutism score. Nowhere else on the body she had hirsutism. But we must identify this. And now in 2018, there was a new classification which was done, which was called patient-important hirsutism. See, the patient is important. If they feel there's unwanted sexual hair growth of any degree, maybe mild or whatever, but it causes her distress, I think, to come to you and ask for treatment, that is a classification which has been added now, considering how we are moving with changing times. Then, of course, hyperandrogenism, is defined by the clinical features that result from increased androgen production or action. And as I said, you can have hirsutism, you can have acne, you can have alopecia, etc. Then idiopathic hirsutism is without the biochemical hyperandrogenemia, and you only have symptoms which indicate that you could have this problem of hyperandrogenic endocrine disorder. And we will see it. So when you evaluate a patient, look at these few pictures which are there. This is simple vellus hair. It is hypertrichosis, or it could be treated hirsutism. This is not hirsutism. So we need to be able to define, differentiate between the fine hair and the thick terminal hair. Then look at these two pictures. Both of them look PCOS, but the left-hand side on your screen, that is to my left, when I'm facing the screen, is there is hirsutism on the chin, but there is no acne. On the right-hand side, there's only acne. And when evaluation was done in detail, like 21 hydroxyprogesterone was done, and it was seen that it was a non-classical congenital adrenal hyperplasia syndrome, and the other one was just plain PCO. So it's very important to do these tests. This is a very interesting case of a menopausal woman who was, I think, 53, 54 years old. And she came with acne, hirsutism, balding pattern on the hair. And it turned out to be an ovarian neoplasm. So how do you? The importance is the rapidity of the symptom, the history, the duration of the symptom. This happened in 5 to 6 months. And that's why we have to look for an ovarian neoplasm or some kind of a neoplasm which can cause these this high levels of testosterone and cause these rapid symptoms. So history taking is also very important when you're looking at hirsutism. I wanted to show you this picture. This is hirsutism with folliculitis barbae. What does this mean? In India, we do a lot of waxing and all. And suddenly, after a couple of years of waxing, after some time, you get these follicles, which are, the hair which is ingrown and it's not coming out. It causes local inflammation, and you can see even pigmentation can occur eventually. And this is because of the mechanical removal of the hair. And we have to be very careful in dark-skinned people that this mechanical things like plucking, waxing, if you insult the skin too much, you can land up with the worst condition like this. This is worse than the hair that is there. So we have to be careful in advising the patients. Now, if you look at the androgen production in a normal woman, if you look at testosterone, which is in the center, testosterone is 50% converted from androstenedione, and 25% from the ovary, 25% from the adrenal. Whereas the DHEAS, remember the S, the sulfation of the DHEA comes purely from adrenal. 90 to 100% is from the adrenals. So when you're evaluating, you must understand that when your DHEAS is elevated, it's an adrenal source. And testosterone can be from anywhere, ovary or the adrenals. So very important to understand this concept of androgen production in the woman. And what is the differential diagnosis? We've talked about PCOS, etc. But remember, the non-classic 21 hydroxylase CH, that's NACAH, congenital adrenal hyperplasia, is something not very common, 0.2%. In fact, PCOS is 70% of the cases. CH is about 0.2%. Idiopathic is also 10 to 15%. So we need to keep this in mind. So a 17 hydroxyprogesterone level. Then if you look at Cushing's syndrome, could also cause it. Then increase prolactin. Simple levels of prolactin are very important because elevated prolactin levels could cause mild hirsutism. Then primary hypothyroidism could cause mild hirsutism. We must remember that. Acromegaly, then primary ovarian insufficiency, you normally don't get hirsutism, but there's irregular menses. So this chart actually, I've identified all the clinical aspects which will help us differentiate the different causes of hyperandrogenism and the differential diagnosis, because depending on the diagnosis, the treatments have to be given. So certain medications like, glucocorticoids, even estrogens, progesterones, which are androgenic, phenytoin, all these drugs can cause hirsutism. So we have to stop them if they're causing this problem. Obesity, virilizing neoplasms, etc. Now, the metabolic reproductive syndrome, actually PCOS. Now, we have to stop calling it PCOS. We have to switch over because it's a metabolic reproductive syndrome. If you can see, the GnRH pulsatility is absolutely normal and it secretes equal LH-FSH. If you see in this diagram, I don't know where my arrow is. Anyway. So the normal FSH-LH. But in PCOS, the pulses just rapidly increase. And these rapidly increasing pulses act more on the LH receptors and more LH is secreted. And remember, if you add progesterone to it, the rapid pulses again go back to normal and you can normalize it. So if excessive LH is there is action on the, if you look at the TICA cells, the LH receptors which are there are stimulated and you get excessive testosterone formation. And this then goes into the granulosa cell, the testosterone and the androstenedione, and it gets converted into the DHT and the estradiol. Now, what happens is excessive testosterone, excessive estrone, and the hyperinsulinemia, all of it results in reduction of SHBG. And the SHBG reduction, again, increases the free testosterone that's available. And you can see there is acne and there is hirsutism. So this is what happens in metabolic reproductive syndrome. And the diagnostic criteria, in the 90s, I think 93, NIH criteria, Rotterdam criteria was in 2003, and the androgen excess PCOS, all of them want oligomenorrhea, less than 7 to 8 menses per year. Then clinical or biochemical hyperandrogenism, and the Androgen Excess Society actually put in even PCOS on ultrasound. So these are the different criteria in which you can identify them. And more recently, the phenotype classification. So if you have a phenotype 1, 2, and 3, yes, you will find hirsutism in them. In phenotype 4, generally, they're normoandrogenic PCOS with no clinical or biochemical. So this is the PCOS when 70 to 80% of your patients with hirsutism will be PCOS, and you need to be able to identify them and do the differential diagnosis of the other forms. So very commonly, idiopathic hirsutism, and you must be aware of thyroid, prolactin, neoplasms, congenital adrenal hyperplasia. These are the more common ones. So evaluation. So in evaluation, you look at it whether it's isolated or local terminal growth, or an abnormal modified Fermin-Gallman score, which is there, or even that, that other definition which I said, local sexual hair growth. And of course, medication use. If there's medication use, you obviously discontinue and if possible, or change the drug if possible. Now, isolated local terminal hair growth, you give dermatologic therapy or even, any kind of local therapy. And if they're fine, there's no excessive hair growth, you don't bother with it. But if the hair growth still progresses, then we should evaluate this patient. So abnormal FG score, the hair growth, or even of an isolated patient, if it progresses, then obviously we do a total testosterone. Total testosterone is a simple assay which should be done. But what I would do is then, depending on the total testosterone assay, testosterone is normal or testosterone is elevated. Depending on that, we go ahead. If the testosterone is normal and the hirsutism is mild, isolated, again, oral contraceptives or local treatment, if it's stable, improved, you don't bother with it, and it's idiopathic hirsutism normally. If there is progression or of the disease, or hirsutism of moderate to severe type, then you do the free testosterone and the SHBG. And also sometimes the free androgen index is done. And depending on whether it's normal or elevated, you go for more workup. More workup includes prolactin, includes thyroid, includes the 17-hydroxyprogesterone, so that you can identify which part it could fall in and how you should treat them. So let's come to the treatment part of it, which is very simple. There are drugs. Pharmacology is one of the baseline treatments of hirsutism. So we have oral contraceptive pills, we have anti-androgens, we have GnRH agonists, we have mechanical agents and insulin sensitizers. Now let's discuss each one. So estrogen, progesterone, I think that OC pill is the best. So you have to use the lowest dose of ethinyl estradiol. You can use mestranol and plus a progesterone. And the progestins I will discuss a little later. This is the first drug of choice, and you can see it's good for hirsutism or acne. It's good for oligoamenorrhea and good for alopecia also. The next group of drugs is anti-androgens, which are cyproterone acetate, spironolactone, and flutamide. So cyproterone acetate is used very rampantly. Spironolactone, if the need be, it's a second line of therapy. And flutamide, do not use it. I think I want the message to go very clear that flutamide is not to be used at all. It causes liver damage, and there have been deaths, and it's irreversible liver damage. So please remove flutamide from your practice completely. The other is metformin, hirsutism and acne. Do not use metformin. It has absolutely no role to play in hirsutism or acne. So let's come to the other agents, glucocorticoids. Yes, dexamethasone, prednisone. If your DHEAS is elevated, it's an adrenal source, this will work beautifully. And it's a very low dose steroid which you give, and it works fantastic. 5 alpha reductase inhibitors. We have finasteride and dutasteride. I'm going to talk in details what it does. And those are the drugs which can be used. The topical ones are ornithine decarboxylase inhibitors, and they give good results in hirsutism or acne. Then there's minoxidil, of course, for the balding or for the scalp where there's hyperandrogenia, and ketoconazole. So let's talk about conversion of testosterone to DHT, and that is by the 5 alpha reductase. And if you see this type 1 and type 2, type 1 are the ones which are important to us: sebaceous glands, sweat glands, hair follicles. And if you go back to that slide, and you can see finasteride is only type 2, so it's not that effective. So dutasteride is the one which is really effective and would help. So that is the drug of choice for hirsutism. Now, androgenic activity of progestins in OCPs. This is very, very important, because there are some progesterones which have high androgenic activity. They will give you hirsutism, like LNG, norgestrel. Moderate androgenic activity is desogestrel, norethindrone acetate, norgestimate. So if you have hirsutism, just see if she's on any of these progesterones, because they may be the cause, and you stop them and it may go away. Then lowest androgenic activity is ethanodiol, diacetate, dinogest, and drospirenone. So these are the ones which have low androgenic activity. But remember that with the progesterone is the venous thromboembolism risk, and the risk is maximum with drospirenone and cyproterone acetate. So when you use this combination of oral contraceptive, please check for family history. Please check that she's not had a history of thromboembolism before. It's very important to do this, and maybe even factor 5 lead-in. You can check before you give it to the girls. So I think this is something that we must keep it in mind and remember. But now the guidelines which have come in 2018 by the Endocrine Society actually say that you can use any of the OC pills except of course the one which are androgenic progesterone. Local treatment is very good. It suppresses hair growth, the efloranithine hydrochloride, as I told you. Then remove the hair pigment by bleaching, temporary deepilation, shaving, chemical deepilators, which are there, and French was a big thing when I was a young girl. Then temporary epilation like plucking, waxing is available, and permanent removal of electrolysis is very good for the Caucasian skin. But laser works very very beautifully on our brown skin, and it's very good in our patients. And all my patients have been very happy with adding laser to their, armamentarium, and laser with the local therapy. Local therapy, whenever laser is used, because laser you need about 8 to 10 to 12 sittings sometimes. So you combine it with the topical preparation and it works wonderful. It's really good. And there's irreversible inhibition of ornithine decarboxylase, which helps. So the latest laser for hair removal is the Ice Cube 2.0, which has been launched by Richfield. It's a state-of-the-art Ice Cube technology. And, I can't handle pain. So this is something where the laser does not give pain. It's very cool. It's an excellent machine for hair removal. I think it's a wonderful thing for women, especially for hirsutism on the face and everything. It's wonderful for the girls. So that's it. But I would not like to end without saying, last but not the least, lifestyle modification. I think we all talk about it. And weight reduction, definitely in the obese patients. If you correct the weight reduction, the hirsutism will be helped. And the insulin resistance reverses with the patient has acanthosis nigrans. As I showed you, the insulin resistance decreases the SHBG, increases the free testosterone level, and causes a hyperandrogenic state. And that is why we need to reduce the weight. Our Indian population is, diabetic, pre-diabetic. We know the metabolic syndrome is 11 times more frequent in Indians than in the Caucasians. And we definitely need to look at this. So if your patient is obese, I think a combination of calorie restriction, increased physical activity, and behavioral therapy is very, very important. So friends, I would like to end my talk by saying hirsutism, if she's obese, lifestyle modification, cosmetic procedures should be offered. Believe me, they're psychologically traumatized. So I think along with our medicines, we should offer them, because I should not say cosmetic for these procedures. They are required because mental disturbance is today very much a reality, and they should be offered. If they're seeking fertility, I would delay the drug treatment until delivery. So deliver and then do it. Not seeking fertility, I think oral contraceptive pills is fantastic. It's superb with the anti-androgen, anti-androgenic action of the progesterone is fantastic. And if oral contraceptives are contraindicated, then obviously anti-androgens. But whenever you give anti-androgens, do not use flutamide. I'm repeatedly saying no flutamide is to be used, causes liver damage and death, so do not use it. But finasteride, duosteroid, which is the new latest drug, and definitely spironolactone, which has been there for a long time. And those would work. And I think that's it. That would cover your hirsutism. And if it's due to the other causes like adrenal, a steroid, even a GnRH agonist is now not used. But if your hirsutism is because of hyperthecosis, GnRH agonist would work wonderfully. So I think I have covered most of the things. If there are any questions, I would love to answer them. But thank you very much. And thank you for this opportunity. I really enjoyed talking to all of you. Thank you.
Thank you, Dr. Nandita. Always a pleasure to hear from you. This is a slightly different perspective of hirsutism than what we traditionally hear. Metabolic reproductive syndrome was a really new one. I think we should work toward that change of PCOS. Let's not keep it PCOS. Let's call it metabolic reproductive syndrome. Actually, it does deserve much more than limiting itself to the ovaries or a gynecological disease. And thank you for bringing us through so much of hirsutism, which we haven't heard of in a long period of time. It's such an important topic in the endocrinology, CME, and thanks that Rakhi has kept it and you have done good justice to it. Thank you, Dr. Nandita. And over to Minu, back to Minu.
Nandita ma'am, for being there. Thank you. Welcome, Dr. Shanta ma'am.
Shanta,
thank you.
Thank you very much.
Nice talk, Nandita.
Thank you. Thank you. Thanks, Aruna and Shanta.
It's Rakhi and team, it's Rakhi and the whole team did the great job. Good.
I know they've done a great job.
Thank you. Thank you.
Good morning, Dr. Shanta ma'am. And thank you, Dr. Nandita ma'am, for such a lovely talk. And thank you, Dr. Basab, for chairing this session. We now move on to our session 3. And for the next session, I would like to invite Dr. Anshu Raina as the MOC. Dr. Anshu Raina is the Secretary, Noida Obs and Gynae Society. She's the Joint Secretary, North Zone Yuva Foxy 2019. And she's a Clinical Director, Head at Apollo Cradle Hospital, Greater Noida. Over to you, Dr. Anshu, for the next session.
Thank you, Dr. Meenu, for a kind introduction. Now I'm going to start a third session of today's conference on a very interesting topic on lifestyle, health, and fitness. The good, the bad, and the ugly. What it is, now we are going to listen. And for this, I would like to welcome our chairperson, Dr. Sonal Parihar. She is herself is a Mrs. India Earth, Mrs. Earth International, and she is a brand ambassador of Rajasthan government for a Beti Bachao, Beti Padhao Abhiyan, and running a very popular YouTube channels, Ask Your Gynecologist, and the list is more and more. So now I will welcome Dr. Sonal Parihar to start the session with a very interesting topic on lifestyle. Welcome, ma'am.
Welcome, Dr. Sonal. What more to have a topic on celebrity talk being there with a celebrity being there.
Thank you, Dr. Rakhi, for having me here and making me a part of this CME. Thank you, the organizing committee. Thank you, Dr. Shanta Kumari, and all other office bearers of OTC. The session that I'm going to chair today is all about lifestyle and about fitness and the good and bad effects of that. And of course, the side effects, the ill effects of OTS, that is overtraining syndrome. And we are living in an era where everybody wants to look good. Most of us, not most of us, many of us want to look like Bollywood stars, and we forget what is our limit. We don't know exactly what kind of body we are having, what kind of stressful situations we are living in. And we as doctors are soft targets for OTS. We know that. We don't get our meals on time. We don't get to sleep on time, always under constant pressure of treating our patients. Whatever quality time we have, if we indulge ourselves into too much activity, then obviously that is going to make us succumb to the ill effects of OTS, that is cardiovascular problems, hormonal dysfunctions, and so many other metabolic errors. Now, coming to the glamour world, I'm connected with the glamour world for the last 4 years. After winning the titles, I'm training women for personality and for pageantry as well. I get women from all walks of life. I get social workers, I get doctors, nurses, teachers, I get even housewives, and everybody has the same problem, same common question. Why am I not able to lose weight? Why am I not looking as good as you, ma'am? Or why am I not able to look like my daughter? Why am I not able to come back to my weight, which was 10 years ago? So they are actually body shaming themselves. They're just depressing themselves, and that is not personality. One has to be comfortable in their own skin. That is what is personality, and that is what exactly I teach them. And this is exactly what is happening in Bollywood. Recently, we had 2 young people succumbing to probably OTS from Bollywood as well as from Tollywood, and they were all in their early 40s. So what is happening is there is a rat race there because the youngsters are coming. So many youngsters are joining the industry. They are 20, 25. So they obviously look better than a person who is in their early 40s. And when they can't understand this hormonal changes in their body, they indulge into drugs, into anabolic steroids, caffeine, nicotine, alcohol, just to increase their stamina. And this is exactly what is happening. They're succumbing to cardiovascular failures. So I'm sure our speaker, Dr. Aditi Tandon, is going to throw light on that. And she's definitely going to make us understand this topic better. So can we have her CV, please, here? So Dr. Aditi Tandon is a consultant gynecologist, fertility consultant, endoscopic surgeon at Dr. Sudha Tandon Fertility IVF Endoscopy Center at Chembur, Mumbai. She has a fellowship in ART and advanced minimally invasive laparoscopic surgery. And she's a recipient of many awards, including Foxy Young Turk awardee and Best Youth Council member. Over to you, Dr. Aditi. Please throw some light on this burning topic.
Thank you, Dr. Sonal. And at the outset, I would like to thank Dr. Rakhi and Dr. Shanta Kumari and the entire Foxy team to allow me to present and give me the opportunity to present today on this very different topic, but very important topic. You know, it's not often that we listen to gynecologists talking about health and fitness in general in gynecology conferences. So this was something different. And when Dr. Rakhi asked me to speak about it, I said, why not? I'd just like to start sharing my screen.
Aditi, you need to cut short your topic little bit better.
Yes, yes, I'll do that. I'm just trying to.
We are running late little bit.
Yes, yes, ma'am. Sorry, I just had a. Okay, I'll just have to rejoin. I think there's some issue. I'm using another laptop.
If there's an issue, we'll have the panel first and then we'll get back to the after inauguration with her talk.
I think she'll come back, Rakhi, just now. You can have a discussion with Dr. Sonal. I think she's around. You could just continue the discussion. She'll just join.
Rakhi, if she wants, we can share the presentation too. If she's not able to share,
I think she's,
put it in the group. We can share it.
I think Dr. Aruna, she went. She's coming back again. She's logged in through two devices. That's what I can see. And that's the first thing, and that's because she's having a problem. Yes.
Yeah. Yeah. Okay. Am I audible?
Yes, Aditi.
Yes, yes. I'll just start sharing. Yeah. So today I'll be speaking upon health fitness, the good, the bad, and the ugly. So, you know, how often do we make resolutions every year, every new year to adopt to a healthy lifestyle, to eat clean and to exercise regularly? And why do we think that is? Because it simply cannot be a change in your routine. It has to be your routine. It has to be a habit, and only then it is sustainable. It has to be a way of life. And at the end of the day, it does come down to the discipline, the determination, and the drive to stay as healthy as we can. And, you know, it's much more than just about aesthetics. It's more than just the way you look, the food you eat, or the weight that you lift at the gym. It's more about the way you feel. It's more holistic. It's about your quality of life, the focus you have at work, your ability to move, and your psychological state. And not only that, you are also going to be setting an example for your friends and family by, you know, making the healthy choices that you make, and they will be inspired by you. So I would like to ask each of you at, you know, listening to this, these 4 important questions. Do you smoke? Are you able to maintain a healthy weight, BMI of 18 to 25, or are you successfully losing weight if you are not, you know, in the normal BMI? Do you eat at least 5 servings of fruits and vegetables a day? And do you exercise 30 minutes or more 5 times a week? So motivation is what gets you started. Habits are what keep you going. So, you know, good habits, we know, are important to lead a healthy life. Brushing and flossing daily, having a good night's rest, because sleep can also trigger overeating. Enjoying regular family meals also is important. You know, being connected to your family and friends is a very powerful, important aspect of a healthy life. Smile, laugh out loud several times a day. It keeps you grounded. Meditate, pray, and otherwise find solace for at least 10 or 20 minutes a day, which is good for your soul and also may help you reduce your blood pressure. Get a smartwatch and let it motivate you to walk. It does not matter how many minutes of activity you need. Just, you know, try to fit more steps in your day. No matter how you get it, it can definitely, physical activity can help diffuse stress, burn calories, and boost self-esteem. Of course, yoga is great. It helps increasing strength and flexibility and improves balance. And I cannot stress upon this next point enough: power up the protein in your diet, you know, because it should make at least 10 to 35% of your calories, because it lasts for a long time in your belly, and combined with high fiber foods, you feel fuller on fewer calories. So we all know the protein rich food, and it's important because the amount of protein we need a daily is 1 gram per kg per day, which for a 60 kg adult is 60 grams per day. And we do not get that in our, regular diets, especially our regular Indian diets, especially those who are vegetarians. We do not get this, required protein intake. So I think we all need to be mindful and really increase the protein contents in our diet, and especially also in pregnancy, since we are obstetricians, this requirement increases to 1.5 gram per kg per day. So it's important to tell our patients the importance of having protein. Last but not the least, have a positive attitude. We know that the belly rules the mind, and some small things about diet. Eat a variety of vegetables, fruits, whole grains are important. Reduce processed carbs, low fat dairy products. We all know the good sources of protein. Reduce your intake of saturated fats and trans fats. Use vegetable oils instead of solid fats. Reduce your daily intake of salt or sodium. Of course, an occasional cheat meal is okay, but you must learn to restrict the number of times you have junk food. And I actually don't remember the last time I drank a Coke or even a Diet Coke. So I honestly don't see what people find great in having a Diet Coke, but it has absolutely nothing which will, it has no nutrients. It only has pure sugar and, empty calories. Even the sugar alternatives are not really healthy. And if you drink alcoholic beverages, do it in moderation. Swap in the refined grains with whole grains. Examples of whole grains are plain oats, whole wheat, rye, corn, brown and wild rice, buckwheat, bulgur wheat, millets. And of course, we know what the refined grains are. So I think this is extremely important. A small change that you make in your diet is really going to go a long way. So we know that exercise is good for us, but how good is it and what are its benefits? It will make you feel better. It adds energy. It adds more years to your lifespan. It, of course, controls weight. It combats health conditions and diseases. It can prevent various health problems like stroke, metabolic syndrome, high blood pressure, type 2 diabetes, as Dr. Nandita already mentioned, that we Indians are predisposed to diabetes. Hence, we should understand the importance of exercise and diet. It also helps preventing mental problems like depression, anxiety, also many types of cancers, arthritis, and also improves cognitive functions. Of course, it'll help improve mood. It will boost energy. It also promotes better sleep. It can also put back the spark into your sex life, because it increases your self-confidence and it may enhance arousal for women. Men are less likely to have problems with erectile dysfunction. And last but not the least, exercise can definitely be fun and social. It helps you connect with friends and family in a fun social setting. So, just take a dance class, go for a hike, or join a sport. You don't necessarily have to run a marathon or even run at all to be healthy. Just choosing an activity that will keep you, active, which you have an interest in, will increase the chances that you'll stick with it. Also, it'll save money because you're less likely to see a doctor. It will lengthen your lifespan. It can also be good for the environment. So yeah, when I'm talking about lengthening the lifespan, if you're having basic healthy habits, you could live up to 14 years longer than somebody who's not. And that's, significant. So the bottom line, the US Health Department basically recommends these guidelines for aerobic activity, 150 minutes of moderate activity, or 75 minutes of vigorous activity a week. And if you're for greater health benefits or to assist with weight loss or maintaining weight loss, at least 300 minutes a week is recommended. But even small amounts is helpful throughout the week. Being active for short periods of time can also add up to provide health benefits. Strength training. We women are so prone to developing osteoporosis, especially post-menopause. So strength training also has to be stressed upon so much, because that is a very effective way to prevent development of osteoporosis. So at least 2 times a week, do it with either weights or resistant bands to tie your muscles after about 12 to 15 repetitions. Also, it's important where you get your information, because nowadays where people get their information is changing. It's instead of a dietitian or a physician, it's going to be their social media news feed. It's going to be a blogger who has a large following on Instagram or Twitter. But the trouble is that some of these wellness warriors and citizen scientists, the advice that they give is unreliable and can even be dangerous. And often, the kind of photos they put are not really what is not very real. It is, faked, and Photoshop selfies are very common. So life is not a stream of perfect selfies. Putting so much focus on appearance over health or striving to look like someone else can be very detrimental, as Dr. Sonal already said. And sometimes these bloggers may just make bold statements like eliminate wheat completely, or dairy, or other toxic foods, where you may not really need to do that. But since these people have such large followers, everyone will think what they're saying is right and probably believe them. Even something where we speak of PCOS, there is so much of an anti-oral contraceptive sort of notion amongst a lot of these people who have no idea what they're even talking about.
Sorry to interrupt you, ma'am. Only 1 minute is left.
All right.
To interrupt you in between.
Yes, no problem. So basically, how much is too much? So apparently, yes, there have been studies which have said that, like any medical treatment, it can be exercise can be harmful if it is overdone. And researchers have also found that although running at moderate speeds was linked with lower risk of death from any other cause compared to no running, but more intense running didn't yield any additional benefit. And studies have also shown that following a marathon, runners showed up to a 50% increase in the levels of troponin, which signals damage to the heart. So basically, this damage can cause scar tissue, and a thickened scar is more vulnerable to abnormal heart rhythms. And these people have shown to have 5 times higher risk of atrial fibrillation or fluctuation in the heartbeat that can trigger more serious heart problems. Almost, if 12% of marathon runners have had heart scarring, and hence these endurance trainers, marathoners, are more likely to have a heart attack or other stroke-related problems. To just sum up, of course, exercise and hormones has its play, and exercise increases insulin, increases epinephrine, increases thyroxine, also testosterone and endorphins, which we know have their positive effects on our bodies. So just keep calm and stay healthy, and thank you for listening.
Thank you, Dr. Aditi, for the enlightening talk, and you made us understand it better with your scientific proofs and scientific, we all know this, but I think we just become very negligent. And
Yes.
Thank you for hammering it again into our
I think
brains
it's
and what we
important to
have.
just keep reiterating it once.
Yes,
once in a while.
yeah.
Yeah.
So thank you very much.
Thank you.
Thank you, Dr. Rakhi.
Thank you, Dr. Rakhi.
Thank you, Dr. Sonal, for chairing a wonderful session. So now I would like to request our next MOC, Dr. Dipti Agarwal, to please start our next session. So Dr. Dipti is an endoscopist and the fertility consultant at Sri Krishna Hospital, Silvassa, and she is a past Secretary General of WAPI OBG Society during 2018 and 19. So now I would request Dr. Dipti to please start the next session, that is session 4.
You're muted, Dipti. Unmute yourself.
Thank you, Dr. Anshu, so much for the kind words. At the outset, I would like to thank Dr. Rakhi Singh, Endocrinology Committee Chairperson, FOXY President, and all the esteemed faculty. We are here for a very novel panel on a topic which is very much of interest in these days about bone metabolics and hormonal imbalances. For this panel, I would like to request Dr. Rakhi Singh and Dr. Parikshit Tang sir as a moderator. Can I have, yeah, Dr. Parikshit Tang sir needs no introduction, but still as a formality, sir is a consultant at Ashwini Maternity and Surgical Hospital, Mumbai. He is also attached to many hospitals in Mumbai and Thane. Sir is presently treasurer, FOXY, chairperson of...
Dr. Dipti, if you don't mind, you can cut it short. Please.
Thank you, sir. Any which ways, you and Dr. Rakhi Singh needs no introduction. Ma'am is presently chair of Endocrinology Committee with doing such a wonderful activities as we are aware. So, ma'am, may I request Dr. Rakhi Singh, ma'am, to introduce all the panelists. Thank you.
Thank you, Dipti. We've got a lovely set of panelists with us with the whole basket of it. And my co-moderator, Dr. Parikshit sir is there. Dr. Meeta Gupta. We have got Dr. Meeta with us. She is the past IMS President of India. And we have, this is a wrong CV, sir. We've got Dr. Amita, and then we've got Dr. Rajiv Tukral. He is the orthopedician and on board with us, and Associate Director for Orthopedics and Head and Joint Replacement Program at Asian Institute, Faridabad. And he has got a special interest and in orthopedic trauma surgeries and complex revision MIS. And he's been the editor for the Clinical Orthopedic and Trauma section and section editor for the Indian Journal of Orthopedics. Next, we've got on board with us the dietitian, Dr. Shilpa Joshi. As we all know her very well, she's been visiting us for FOXY programs many a times. She is a director of Mumbai Diet and Health Center, practicing dietitian and diabetic educator, vice president 2019 to 21 at the Indian Dietetic Association. Next, we have got on board Dr. Pushpa Sethi. She is a senior practicing obstetrician and gynecologist from Gurgaon. And she has been the vice president of FOXY. And we've worked at length and heard her publications and her presentations many times. Welcome, Dr. Pushpa, ma'am. And then we have got Dr. Surendra Kumar Sharma, sir. He's an endocrinologist on board with us. And thank you, sir, for taking out your valuable time and being there for us. And he's got many publications to his credit and past professor for the medicine at the Mahatma Gandhi Institute of Medical Sciences and chairperson of the Diabetic Welfare Society, chairperson of the Diabetic and Thyroid Endocrine Society. Here I present to you the expert panelist. Over to you, Dr. Parikshit, sir.
Thank you. So I'm just going to start sharing my screen. And since Dr. Meeta was not formally introduced, may I just add that she's a practicing gynecologist in Hyderabad, and she's a past president of the Indian Menopause Society, an extremely well-read, well-known figure in the field of menopause medicine. And it's a pleasure to have all of these wonderful panelists with us today. So when we were, trying to formulate this panel, I must at the outset say that Rakhi's done all the work, and I'm here purely as a supporting actor type of thing. So we thought what would be of interest, to practicing gynecologists, and what are the practical things that we can discuss today, which would be useful in day-to-day work, day-to-day practice. So we know what osteoporosis is, and it's not only the bone mass, but it's also the changing paradigm of the bone quality. Rakhi, if you could go to the next slide, please, if you don't mind. Right, which we are talking today. And ultimately, it's the bone strength which makes up our skeletal framework, which is at risk when we are talking about osteoporosis. Next, please. So postmenopausal states, this is one of the most common problems that women face. And as our lifespans are increasing, women are going to spend a significant amount of time in that postmenopausal state. So that's why osteoporosis becomes an important entity that we need to look at. Next, please. So let me start with Dr. Sethi right away. I mean, when we are talking about this problem of, bone health, what is the incidence? What kind of disease burden are we looking at in terms of osteoporosis?
So a very, very good morning to all of you. Good morning, Dr. Parikshit. Good morning, Dr. Rakhi. Thank you for having me here. And a very, very important topic in our, IMS circles is osteoporosis. And at times I say, when we are faced with the orthopedic surgeons at the same platform, we feel slightly nervous. But I think today is going to be a very basic and, a nice talk on the basics that the gynaes need to be aware of as far as osteoporosis is concerned. So when we talk of the burden of osteoporosis, we'll be talking of the Indian data. So among the Indian women, the studies have been conducted in small groups all over the country. And the 2019 survey said that it was estimated that amongst the 230 million Indians expected to be over the age of 50 in 2019, 46 million women would be having osteoporosis. So to that much. And this data in 2003 was 26 million.
I've already joined. I
And
joined from another
2013
number.
was 36 million. And in 2019, it became 46 million. And the incidence comes to 1 in every 3 females in India will be having osteoporosis if we go by this data.
So it's undoubtedly a huge problem that women all across the globe and in India too, they are going to face in the times to come. I think Dr. Meeta has joined with another name, but I think it's
her only, Nonehal Singh, yeah.
Yeah, okay, that's fine. Yeah, hi, Dr. Meeta. Good morning. Yes.
Good morning.
Yeah. So my next question to Dr. Joshi, the first thing that any human being would look at is not to take medicines. And one of the most common questions that we get asked is, so fine, I'm going to face this problem, but can I treat it with something in my diet? So the question to you, Dr. Joshi, is the peak bone mass that a woman is going to achieve and what she eats, are they interrelated? How are they interrelated?
Thank you so much for the question. Thank you, Dr. Rakhi, for the invitation. Can you hear me? Because, hello?
Yes, we can hear you, Dr. Joshi.
Yeah. So, yes, it is related, but unfortunately, what happens is diet comes to mind of people after the bone mass has gone down, after after osteoporosis has set in. So if somebody takes care of diet much before that, then it is going to help to build the peak bone mass. And like rightly said by my previous speaker also, that there is a lot of, people talk about calcium and vitamin D, but people forget to talk about protein, which forms the matrix. And also people forget to talk about salt, which leads to a lot of bone mass loss, and Indians eat a lot of them. So I think all this is very important to talk about. When they are reaching peak bone mass, so at around 25 years of age. But the bigger problem is that most of the girls in our country at 25 years of age are busy following a fat diet to lose weight. So rarely are they thinking about eating healthy. They're just trying to think about what to avoid so that they don't gain weight. So it's very important that they eat healthy and they exercise so that they achieve a peak bone mass.
I think these are very important messages, not only for gynecologists, but even in the broader sense. As Aditi was saying that, it's not just about good looks, it's your health which you are aiming at in the long term. So Rakhi, if we could go to the next. Dr. Meeta, this comes to you, and having been the president of the IMS, there have been so many programs about osteoporosis, menopausal health. So my question is that who should we screen in terms of bone health? Is it everybody or some selected group of women? What kind of prevalence is there in terms of screening in our country, and what is the unmet need? If you could please address these issues. Ma'am, you're muted, so I think first you'll need to unmute.
Sorry about that.
No
A very
problem.
good afternoon, and thank you so much, Dr.
Pleasure.
Tank. And also thank you, Dr. Rakhi and the team for having me in. And a big hello to all my colleagues, because all of them are well known, Shilpa and Pushpa and most of them. Coming back to the question, I think, the answer actually lies in the first question when you made that beginning and said such a huge problem. 1 in 2 women will suffer from osteoporosis, and India is no different from that. Of course, the prevalence rate that we have got are very, very different, because based on the different studies that have come in. But yes, the prevalence is very, very high, and the screening is very low, extremely low. But who has to screen? See, it's not just the prevalence is low. Now, to understand, this is a very good initiative, because it's not just the gynecologist. I think everyone in the medical field who comes in contact with a woman above the age of 40 should be sensitized for these primary things, like a primary physician. So being now a very super specialty world all over, so the woman reached to the orthopedician for fixing up the fractures, which is not the right thing, actually. So the menopause, though it's been there for a very long time, the awareness is just setting in. And we had the WHI, and there was a huge setback again. So I think people are coming back to understand the role of hormones in the woman. We're not talking about the external hormones. We're talking about the hormones which are present and the process of aging, of menopause. So I mean to say that screening is, of course, very, very, very important. And the prevalence of low bone mass, like we put it in the textbook of clinical practice guidelines of menopause, 60%, 80% by the time you're 80. And this was a very good study from Pune, good studies coming in from Vellore, a lot of work from Vellore, which have very clearly shown that the doctors are unaware. The people are unaware. The knowledge is very, very poor when you're looking at the understanding of osteoporosis. So it's a huge unmet need, which we need to fulfill. And screening is very, very simple. Coming to the methods of screening. So screening it's for everybody. It's not selective screening. It's a universal screening that we have to adopt, because there are cost-effective methods, which you don't even need to be a doctor. Any paramedical can do screening for osteoporosis, because we have some excellent tools like Osta, which is just the weight and the age.
I think we are going to talk about those things in the next few slides, Dr. Meeta. But I think point very well taken that it's
Dr. Parikshit? Dr. Parikshit, sir? Have we lost Dr. Parikshit?
Yeah, I think his internet might be.
Yes, ma'am.
Moving ahead, Dr. Pushpa, ma'am, this is another question to you. What are the risk factors what we are looking at? Who are the patients whom we are looking at that they would be exposed for osteoporosis?
So when we talk of the risk factors, we talk of 2 types of risk factors. One is modifiable and one is non-modifiable. The non-modifiable risk factors, they are not in your control. So you cannot control them. But the modifiable risk factors, they definitely are in your control and can be controlled. In the non-modifiable, you have age over 50. You are, once you are menopausal, you are exposed to osteoporosis. Female gender, estrogen deficiency, whether it is because of menopause or it is because of premature ovarian insufficiency or surgical menopause, then hereditary, if you have family history of fractures in your, the females in your family, or there's a family history of osteoporosis, you're more exposed. Then race and ethnicity. The Caucasians, the Indian population is more prone to osteoporosis than the Caucasian population in the ratio of 1:3. So, and the modifiable risk factors are very important, especially smoking and drinking, because this has become it's become a habit with the younger generation. So, smoking is absolutely no. Drinking in moderation is all right, like 1 drink a day for women and 2 drinks a day for men. They say that is moderate drinking. So that is permissible. Malnutrition, you're having the same thing, that you don't eat a balanced diet, you have lots of, low dietary intake of calcium, vitamin D, so many micronutrients. Then a high protein diet. They say high protein diet leads to urinary loss of calcium from the bones. So high protein diet is taken as a modifiable risk factor. Then being underweight. Low BMI, less than 19 kg per meter square is a modifiable risk factor. Then insufficient exercise, another factor which is very common because of the sedentary lifestyle these days. So this leads to people being more exposed to osteoporosis.
Thank you. We need to focus more on the modifiable factors. Non-modifiable factors we cannot look at. Over to you.
Yes, and I think we've been talking about osteoporosis in general, but let me come to Dr. Sharma, sir. Sir, there's a concept of secondary osteoporosis. So if you could please throw some light on that.
Well, secondary osteoporosis is again very, very important. In addition to advancing age and female sex and menopausal, we have to sometimes look into many of these secondary causes. And one of the very common secondary causes are like hyperthyroidism, our diseases like Cushing's disease, where we have excess of glucocorticoid secretions. So many medications are also going to produce osteoporosis. And you find that rheumatological conditions where we are using large amount of steroids for the treatment are again linked to many of these secondary osteoporosis. So, and simple, a celiac disease patient is again having problem, and you have some secondary osteoporosis. So secondary osteoporosis is to be looked into whenever you find that the osteoporosis is occurring at an unusual time. Early patients, like younger patients are having, or patients who are suffering from other diseases, first we have to rule out secondary causes. Thank you.
Absolutely, sir. I think sometimes we, approach the problem with our blinkers on, and we might miss something which is important in terms of the overall medical picture, the medications, and that's what we need to be, be alert for. Now, I would request Rakhi to take over and, continue with the proceedings for the rest of the panel.
Thank you, Dr. Parikshit. My question is to Dr. Rajiv. Could you please highlight on the different clinical scenarios what you've been seeing with osteoporosis patient, and how do you distinguish that this patient could be at risk for osteoporosis, and what are the different screening tools and their modalities for osteoporosis? Dr. Rajiv? Dr. Rajiv? Dr. Rajiv is not there?
I can see him. I can see Dr. Rajiv. Yeah, there he is. But I can't hear him.
He is muted?
No, he's not actually. Dr. Thukral, there's something not okay with your mic. No, we can't hear you as yet.
Because I can't see him. Because
I can see him, but I can't hear him. So maybe we could ask Dr. Neeta to answer this because she was on that track, and we thought.
Otherwise, also we were about to ask Dr. Neeta.
Yeah. Dr. Meeta, if you could please take this one. And in the meantime, we request Dr. Rajiv to, get the audio on.
Am I audible now?
Yes. Dr.
Great.
Rajiv is audible now.
Yeah.
I'm so
Yeah,
sorry
great.
about this. I was on my phone earlier. Now I've come on to my laptop. Really, I mean, thank you for having me at the outset. First and foremost, being an orthopedic surgeon in the middle of all this gynecology is a little by itself. I won't use the word scary, but at least something odd that we don't normally get used to, being in an all-male field, more or less. But then having said that, what do we actually see is that in our clinical practice, there are many patients who are not even diagnosed. So this problem is actually only picked up when patients come to us with fractures or who come to us, with dull aches and pains all over the body. And even if they are diagnosed by other people, they are pretty much undertreated. And it's a common fallacy for most physicians all over the world, even in our own country, to only give calcium or only give vitamin D. Now, the requirements, if you really look at for which patients are supposed to go for a bone mineral density test, are classified by the National Osteoporosis Foundation as such. All Caucasian women above the age of 65 and any postmenopausal women, even above the age of 45, who's at risk of osteoporotic fractures, or those who already have had fractures in their past or who are on hormone replacement therapy, or even males above the age of 70 are considered risk for osteoporosis, and they're required to undergo a bone mineral density. Ideally, that's the protocol. Unfortunately, it's not done routinely. If you really look at what are the scores available online, there is the most famous score that is called the FRAC score, which you can just go on to the NHS website and you can sort of enter online the different data, and it will give you a bone mineral, it will give you a fracture risk score over the next 10 years based on your age, your sex, your height, your, that's the one, on your history of fractures in the parents, or you having taken steroids or alcohol or smoking. So all of them together. But there are other scores that are also used, something like the OSTA score, which is the osteoporosis risk assessment score for Asians, which is a very simple tool which takes into account the height and the weight only. It's actually equal to 0.2 times the height minus weight, or is it the weight minus height, something like that. So it'll give you a score, and then it's a very simple score, and that gives you an idea. But none of these are very sensitive. You have another 1 minute score, which is a part of the FRAC score. You have the score itself. All of them are different sort of screening tools. But what is really used to as sort of define osteoporosis is still the bone mineral density done by the DEXA scan. So the DEXA scan will give you a score, and it will give, sorry, Raki, did you say something?
No, I was telling Dr. Meeta wanted to add something.
Please.
Raki, perhaps, I would like to add something, especially because we have the other specialties over here, basically for the orthopedicians and the endocrinologists. We would like to send in the message that, based on the input from the experts or people who have done a lot of research in the field of osteoporosis, we have come up with guidelines as to who has to go for screening by DEXA. If it is possible, and it is very different from the NOF. And the very reasons are very, very clear, because the early age of menopause, around 46 compared to 52 in the Caucasians. And our average age, when we had initially done the guideline in 2012, updated in 19, then the average age of a woman would expect to live was 65 to 67. So, the purpose doesn't serve at all if you have started screening at 65. So it is 5 years after menopause without risk factors, and at menopause if there are some major risk factors. So these are very important messages which we have to propagate in India. Otherwise, we are going to lose a lot of women who are going to be not be taken up. Yeah, that's it. Thank you, Raki, for that.
Thank you, ma'am.
Yeah, so Dr. Geeta has basically emphasized what we keep telling our patients, the same thing. It's very nice to hear the experts say that. I mean, whatever has been described on the presentation are basically criteria that are prescribed by the National Osteoporosis Foundation, the US and the UK. But of course, we have to modify them to Indian standards. And like she mentioned, the age of menopause is much lower here. And also the life expectancy for the woman is pretty lower here comparatively. So having said that, there are other scores available, like you can see out here, and they take into account certain medical diseases like rheumatoid arthritis or diabetes or glucocorticosteroid intake. and a history of fractures. But for an orthopedic surgeon, if you ask any orthopedic surgeon who knows about osteoporosis, he will tell you that fragility fracture by itself confirms that there is osteoporosis. So you don't need to actually go and get any special tests or a DEXA scan done. But then it's done mostly for you to base your treatment on. Now, this 1 minute score or this different kind of tests that have been putting up on the screen just now, they're all different variations of the same frac score, which tell you about, how prone you are to develop fractures. If you have medical disorders, if you're on medication, if you've had a parent who's got a hip fracture, or if you've lost height over some time, or taking alcohol or smoking, all of these are indicators for, low bone mass and therefore requiring some form of treatment.
Dr. Tukral, do you normally get the MRI and the CTs done for challenges in the insufficiency fractures or anything regular, or it is only done for the limited population?
Yeah, so that's a very good question, because, if you actually look at it, what we do in ultrasonic bone mineral density management or testing, the DEXA scan is only an area, it's not a volume. So you don't really do, it's a gram per meter square, the result that you get from a DEXA scan. But if you want to do a true bone density, you have to do a gram per cubic meter, which is done through a quantitative CT scan. Quantitative CT scan. But really, this, unless, like you correctly said, you're looking for is occurring in subchondral bone, patients presenting with dull hip pain for a long time, not getting better. So you do MRIs like this and you can pick up these insufficiency fractures. We don't totally do them. We only do them if you're not able to explain the pain or you're not able to diagnose the problem. If it's localized to a particular area, then we only do these MRIs.
Okay, great. Moving on ahead, we've understood and learned a lot about the diagnosis part of it and how to prevent it. Let's understand from our friend Dr. Shilpa Joshi madam that what has to be consumed and prepare ourselves for a healthy menopause. Over to you, Dr. Shilpa madam.
Many things. First of all, emphasis on healthy diet. Like I said, protein has to be consumed. Now, ma'am had said that high protein diet can cause bone loss, but that is not a worry in India unless people are going on a high protein diet by choice. Typically, Indians are consuming very low protein. So a high protein diet in India means 0.8 grams per kg body weight, which is actually just the right protein diet. So that is something very important. Eating less salt, like I said previously also, is very important. And that's a big problem in India. Our sodium consumption is very high. Besides that, having bioavailable sources of calcium. So people tend to have calcium from sources which are not bioavailable. So it is very, very important that bioavailable sources of calcium, typically which come from dairy products, is very, very important. And that should be consumed. If consuming dairy is a problem because of lactose intolerance, then, low lactose containing foods can be taken. Besides that, vitamin D fortification, because there are no dietary sources of vitamin D. So therefore, supplementation of vitamin D. Magnesium is also very important, which comes from nuts and oil seeds in our diet. So magnesium should be taken. And vitamin B12, again, if somebody is vegetarian in India, there are very few sources of, there are actually no dietary sources of vitamin B12 in a vegetarian diet. So supplementation is important. If somebody is non-vegetarian, then they could consume non-vegetarian food, which is not overly cooked. And that's a great source of vitamin B12 in the diet. Besides all this, eating balanced food with vegetables, fruits, etc. is important, because fiber is also important part of the whole gamut. Yes.
Thank you, Dr. Shilpa. Dr. Meeta, would you like to please tell us about the recommendation on the calcium and D3 on the vitamins, what supplementations, what we give it to our patients and when and why?
Thank you, Dr. Rakhi. Yes, I mean, I agree with what Dr. Shilpa has been talking about, that, when you talk to your woman, at least till the age of 60, where the absorption capacity is pretty good, you should always try to enforce the dietary mode of consumption of the calcium, and the requirement in the reproductive age and differs from the pregnancy and the lactation at menopause. When you're talking about post-menopause, it's more than 800 milligrams. The NIN has just hiked it up to 1200 milligrams last year. But we feel that anything more than 800 milligrams is also sufficient, because as such, when you look at the studies, we hardly take more than 400 milligrams on an average. So the worry is when you increase it to 1200, probably the prescriptions of calcium are going to go up exponentially, which they already are even with that 800 milligrams. So having said that, so it's about more than 800 milligrams of calcium and about 1000 IU of vitamin D every day. So that should be the prescription for your women. With the protein, the protein is very important, 1 milligram per kg body weight for the bone health. So all the ingredients are necessary for the making of the bone. If you don't have them, there's no point. And we see a lot of prescriptions where vitamin D is given, but the calcium is not supplemented. So it doesn't make any sense, because vitamin D is only a vehicle to absorb that calcium from the intestine to take it to the bone. So both of them have to go together. Only then it makes sense when you're doing your prescription. So I think I answered your question. Anything else that we missed out on?
Just want to put in one word, Meeta.
Yes.
The calcium intake becomes very important when the girl is growing up, adolescence, pregnancy, lactation, because she has to have good calcium till the time she builds up her maximum peak bone mass. If peak bone mass does not build up to its full capacity, she enters menopause with already a deficit. And on top of that, losing calcium. So she becomes more prone to fractures. So calcium is very, very important at that time of growth when she's building up her peak bone mass.
Absolutely.
The peak bone mass needs to be addressed, and the storage has to be addressed for these young adolescents and the young adults, so that we have all of them in place. And moving on ahead, Dr. Rajiv, lifestyle and physical activities, what would you like to recommend for all our young adults and the perimenopause?
I think you had a very good lecture before this panel discussion on how to change your lifestyle by doing regular exercises. Naturally, if you're looking at pure vitamin D, we all know that the metabolism of vitamin D requires you to have sunlight exposure where you can get UVB radiation on your skin, so that it can get a little activated to a hydroxy form and then go through the liver and the kidney to actually form the active vitamin D. So you need to have a good liver and you need to have a good kidney to actually have good vitamin D metabolism. But then having said that, exercise is something that I think cannot be stressed less or enough, because the lifestyle that we have today, especially with the pandemic coming in, is pretty sad. It's all limited to within the house, and like we are doing an online web program, most of the work is online. So somehow we have lost the sense of understanding that we need to get out and do stretching exercises and some form of loading of the skeleton, because if we don't, we won't build up, it will not be absorbed by the body. So any exercise, whether it is simple stretches or walking, some form of yoga is one of the best ways of doing that, or some dance programs, all have to improve your exercise and your muscle mass and your bone mass.
More so, the weight-bearing exercise would help us a lot in the perimenopause.
Definitely, but what I say is that if you can't weight bear, I mean, there are some people who can't. Fractures, for example, patients who come to us. So in those patients, we tell them to do mobilization first to improve the blood supply, and then you can weight bear. So
slowly and steadily the things move on ahead. Coming down to Dr. Meeta, hormone replacement therapy in menopause, as it has we've heard at length with our international expert. Would you like to comment?
Yeah. Thank you, Raki. That's a very appropriate question, because that's one of my favorite topics, hormone therapy and osteoporosis. And, as a gynecologist, when we deal with women at menopause, and we know the term itself is post-menopausal osteoporosis. It's got a lot of meaning when you say post-menopausal osteoporosis, because the loss is to the tune of 1 to 5% when the estrogen deficiency is there. So it's just common sense that, you have to replace what is deficient for these fast losers. So there are fast losers and slow losers. So people who have a good bank, the peak bone mass, a good peak bone mass, a good lifestyle, and they are not on any other medications, no risk factors, they have led a good life. So they start off with a very good bone balance and they don't lose so much of, in spite of the deficiency. But unfortunately, there are women, in spite of everything, they are the genetic factors where there's going to be a problem. So I think these are the women where when there is low bone mass, it is accepted all over the world, low bone mass. Within 10 years of menopause, there is a role of hormone. We don't say hormone replacement therapy at this age. We'll say menopause hormone therapy. And
Oops, I think we lost Dr. Meeta there. But...
Okay, we'll move on ahead. Dr. Sharma, would you like to tell us and inform us that if there is any medication for the prevention of osteoporosis, what all these high-risk age group we could offer for them?
Well, for the prevention, you have to right from lifestyle, you have to go for exercise program. You have to take care of nutrition, vitamin D and calcium. All those things are preventing the osteoporosis. So exercise, weight-bearing exercise, vitamin D, proper doses like 1,000 to 2,000 units, what we are recommending now. Earlier, we were having lower doses, but now recommendations are up to 2,000 per day. And particularly doing these weight-bearing exercises are very important. And early diagnosis is very, very important. Earlier, we discussed the BMD, but many a times BMD is fallacious. And most of the fractures are occurring in patients who are having a BMD of less than minus 2.5. So you should know that how to identify these patients. And for that, we are sometimes going for TBS, that is trabecular bone scoring. And that is again a software which is attached to these BMD machines, and they take out this TBS score, which is again very helpful, because trabecular bone is the bone which is very rapidly destroyed, or you can say damaged in osteoporosis. So we have to look into that aspect also. And of course, then we have large number of drugs which are for the treatment of osteoporosis, right from anti-resorptive to anabolic, and now we are having sequential therapy, and now there is a concept of combining many of these very good drugs for the treatment of osteoporosis. Thank you.
Sir, have you seen any patients with the magnesium deficiency, lot of magnesium deficiency along with the moving on towards osteoporosis, or the combination being there?
Not very common. Magnesium deficiency is not that common, but of course, magnesium deficiency leads to decrease in parathyroid hormone, and parathyroid hormone is a dual sword. You know that it is a bone healthy hormone, but if it is present in excess continuously, then it is causing more osteoporosis. So magnesium may lead to parathyroid hormone deficiency, and then
hypoparathyroidism, we need to be very cautious in these patients for osteoporosis.
Absolutely.
Moving on ahead, Dr. Rajiv, as it is sir has briefly explained, role of bisphosphonates, all the different types of bisphosphonates, and which drug for which patient would you like to give? And then I would like from Dr. Sharma also to please.
I was going to say, when you have Dr. Sharma, why do you need Rajiv to answer this question? But then again, I can just briefly sort of tell you that what we use as orthopedic surgeons, basically alendronate, risendronate, and then if you want to sort of space it out, then you give monthly doses. You have idrophos, and then you have that is called ibandronate. If you want to give a yearly injection, then it's zoledronic acid. That's what we normally go for. And I think they are all anti-resorptives. There's some recent literature to talk about them also being anabolic, but they're mostly anti-resorptive. And you can see there are many trade names for these. There are some in combination with vitamin D, and there are some which are isolated, given by themselves, whether they're given daily, weekly, or they're given once in a month.
Zoledronate, we give it normally yearly once.
Yeah.
If I'm not.
Or they're given once in 3 months as an injectable format, or they're given once in
3 years.
Injectable infusion. So Dr. Sharma could perhaps go ahead.
Yeah. The denosumab is a new drug, which is again a anti-resorptive, which is given 6 monthly. So it is a good drug. It causes significant improvement in bone and mineral density. And The problem with the denosumab is that once you stop this drug, there is a rapid fall in again BMD. That is the problem. So that's why people are now asking for sequential therapy. So if you are giving denosumab after, let's say, 3 or 4 or 5 years of denosumab, you can now give them anti-resorptive like alendronate or risedronate or zoledronic acid. The important point about zoledronic acid is that many of our patients are not tolerating these oral preparations. They may have esophagitis, etc., and they usually forget. And this is a long-term treatment. That's why zoledronic acid once a year is a very, very effective way of treating these patients. Now we are having this anabolic steroids like teriparatide. Abaloparatide is not available in India, and romosozumab is a dual. It is anti-resorptive as well as anabolic. But again, there are some concerns that there is some problem with you can say more of cardiovascular, but it is signals only, but it is not available in India. So we have teriparatide, and it is a good drug. It is a anabolic, so that's why it increases significantly. All those patients who are having significant low BMD and those who have already suffered fractures, probably a 2-year course of teriparatide followed by like denosumab or other and this alendronate or risedronate are very, very useful in our patients.
Basically, it is the side effects what with bisphosphonates what we see more of often, that is gastro GI side effects which the patients don't tolerate for, and they leave.
I have to leave, ma'am, because I have to catch a flight. So I will leave from this. Thank you.
Thank you. Thank you, Dr. Shah.
Dr. Meeta, any word about role of SERMs, if you would like to address to that?
Yeah, so like you put it on the slide, that is selective estrogen receptor modulators. And in India, we only have the raloxifene and we don't have the bezidoxifene as of now. And unfortunately, raloxifene cannot be given if a woman has hot flushes. So that is the, especially in the early part of the menopause. Otherwise, it's actually very great for women who are at a high risk of cancers, breast cancer, when we cannot be giving the traditional hormone therapy. In fact, when the Reddy Labs had brought in raloxifene into India years ago, maybe about 10, 15 years ago, I was part of the trial on raloxifene, and it really works very well. Now, for the osteoporosis, all the bone markers respond well, the BMD increased, and even the lipid profile actually increases. It's beneficial. The only place is it can precipitate hot flushes. And the bezidoxifene is a newer version which does very well, but we need to wait for it to come to India, where it actually looks after the vasomotor as well as the bone.
Bezidoxifene actually, it's there in combination with the Premarin also, conjugated equine.
Yes. And so it works for both. And also they say that bezidoxifene probably, again, like raloxifene, reduces the incidence of breast cancer. So they are also placing it as a prophylactic therapy for breast cancer, just like raloxifene.
Yeah. Moving on to the last question of my panel. That is the newer therapies. I would like anybody to answer, Dr. Meeta or Dr. Rajiv. Dr. Sharma has already left.
Yes.
So Dr. Sharma actually mentioned denosumab, and you have put it up on the slide here as well. Denosumab is something we normally give after we've tried our 2-year of teriparatide therapy, and we want to continue the anti-osteoporotic treatment for a while, because the anabolic effect starts wearing off very quickly in a postmenopausal woman. So 6-monthly injection of 60 milligrams subcutaneously but you cannot stop them, because you stop them and again it reduces the bone mineral density, reduces suddenly. So you need to supplement them back with some bisphosphonates. And of course, these other anti-resorptive sclerostin inhibitor, which Dr. Sharma also mentioned, romosozumab, is not available in our country, but it's a combined anti-resorptive plus an anabolic. Supposedly, the next thing that perhaps will continue once denosumab cannot be given. Calcitonin per se is only for bone pains, we don't really give it as an anti-osteoporotic treatment. So patients who have, for example, osteoporotic vertebral fractures and they have severe back pains, they're not going for surgery, they're not having vertebroplasty or kyphoplasty done. For them, we give them calcitonin for reducing the pain, nothing else.
Calcitonin sprays are given only for a shorter duration, if I understand, and not for a long time.
Yeah, that's right. It's only given for pain relief. It's not really going to change your bone mineral density.
And it comes as a nasal spray, so no oral medication. I think
it's not oral. It can be given either intranasally or intravenously.
Yeah.
It is carcinogenic also. For that reason also, it was not advised to be given for a long time. There are few drugs which have been withdrawn from the market, that is odanocatab, which had an increased risk of cardiovascular events and especially stroke. Salmotin, the calcitonin, which has been withdrawn, and serotonin again is due to its liver inflammation and reduced RBCs. It has been. There are various emerging therapies which are there in line, which are going to come down. And anything else which my dedicated panelists would like to tell about it? Dr. Parikshit or anybody from my panel?
I think the important messages have really been put across, that we need to build awareness, not only amongst the population, but amongst gynecologists and all other specialties. Let's look at it broadly. Let's screen more women, and let's keep the core of the issue right where it's supposed to be, a healthy lifestyle. That's what is going to be the answer in the long term, probably. And of course, we have various therapies, including hormones, which can be used when the problem sets in. So I think, yes, Dr. Thukral would like
to add, I mean, since you as gynecologists actually see patients in the younger age group, it is, I think, incumbent upon you to actually educate your patients, especially the young pregnant women or who are still in the young age group, who can build their bone mass to have a healthy lifestyle, because they eventually come to us, and the next generation that is coming to us is actually in a pretty bad state. So we will see the older people with fractures, but we are seeing them now younger and younger, but you can see them at a much younger age, and you can ensure that they don't come to us.
They should build up their peak bone mass to the full capacity. That's very important, so that they enter menopause with the healthy bones.
Absolutely.
Absolutely.
I think probably we should close this session. And again, I must thank Rakhi for doing a wonderful job with the material. And thanks to the organizing team, the scientific committee, for their invitation. And a pleasure to be with all of you today. Thank you.
Thank you. Thank you so much. Thank you. Thank you, Rakhi.
Thank you. What great could be, we were having such a multidisciplinary panel on such an important topic and discussed by so esteemed faculty of various specialities. So I really congratulate the moderators, Dr. Parikshit sir and Dr. Rakhi ma'am, for wonderfully conducting the panel discussion, and all the panelists to be the part of the same. Now, I call upon Dr. Meenu for the inaugural session. Dr. Meenu, please. We are all very well aware of Dr.
Dipti, I think we can skip this. Yeah, thank you so much.
Forward the proceedings.
And just for the benefits of the delegates, before we proceed on, it's our great privilege to announce that this particular seminar on the Orchestra of Hormones has been awarded the 4 ICOG credit points. Now, as we move for the inauguration ceremony, foremost, I would like to call upon Dr. Basab Mukherjee, our Vice President Foxy, to please come and give the welcome address.
Thank you, Dr. Meenu. Thank you. Very short welcome address. I think we were looking forward for this program, along with the other academic programs, which under the inspiration and under the leadership of Dr. Shanta, we have rolled out over the last 6 months. So Orchestra of Hormones, or Hormonal endocrinology in some form was the basic idea before Rakhi came up with Orchestra of Hormones, this name. And Dr. Rakhi and Dr. Varsha were the chairpersons who were allotted this seminar to do. We can see that she's done a wonderful job, involved different subspecialties, and got a discussion which has been rolling on from the morning, which is of immense academic value to everybody who's listening here. I want to congratulate her and everybody who's in the organizing and the build up to this academic event, just one more of the so many that we've seen in this year. Also take an opportunity to thank our MOCs for the afternoon, Dr. Minu, Dr. Deepti, Dr. Anshu, who have done a wonderful job and will do it till the end of the program. And I think we should go on with the other part of the inauguration. Thank you.
Thank you so much, Dr. Basar. I would now like to invite the dignitaries to the dais for the invocation and the lamp lighting. Foremost, President Foxy, Dr. Shanta Kumari ma'am. Our chief guests for today, Dr. Raymond Lee, who's the chair and the Reproductive Endocrinology and Infertility Committee, AOFOG. Dr. Kamal Bakshi, our past president, Foxy. The Secretary General of Foxy, Dr. Madhuri Patel. Foxy representative to AOFOG, Dr. Krishnendu Gupta. Vice President EMOGS, Dr. Ame Purandre. The Vice President Foxy, Dr. Basap Mukherjee, Dr. Bipin Pandit, Dr. Fessy Lewis, Dr. Kavita Bapat, Dr. Archana Verma, past President Foxy, Dr. Nandita Palshetkar, Deputy Secretary General Foxy, Dr. Suvarna Khandelkar, Treasurer Foxy, Dr. Parikshit Tank, Joint Treasurer Foxy, Dr. Niranjan Chauhan, Joint Secretary Foxy, Dr. Aruna Suman, Endocrinology Chairperson, Dr. Rakhi Singh, International Academic Exchange Committee Chairperson, Dr. Varsha Basti. Let's all proceed for the lamp lighting. Can we have the presidential team video also, please?
I think we are running late. Why don't we skip this?
Dear friends, Foxians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of Foxy, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world. Just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Foxy's commitment towards women's healthcare. Foxy for all, always.
Foxy for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dhira to stop violence against women. Foxy for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme Foxy for all always and Dhira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy and also especially support her campaign, Dhira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the president of Foxy, declare my commitment towards women's health and safety.
I would now request Dr. Basab Mukherjee to please introduce Dr. Shanta Kumari ma'am for the presidential address.
Dr. Meenu, I think this is our program. I don't need any introduction. And shall we?
Sure.
I think this has been a wonderful program. I have to really congratulate the whole team. Dr. Rakhi Singh, Dr. Basab, and the whole team of Endocrinology Committee. This whole program has been very beautifully structured, and I would like to appreciate and welcome Professor Raymond Lee for taking time off to be with us today, sir. Welcome to India and Foxy. We would have loved to have you in person, but nevertheless, I am happy that you are able to join us virtually. So I take this opportunity on behalf of my whole team of Foxy, my Secretary General, Dr. Madhuri Patel, Deputy Dr. Suvarna Kadilkar, Treasurers Parikshit and Niranjan, and my whole team of Vice President, Archana, Basab, Bipin, sir, Fessy Lewis, and Kavita Bapat. Aruna Sumana, Joint Secretary. Everyone extends their whole heartfelt welcome to all of you for being with us today. And I have to thank Professor Krishnendu Gupta, our own AOFOG representative, for actually orchestrating the entry of Professor Raymond Lee into this program. Thank you very much. And I know it's because of you, the team is here. And this is a wonderful way where Foxy and AOFOC and the other organizations can actually have a dialogue to exchange ideas, to exchange knowledge, and I think become partners in patient care. And though COVID has kept us apart over this past 2 years, I'm sure things are going to change and we will be able to meet each other soon. Today there were some very good lectures, especially the lecture on Hirsutism Dr. Nandita Palshetkar had given. It was such an important and very, very, I think it touched the core of the clinical practice. There are so many girls and young women who actually come to gynecologists for management of hirsutism. And it is extremely important for us to actually be able to manage that. And I have to specially invite and give my respects and regards to our own chief guest, Professor Kamal Bakshi Madam, our past president of FOXI. Madam, we are very, very happy and glad that you have joined us. In fact, when before the inauguration was starting, I couldn't see you, so I was calling your number. And then suddenly I saw your face and I switched off the mobile. So thank you very much for being here. I have to really put on record. We've got some fantastic senior professors, past presidents of FOXI, past presidents of local societies. But what I have observed in the 6 months is, when it comes to knowledge sharing, when it comes to academic exchange, who I am finding at the forefront? It is all the seniors of FOXI. It's the seniors, be it online, be it offline, even in COVID time. We just had one hybrid meeting in Kolkata last month, in November. And what I found there also was, there were so many past presidents of Bengal OB-GYN societies. They were all seniors, mind you, but they took the pain to be there in the program. And that shows the commitment of FOXians. I only wish that all the juniors also learn from seniors, because it's so very important and vital that we actually meet, exchange ideas, and along with the time we spend in practice and in other aspects of life. I think this is so very important, which we should learn from our seniors, and never lose an opportunity when you can gain something new through academic exchange, and either as a delegate or as a faculty or an observer. I think that's so very important. And I hope that 2021 end will also be the end of this era of maskings and staying away. Let's look forward to a fresh 2022 after Christmas, and Happy New Year. Let's look forward for a new beginning. And I really am looking forward to see all of you at AICOG Indore, which is going to be a physical congress from the 9th to 13th of January. The whole team of Indore and Madhya Pradesh are very eagerly awaiting the presence of all our FOXians. The only point I would like to reiterate is, I'm sure most of our FOXians are already vaccinated, and those who are eligible for the booster dose, kindly do take your booster dose, because now some sort of directive has come. Look into it, get your booster dose, and those who have not had the shot, I would request you to please get your vaccine shot, because it's quite mandatory that we allow people with mask and vaccination physically at AICOG Indore. So I'm sure the whole team joins me in congratulating the whole team. Rakhi, good job, very well done, and keep up the good work. I only hope that all the committee chairpersons now start gearing up to doing some physical activities, be with the societies, do some activities which will make FOXI a stronger body. Work with the societies. Please work with the society. We have got 262 societies. We've got A, B, and C. Who need your input and help are the B and C societies. And reach out to those societies which have not been active, so that you can make them more active, and that will definitely bring them into the loop. So thank you very much, Professor Raymond Lee, for joining us again. Thank you very much.
Thank you. Yeah.
Thank you so much, ma'am, for your golden words. I would now request Dr. Rakhi Singh to please introduce our chief guest, Dr. Raymond Lee, for his address.
As it is in the early morning session, we've heard Dr. Raymond Lee, the chief guest, speaking on a lovely talk on a keynote. And then we have got him as a chief guest right now. To introduce him, he is a clinical associate professor in the Department of Obs and Gynae, University of Hong Kong. He is honorary consultant at Queen Mary Hospital, and Wong Hwa Hospital, Hong Kong, Honorary Medical Consultant, Family Planning Association of Hong Kong, Chair of Reproductive Endocrinology and Infertility Committee, Asia Oceanic Federation of Obs and Gynae, that is AOFOG, and clinical research interest and reproductive endocrinology and subfertility in the family planning. I welcome you, sir. Can we have your words as a chief guest?
So, hello, can you hear me?
Yes.
Yes.
Okay. Dear Dr. Shanta Kumari, Dr. Kamal Bakshi, ladies and gentlemen, this is my great pleasure and honor to be invited to take part in this very wonderful conference named Orchestra of Hormones, Endocrine, Our Lifeline, organized by FOXI. Many thanks to Professor Krishandu Gupta for bringing me to India, although virtually, and be part of this inauguration ceremony, together with our highly respectable Dr. Kamal Bakshi. On behalf of my own self, and as well as the Asia and Oceanic Federation of Obstetrics and Gynecology, the AOFOG, I would like to extend a very warm wish to all of you for a very successful and fruitful meeting. Being a reproductive endocrinologist myself, the theme of this meeting is close to my heart. Indeed, hormones play a very key role in women's health and reproductive function, impacting health of all women from young girls to the elderly. Endocrine investigations and treatment is widely utilized for various gynecological and pregnancy-related conditions. Hence, a sound knowledge about hormones is essential to every obstetrician and gynecologist. I am delighted to see this wonderful program being put up, covering a wide variety of topics centered around reproductive endocrinology, from common endocrine conditions that affect pregnant women like gestational diabetes mellitus and thyroid problems, to various anovulatory disorders, hirsutism, bone health, interplay between reproductive and metabolic health, to the use of hormone therapy. I'm sure all of you in the audience will benefit a lot from these lectures as much as I do, and apply the knowledge to our daily clinical practice. It is a pity that the COVID pandemic has prevented us from getting together face-to-face and enjoy more social networking and interactions in the meeting, as pointed out by our president. Fortunately, the online meeting platform has enabled us to continue our medical education and knowledge exchange in an equally, if not more, effective manner. I wish all of you will enjoy the rest of today's fantastic program. And like all of you in the audience, I hope we shall overcome the COVID pandemic and return to our usual track very soon. I wish you all stay healthy and well. Thank you very much.
Thank you so much, Professor Dr. Raymond Lee, sir, for these kind words. And now I would request Dr. Aruna Suman ma'am to please introduce our next chief guest, Dr. Kamal Bakshi ma'am.
It's my privilege and honor to introduce Professor Kamal Bakshi madam. She's former professor, HOD, Obstetrics Gynecology, AIMS, New Delhi, India, senior consultant, Indraprastha Apollo Hospital and Fortis La Femme, emeritus professor, National Academy of Medical Sciences, NAMS, first time World and India US guided fetal skin biopsy in 1988, intrauterine fetal blood transfusion 1986, uterine balloon therapy in India, started the Department of Fetal Medicine at AIMS, Dr. B.C. Roy National Award for Eminent Medical Teacher, Lifetime Achievement Award FOXI and AOGD, Bharat Jyoti Award, Indo-Norwegian Scientist Award, a living legend title given by International Journal of Gynec Plastic Surgery, Kamal Bakshi Oration, instituted in recognition of pioneering work in fetal medicine, former President FOXI and Indian Society of Perinatology and Reproductive Biology, and she has got more than 250 national and international journals on her name. Thank you, ma'am, and I welcome you to give your address.
Thank you very much. First of all, I wish to congratulate each and every member. Today, it was a real orchestra as far as endocrinology was concerned. I'm very thankful to Professor Shanta Kumari, our dear president. What a dynamic president. Being a woman, she understands the problem of the woman. And she's a woman in a real sense, How lovely she always at every point says, no violence against women, If women are mentally tortured, depressed, how will they bring up their families? How will they look after everybody? So I really love Dr. Shanta Kumari for your vision and for your dynamic 24/7 involvement. The twinkling star of today and the twinkling star as far as the orchestra is concerned, our young star, Dr. Rakhi from Noida. I must say, I wish to congratulate you for a wonderful feast that you gave us of academic. We yet have to have a feast like this. And Dr. Rahman, I really fell in love, the way you spoke, I felt. I wish every endocrinologist could speak or give a talk which pierced not only every molecule or cell of the body. I fell in love with endocrinology because of my patients, And my message is to the youngsters, When one of the young girls of the Hirsutism, she came to my office and says, ma'am, I want to commit suicide. I said, why? She says, I am a ballet dancer. And the young people are so charming. They're dancing with the youth, And here I have these ugly hair. So I made her sit in my office. I said, don't worry. And she gave me one advice that your endocrine OPD is with all the women. I would like you, ma'am, to have the endocrinology OPD for the young adolescent girls separately and not with everybody. And that is where I started with the Hirsutism. We graded the Indian women and then wanted to study what the cause was. Studied as far as the mothers are concerned, the husbands are concerned, it was from both sides. And in utero to know, because I had to treat 2 to 3 generations as far as Hirsutism was concerned. So we went into the depth of it, Then the treatment, we started oral contraceptives, therapy. And then we started cimetidine. And then the chemist wouldn't give medicine. They would say, wow, this is only for as far as the GI upset is concerned. And then I started spironolactone, again, the first one to start as far as India. It was only because of the love of the patient. Now, this endocrinology and genetics and environment, I tell you, they all go together. And we must see that this pollution doesn't occur. With due apologies, that so much of advertisement that is there, that we are having the plastic, we are having the unnecessary things. And I must congratulate Dr. Jaideep Kang, who said so beautifully that our culture, wash your hands, be clean, eat the organic food. And what beautiful our president says, learn from the seniors, And that is where we learn from our teachers that you love your patient, and it is the love of our patient that we must do research, We should not be the copycat. We should be the one to see how to advance the science forward, to love each our colleague, to go as a deep scientist. And it is not you and me, it is we, the whole global world together. And I just would say one thing, a short, once my younger daughter, she wrote a poem and she says, that was the time when there was about the Hiroshima and all. She says, Mom, where will the candies be if there is a war? So let's be all friends together, live together, learn for the nature and admire. And thank you all for giving me the time to say my heart and to express my sincere gratitude and thanks to each and one of you. Namaskar. Thank you. Could you hear me?
Yes, ma'am. What a dil se address what you have given, ma'am. Thank you for that passionate address.
Thank you, Madam Kamal Bakshi, Madam, for joining us. And it was a real pleasure to meet you in Delhi last month.
It is always a treat to meet you. Even at Hyderabad, I tell you, you must have killed many hearts, but I am one of them.
Thank you.
Dr. Anshu, over to you.
Hi, it's good afternoon, everyone, all my respected seniors and all dignitaries. Now it's my pleasure to invite our dynamic First Lady Deputy Secretary General FOXI, Dr. Madhuri Patel, ma'am, to please give a vote of thanks. Please, ma'am.
I can't see Madhuri Patel, our Secretary General. I think she's busy with the MOGS Physical Congress, which is happening. I think Rakhi can give the vote of thanks.
We are thankful to Dr. Shanta Kumari, Madam, for the dynamic president of FOXI, for giving us the opportunity to do this program, Orchestra of Hormones, along with the International Academic Exchange Committee, Dr. Varsha Baste. And we are thankful to all the office bearers of FOXI, the chief guest for the day, Dr. Raymond Lee, for taking out his valuable time for being there with us, and Dr. Kamal Bakshi, ma'am, who is the teacher par excellence for me. And I've been growing in Noida looking at her. And then thank you, madam, for being there as a chief guest, taking out your valuable time. And I thank all the office bearers of FOXI, all the vice presidents of FOXI, and Aruna Suman for entirely working with me hand in hand. And thank you, the academic partners, MITI, and thank you one and all for being there for us. And handing over the session to you, Meenu, for the next session.
Dr. Anshu, to carry on.
Thank you, respected seniors, dignitaries, colleagues, and my friends for your valuable and gracious presence in the inaugural ceremony of Orchestra of Hormones. Now, I would like to start our next session, session 6. For this, I would like to invite our chairperson, Dr. Varsha Baste, ma'am. Ma'am was here. So, ma'am is a practicing gynecologist in Nashik since 30 years and director Pushpa Fertility Center 18 years. And she CEO and the founder of the Cell Gender Anti-Aging Center, first adult stem cell therapy center in Western India, and the first ICSI-PZD baby in the North Maharashtra 2003, and the past president of OBGY Society Nashik, and chairperson FOXI IIGC 2019-21, and is a prestigious Dr. Anand Bhai Joshi awardee. So ma'am, please start the session with our first talk of Dr. Madhuri Patel, ma'am.
Can we have the CV of Dr. Madhuri, ma'am?
Can't see Madhuri has joined, Rakhi. Just
no, ma'am, it is there. The talk is there, ma'am. Can we have the CV of Dr. Madhuri, ma'am?
It's a recorded talk.
Can you please, Madhuri ma'am slides? Yes. So Madhuri ma'am needs no introduction at all. Ma'am is a Secretary General FOXI and the Joint Secretary FOXI 2009 and the former committee member FIGO preterm birth. So now I just wanted that technical partner team to please
continue over it. Can we have her talk, please?
Respected Chairperson, my seniors and juniors, very good afternoon to all of you. At the outset, I would like to thank Dr. Shanta Kumari, President Foxy, Dr. Basab Mukherjee, Dr. Bipin Pandit, Vice President Foxy, Dr. Krishnendu Gupta, Dr. Rakhi Singh, Dr. Varsha Basse, and Dr. Amay Puradure for giving me this opportunity. Today, I am going to talk about obesity in obstetrics, problems of plateau. 21st century has been an epidemic of obesity and other lifestyle diseases. During the same lifetime span, remarkable progress in infertility management occurred, resulting into more and more obese women getting pregnant. Maternal obesity is associated with adverse maternal and fetal outcomes, and therefore it is a high-risk pregnancy. It is also associated with significant adverse long-term effect on both obese mothers as well as infants. The prevalence has been doubled in the last 3 decades. In US, 2/3 of the women of childbearing age are obese or overweight. In India, there is an increased incidence of obesity from 11 to 15% in 2005 to 2006 as per National Family Health Survey 3 and further to 20.6% in 2015-16 as per NFHS 4. The obesity is a multifactorial condition in which environmental, biological, and genetic factors all play essential roles. So body mass index is defined as equal to weight in kg by height in square meter. The obesity is patient is labeled as obese when the BMI is more than 30 per kg square meter, and then it is divided into class 1, 2, 3, and super obesity is more than 50 kg per square meter. In India, we come across both the nutrition extremes. Undernutrition is more prevalent in rural areas, whereas obesity is 3 times higher in urban area. In extreme degree of obesity, anovulation, amenorrhea, and infertility are highly prevalent. However, because of the advanced infertility treatment, such women are getting pregnant, and it is giving obstetrician on new challenges. Bariatric surgery has also added issues in management of such pregnant obese women. There are potential issues in pregnancy, that is antepartum, intrapartum, and postpartum, and of course in offspring. A systemic review and meta-analysis by Molinex et al. Have reported there are high chances of depression and anxiety. GDM increases by 0.82% with each 1 kg per square meter increase in BMI. Preeclampsia doubles the risk with each increase in 5 to 7 kg per square meter in BMI, and there is prolonged pregnancy. The other antenatal problems are early pregnancy loss, multiple pregnancies, obstructive sleep apnea, and carpal tunnel syndrome. It has been reported in general population the carpal tunnel syndrome occurs only in 4% of patients, but in obese women it is more than 40%. So there are intrapartum problem in form of first and second stages of labor are prolonged. There is early maternal exhaustion and poor bearing down, efforts lead to increased incidence of instrumental deliveries. There is mechanical problems in head delivery may be occurred due to soft tissue obstruction, malposition, and macrosomia. Ultrasonography facility is a must in labor ward to deal with these obese women because the clinical palpation becomes difficult with these obese women. There is labor dystocia, and the reason may be in passage, passenger, and power. In passage, the soft tissue obstruction theory implies difficulty in late labor. By contrast, clinical studies have revealed that these obese women have slowest part of labor from 4 to 6 centimeter of dilatation of cervix. Now, there is a fault with passenger in these women. The obese women are more likely to have a large babies. Clinical studies reveal that higher fetal weight does not increase in incidence of labor dystocia when GDM is under control. So one has to keep GDM under control. Then there is a power. The obese women's myometric cells contracts with less efficiently compared to normal weight women. Adipose tissues produces cytokines, chemokines, and adipokine. Adipokines like leptin, adiponectin, and schispeptin are possibly responsible for GDM and preeclampsia in obese pregnant women. Myometrial contractility is affected by cytokines and inflammatory processes, which brings about changes in pregnancy and the gestational age. Leptin is elevated in obese women, which is produced by fat cells and also by placenta. It disrupts the contractility in uterus as well as is also obstructs the cervical lining. Cholesterol is also elevated in obese women, which disrupts the contractility in uterus, and therefore there is decreased oxytocin receptors and connection 43 connection between myocyte, contributing to labor dystocia and postpartum hemorrhage. In prospective induction of labor trial in 509 women controlled for ADM, Pitocin infusion standardized protocol reported these women, obese women, require a higher dose of Pitocin compared to normal weight women, and they had more labor dystocia, resulting into unplanned cesarean. Wolf et al. Reported the failure rate of cervical wrapping with prostaglandin was higher in obese women, that is 54.7%, compared to normal weight women, that is 34.5%. The LSAS rate was twice the normal. Every 10 kg rise in body weight, there was 17% increase in LSAS rate. There were technical problems in administration of spinal, general, epidural anesthesia, and analgesia. Delivery of the baby was difficult as there is microscomia, thick abdominal wall, malpresentation, poor exposure, and difficulty of cesarean also difficult. Increase in postoperative thromboembolic complications were observed, and postpartum recovery to pre-pregnancy stage was difficult. During postpartum period, it has been reported fourfold increase in atomic PPH, increase in lactational failure, increase in venous thromboembolism, increase in infection, increase in postpartum depression, and one has to adjust the dosage of drug according to body weight. In 2018, Hernandez et al. In their study from 1999 to 2012, that is almost 14 years, reported relative ratio of maternal death showed a rising trend with severity of the obesity, that is from a 2.8-fold increase for class 1 to 7-fold increase for class 3 compared with women with normal weight women. So there are the potential issues in upstream. There were multiple studies this reported. There is increased risk of congenital anomalies, especially neural tube defect, 2 to 3-fold increase in macrosomia, 2-fold risk of IUFD in late third trimester, up to 2.24 increase in spontaneous extremely preterm delivery, and up to 2.74 increased risk of induced preterm delivery. And of course, there is a lifetime risk of diabetes mellitus, heart disease, and obesity. The other issues were infant death, which was 2 to 4 times higher compared to normal weight women, asthma, and neurodevelopmental problem. So patient is going to come to us during the pre-pregnancy stage. or during the pregnancy stage, and we have to deal with them effectively. During the preconception phase, effective counseling and the evaluation is required. Inform the patient and the relative that obesity may give rise problem for conception, and in case she conceives, she will be having more complication with the associated with obesity. Then also evaluate the comorbidity associated with obesity. Counsel about the benefit of weight loss by diet, exercise, behavior modification, and bring down BMI at least less than 30. And explain them about the role of pediatric surgery. And 5 milligram folic acid per day, 1 month prior for planning pregnancy to be started. It has been reported that preconception BMI was directly linked to the comorbid condition like gestational diabetes mellitus, hypertensive disorders, and higher C-section rate. When the patient comes during pregnancy in first trimester, height, weight, and calculate BMI at first visit. Ultrasonography for the first trimester to confirm this is necessary because they have ovulatory dysfunction and you cannot calculate LMP, expected age of delivery by LMP. Aneuploidy screening in first trimester should be done, and one must screen for depression and anxiety because they are patients who suffer. The incidence is high of depression and anxiety. Screening for hypertension, DM, and non-alcoholic fatty liver disease with baseline lab tests along with routine lab tests are recommended. If there is a history of bariatric surgery, evaluation for and treat nutritional deficiency, and refer all such patients to higher center where all the facilities are available. So one has to stress upon the diet, exercise, and tell them the gestational weight gain should not exceed more than 1200 to 1500 kilocalories per day and review them frequently. A randomized controlled trial of 425 obese pregnant women compared with outcome in women under standard nutritional and physical activity and with women with special care like physical activity of 11,000 step count and dietary restriction to 1200 to 1500 kilocalories per day concluded that there was no rise in intrauterine growth retardation in women under special care and weight control of women was better. So how much the weight gain should be? Usually in the first trimester, patient has nausea, vomiting, loss of appetite, so they don't put on weight. But at the second and third trimester, they put on weight, so it should not exceed 9 kg throughout the pregnancy. That means the weight gain should not be more than 0.2 kg per week from second trimester onwards. During second trimester, anomaly scan as 18 to 20 weeks is done, and fetal echocardiography is undertaken routinely if the BMI is more than 40 kg per square meter. Detailed anomaly scan of the heart may not be optimal. In such patient also, the 2D echo is recommended. Quadruple marker is optional if the dual marker is done. Screening for gestation diabetes at 24 to 28 weeks of gestation as well as 32 weeks of gestation should be done. The thrombophlebotomy is recommended of 150 milligram aspirin should be started for all women with BMI more than 35 kg per square meter, multiple pregnancy, and women above 40 years. This will also help in preventing PIH. Low molecular weight hyperinsulinism is an individualized decision. So during third trimester, frequent maternal assessment should be done, frequent visit during third trimester. One should give psychological support and prepare the patient, obese women, pregnant women, for successful lactation. She requires early hospitalization in case there are early signs of PIH, uncontrolled diabetes, GDM, etc. It is equally important to do fetal assessment and well-being during third trimester frequently. The frequency of fetal demise increases in pregnancies of obese women. Therefore, clinical assessment along with ultrasound assessment, antenatal fetal surveillance with modified biophysical profile, NST, SOS color Doppler are indicated. Elective induction of labor at 40 weeks is recommended in view of high rate of postdatism, GDM, macrosomia to reduce the risk of stillbirth and birth trauma. During labor and delivery, a comfortable position with the left lateral tilt is given, adequate oxygenation is maintained. If possible, if available, electronic fetal monitoring should be used, and sonography is very useful to monitor the progress of labor. Use forceps or vacuum to pursue the second stage of labor. Shoulder dystocia is very common in macroscopic babies. Hence, one should make the experienced obstetrician available, and active management of third stage should be done in all these patients because there are high incidence of postpartum hemorrhage in form of 10 units of oxytocin intramuscularly immediately after delivery of the baby. In a systemic review of 8 studies reported that the obese women had more intrapartum intervention compared to normal BMI, which included early hospital admission, induction of labor, AROM, augmentation of labor, epidural, and unplanned C-section. It has been reported that when by Walsh and Follis in their prospective observation study with active management labor protocol of 2,143 nulliparous term women with spontaneous labor reported that obese women had significantly failed with oxytocin augmentation requiring C-section for dystocia compared to normal weight women. The majority of these cesarean sections, they occur as an emergency due to labor dystocia. A combined epidural spinal anesthesia with due risk is recommended due to prolonged operative time. You can modify the surgical technique depending upon your experience. Achieve the hemostasis promptly. Use of pneumatic compression devices at the time of cesarean delivery post-op recommended to reduce the thromboembolic phenomena. Individualized use of thromboprophylaxis and of course, prophylactic antibiotics should be given. So there are more complications during cesarean, and it has been reported by Flagel et al. that 1/3 of the maternal deaths associated were due to obesity complication, and majority of them were following C-section. Recently, we are facing the challenges the patient with pediatric surgery because several complications may occur during pregnancy like persistent vomiting, gastrointestinal bleeding, anemia, micronutrient deficiency, placental vascular disease, fetal neural tube defect, fetal growth retardation, and abortion. Pregnancy and delivery should be under combined care by the pediatric surgeon, physician, and expert obstetrician in a high center. Cesarean delivery rate have been reported to have been increased in cases of previous history of pediatric surgery. But remember, pediatric surgery is not the indication for C-section. The immediate postpartum problems, as we have said, there is increased risk of atonic PPH, thromboembolic phenomena. That's why they recommend to start prophylaxis, treatment at least 1 week in class 3 obese women. There is delayed lactogenesis, more than 60 to 72 hours, reduced lactation, duration of lactation, and postpartum depression and anxiety. These multiple studies also reported long-term, problems like postpartum depression and anxiety. They require to decrease the weight, and therefore lifestyle changes and dietary changes are very important. Tests for DM at 6 to 12 weeks, follow-up for hypertension, and referral for the weight reduction to weight reduction specialists, endocrinologists, etc. So to conclude, obesity in obstetrics, problem of plenty, is a global challenge not only to the obstetrician but also policymakers. Pregnancy after bariatric surgery is even more challenging. expert nutritionist supervision following recommended exercise schedule, prevention and control of metabolic diseases essential. A well-planned pregnancy after reduction in weight to ideal BMI range, appropriate counseling, careful vigilance during pregnancy and labor, especially at high center, will go a long way to minimize and overcome anticipated obstacles and difficulties. I thank all of you for the patience here.
So now, after an excellent talk by Dr. Madhuri Patel, ma'am, now I would like to invite our next chairperson, Dr. Vijaya Lakshmi Seshadri, ma'am, to please introduce our next speaker, Dr. Krishnendu Gupta, sir. Dr. Vijaya Lakshmi, ma'am, is a executive committee member of TNFOG, president of OGSSI, and Constitution Committee member of ISOPAP, member Practical Obstetrics Committee of FOXY, and the chairperson Research Committee IMS 2018-20. And ma'am's area of special interest in high-risk obstetrics and midlife health. So ma'am, please introduce our next speaker, Dr. Krishnendu Gupta, sir. Please.
Thank you. It's my earnest request to Vijay, my dear friend Vijay Lakshmi. Since
I will cut it short.
Please,
no,
please,
I know. I'll cut it short. There are too many introductions for you. I know.
Thank you.
I'm really honored to be here chairing and in the session where Professor Krishnendu Gupta sir is there. And I would really congratulate the whole team of today's conference for choosing such a nice topic of galactoria, which I think is not very openly discussed in detail in most of the webinars. So I thank Rakhi for this opportunity. I thank Dr. Shanta Kumari for this very nice webinar opportunity. And Dr. Krishnendu Gupta, of course, is known all over. And he has been to me, as he has requested, I would cut it short. I know he has been the chairperson of ICOG. I know he was the vice president of FOXY, and has been awarded the fellow of the Royal College of the Obstetrics and Gynecology. Lots of merits to him, lots of credits to him, and he is presently the professor and unit head at the Department of Obstetrics and Gynecology at the Vivekananda Institute of Medical Sciences, Kolkata. So over to you, sir, for a very interesting topic, galactoria, and I know which you would be doing a great job, which I have always heard you speaking so clearly and so vociferously. Over to you, sir.
Thank you. It's a recorded talk because I was not sure whether I'll be able to log in today. So it's recorded and the talk will be played just now.
Yes, sir.
Thank you. But I'm there for any questions.
Okay.
Start, sir.
Good afternoon. At the outset, let me thank the organizers for giving me this opportunity to present before a very interesting topic called galactoria. And I'm going to take you through an evidence-based approach on how to deal with a patient with galactoria. But first, we'll ask ourselves a question. Does galactoria loosely refer to hyperprolactinemia? And for that, let's have a look at a publication done in a reputed journal of our country, where the heading shows as hyperprolactinemia with normal serum prolactin, its clinical significance. This is a case report of a 31-year-old para-1 living one, last childbirth of 8 years, complained of amenorrhea for 2 years, prior history of normal menstrual cycles. Breast examination, of course, showed some secretions from both the breasts, which is not noticed by her earlier, and pelvic examination was normal. In view of the amenorrhea and galactoria, she was advised serum prolactin and thyroid profile estimations and an ultrasound of the pelvis. Now, as you can see, prolactin levels were normal, which is euprolactinemic. Thyroid profile was also normal and a normal ultrasound study. But nevertheless, because of the breast secretion, she was advised cabergoline 0.5 milligrams once a week. She took this treatment for about 4 months and she continued to remain amenorrheic. Thereafter, discontinued treatment, and after a month, she bled a slight bit and thereafter presented with amenorrhea for 2 months. And lo and behold, she was pregnant. 7 weeks gestation, she had uneventful antenatal period and delivered a healthy baby. So basically, the discussion is isolated galactorrhea with normal menstrual cycles and normal prolactin levels. So this should not be hyperprolactinemia, but euprolactinemia has been estimated to occur in up to 20% of women at some point in their life. So this should be actually galactorrhea with normal serum prolactin, its clinical significance. And the issue is because of the heterogeneity of the prolactin molecule, which poses a challenging clinical issue with the gynecologists. So taking you through prolactin, some important facts. We all know it's a polypeptide hormone with 199 amino acids with a molecular weight of 23 kilodaltons. It's synthesized and by a pulsatile secretion from the anterior pituitary, from the cells known as the lactotropes. There are three types of prolactin: little, big, and big, big. And the little one has got the greater biological activity, and the unit of measurement is about 1 nanograms per mil, which corresponds to 20 milli international units per ml. The normal serum adult levels are about 5 to 27 nanograms per mils in females, and its highest secretory period during the rapid eye movement sleep, and the peak levels are between 4 to 6 or 5 to 7 a.m. And that is why it's very important that whenever you kind of request a patient to get a prolactin estimation, it should be preferably after 8:30 or 9 o'clock in the morning. And it can even go normal levels up to 30 nanograms per mils, and the circulating half-life is about 50 minutes. As discussed, it's synthesized and secreted from the lactotropes in the anterior pituitary. Hypothalamic dopamine inhibits prolactin secretion, and there are several hypothalamic releasing factors like the vasoactive intestinal polypeptide, thyrotropin-releasing hormone, and also estrogen, which also explains why pregnant women have elevated prolactin levels. It is impossible to go through the entire prolactin regulation in this presentation, but we all know the role of dopamine. So having discussed a confusing published case report, I'll take you through certain facts of galactorrhea, give you a brief overview about nipple discharge, the causes, evaluation, and evidence management of galactorrhea, some guidelines, and some issues for the postgraduates to kind of refer to, and end with some key points and summary. So it's a non-lactational milk production. So milk production after 1 year of pregnancy or cessation of breastfeeding is called as galactorrhea. It can be seen in nulliparous and postmenopausal women, and also sometimes in men. The incidence is variable, but can occur up to 90% of women with hyperprolactinemia, and that's why galactorrhea and hyperprolactinemia are very, very loosely interchanged, and that was my question right in the beginning. About 30% of women who present to their doctor for a breast examination have some sort of nipple discharge, and it can be also seen in 7 to 10% of all breast symptoms. It's classified as normal or abnormal depending on whether it's unilateral, bilateral, depending on the menstrual cycle, the quantity, color, or presentation, whether it's spontaneous or it's induced with some kind of medication, which I'll come to later on. The spontaneous or induced nipple discharge may be identified by either the patient accidentally or during a clinical examination, which happens sometimes suddenly while doing a mammography because of the pressure of the breast with the film. So there can be a kind of a discharge, and it can be categorized as normal, abnormal, or attributed to galactorrhea according to history and physical examination. So a nipple discharge is called to be normal, is said to be normal when it is non-spontaneous and is usually bilateral, serous, and originates in many ducts. Multiple duct discharges are rarely caused by cancer. I repeat, multiple duct discharges are rarely caused by cancer. In cases not related to breast pathology, like mechanical stimulation, thoracic trauma, and medications are sometimes included in the differential diagnosis of breast discharge. So sometimes what happens, the patient is very curious to keep checking, and there's continuous mechanical stimulation of the nipple, wherein she must be told that you must stop this mechanical stimulation, otherwise it will not, this kind of nipple discharge will not go away, and if you stop it, it sometimes goes away. And therefore they should be advised to stop and avoid checking themselves every now and then. Abnormal nipple discharge is one which is non-lactational, persistent, spontaneous, and unilateral, usually located in one duct, and as it is usually spontaneous, it may actually disappear. And it may be gray, green, serous, or bloody, and even if bloody, it is usually benign. So just because someone has a bloody discharge from the nipple, please do not say it's cancer, because it's associated with only about 1.2 to 15% malignancy. So it's important to counsel and reassure the patient that most likely things should be all right. So this is a kind of a picture showing, a kind of galactorrhea, kind of a serous discharge and a bloody discharge, and of course, greenish discharge, which you sometimes get in fibrocystic disease. So there are a whole lot of kind of, just by looking at the discharge, you can kind of decide what kind of a discharge it is, and whether it's, kind of, whether it's galactoria, or whether it's kind of, whether you can think of whether it can be cancerous or not, whether it's unilateral, bilateral, as I, discussed a little earlier. So galactoria is typically bilateral. It originates from many ducts, and the discharge is milky. And this is typical in pharmacological galactoria, and discontinuation of the medication will eliminate the finding. So when galactoria is accompanied by amenorrhea, it is usually caused by hyperprolactinemia. It's a very important point. So galactoria with amenorrhea is usually due to hyperprolactinemia. So, however, when a patient has normal ovulatory cycles and galactoria, the prolactin levels are usually normal, or the patient is euprolactinemic. So we classify galactoria into two types: hyperprolactinemic galactoria and normal or euprolactinemic galactoria. So whenever there's any excessive nipple stimulation, as I spoke to a little earlier, including during sex or suckling, can cause a hyperprolactinemia and galactoria both. In the neonatal period, it's something important to know that the high level of estrogen from the mother can cause transient galactoria in the newborn, which is also called as witch's milk, which can come as a short note, and you must know what it all stands about. And we all are aware that during pregnancy, especially in the third trimester, the levels can go up very high, so there can be some amount of galactoria as well. And other causes of transient galactoria could be vigorous exercise, physical stress, etc. I will not go through the causes of hyperprolactinemic galactoria because that's a class by itself. We know it could be either physiological or pathological. We know the stalk effect, the tumors, the pituitary lesions, the lesions involving chest wall, systemic disease. But which is most important, and we have to ask in the history, is medication-induced hyperprolactinemia. And if you see the list of medications which can actually cause galactoria, it is mind-boggling. And a lot of our patients keep looking into the internet and taking all sorts of these kind of non-hormonal medications, these herbs like anise, blessed thistle, fennel, fenugreek seed, marshmallow, nettle, red clover, red raspberry, etc. We can actually cause galactoria. So a history is very important. We are all aware about antidepressants, anxiolytics, some antihypertensives, etc. But what is also important for us to know that antipsychotic and GI promoting agents, they block the dopamine receptor on the pituitary lactotropes, thereby decreasing the normal inhibition of prolactin release and thereby causing hyperprolactinemia. So it's important for us that many illicit drugs and herbal supplements, in addition to the standard medication which we keep reading, can also cause galactoria. Just a slide on Chiari-Fromel syndrome, which we all know is a rare endocrine disorder that affects postpartum women and is characterized by galactoria, anovulation, and amenorrhea. Symptoms persist for long, more than 6 months postpartum, and it very rarely can actually result in uterine atrophy, but it can also resolve spontaneously, and hormone levels and reproductive function return to normal. So we know about idiopathic, hyperprolactinemia. No causes, sometimes found. Again, we have to follow them up. But, where there's really sometimes, very kind of irritating galactoria not going, we should, look at a CT scan, an MRI of the brain, and especially ask for very high-end CT scan with a 3 Tesla machine with 1 millimeter cellular cuts. Because if you don't get adequate cellular cuts of 1 millimeter, around 1 millimeter, if it's more than that, you may actually miss out on these very small microprolactinomas, which can be the cause for this so-called idiopathic hyperprolactinemia, which actually is not. And we have seen that many times when these old machines go to the districts, and the district brain, MRI pituitary comes as normal. Actually, when you use these high-end machines of 3 Tesla with 1 millimeter cellular cuts, you will actually pick up a prolactinoma, which was not there earlier. So when we talk about evaluation of galactoria, we can evaluate based on, we kind of distinguish them from pathological nipple discharge, which can involve breast tumors. We all know what is galactoria. It's bilateral, multiductal, it can be milky, it can be various, even the discharges can be of different points. So we have to make sure that we don't mix one with the two. And well, we have the Sudan 4 staining for fat droplets in the nipple discharge, which can confirm the diagnosis, which, whether it's we are dealing with galactoria or, just another kind of breast discharge. So based on the various kind of clinical symptoms, we can think of the possible etiology of galactorrhea, whether it's galactorrhea in the neonatal period or whether it's associated with certain headache, visual disturbances, decreased libido, tiredness, and things like that, which we can actually have the different diagnosis of hyperprolactinemia, hypothyroidism, thyrotoxicosis, etc. And we can go down the list and actually think clinically what could be the cause of galactorrhea. Physical findings, again, will give us some kind of idea with poor growth to hyperpituitarism, if it's gigantism or acromegaly, a pituitary tumor, etc. Again, we can, kind of plan both clinically as well as both by the signs and symptoms and also by the clinical findings. And we have a lovely algorithm where we start with the nipple discharge, whether we rule out breast pathology, if it's galactorrhea, whether there is any, elevated prolactin levels. If it's a eupolactinemia, we really don't have to bother much, reassure the patient. If it's yes, then we have a whole lot of kind of causes which will rule out, whether it's a thyroid issue, whether it's pregnancy, whether it's, there's a renal disease, whether it's medication induced, and if there are no causes found, we can definitely do an MRI and pick up a hyperprolactinemia, a prolactinoma, which is hitherto missed, or you diagnose one and then treat with a dopamine agonist, or very rarely surgery. And then if it's normal, we again go back to idiopathic hyperprolactinemia and reassure the patient. So coming to management, once we exclude the breast, pathology, we actually treat only bothersome galactorrhea, and if not, we just kind of reassure the patient and monitor her condition, because most galactorrhea associated with hyperprolactinemia treatment is obviously classified based on the underlying cause. And the medications we have, we are well aware of bromocriptine and cabergoline. And although bromocriptine is a long used drug, we are very, very comfortable with the use of cabergoline now. And I think it goes without saying that most of us have shifted to cabergoline. The only thing which sometimes people do speak about is that bromocriptine has got a better kind of safety database compared to cabergoline, especially when someone trying to get pregnant. But I personally feel in our clinical practice now, cabergoline is doing just as well. And we all know that the levels with cabergoline come down dramatically. We have to give it once a week, so the compliance is much better than bromocriptine. So, normoprolactinemia, galactorrhea, just a few words on it again. If the galactorrhea is not associated with breast tenderness and swelling, it is not particularly bothersome. Just reassure the patient, do nothing else. And again, no mechanical stimulation, and that's very, very important to advise them. But if it becomes bothersome, I think a low-dose dopamine agonist like cabergoline will definitely help us to resolve the issue in a couple of months, and we have a happy patient, and just taper off the drug. For some of the clinicians who are interested, there's a wonderful guideline in the Journal of Clinical Endocrinology and Metabolism. And this is a guideline by the Endocrine Society in 2001. I think it's time that it's revised, but this is such a wonderful guideline. It'll be wonderful if some of you can even look at it and go through the guidelines on how to treat hyperprolactinemia, which I've gained a lot when we talk more detail on a topic, let's say on hyperprolactinemia, not on galactorrhea. Another is a wonderful systemic review and meta-analysis by Wong et al., which is published in Systemic Reviews in 2012, where again, just imagine 8 randomized, 178 non-randomized study over 3,000 patients meeting the clinical criteria. And it was very clear that cabergoline was more effective than bromocriptine in reducing hyperprolactinemia, amenorrhea, oligomenorrhea, and galactorrhea. So cabergoline is definitely the medicine of choice now, and the author's conclusions were obviously cabergoline proving more efficacious than bromocriptine. So this systemic review is also another great one to look at. So I'll end with certain key points. And galactorrhea is commonly caused by hyperprolactinemia, which we know 90% of it, especially when it is associated with amenorrhea. Hyperprolactinemia is most often induced by medication, and that's very important in the history. It can be associated with pituitary adenomas, androcellular or supracellular lesions. Less common cause of galactorrhea, as in the algorithm I discussed, for thyroid, hypothyroid, renal insufficiency, pregnancy, and nipple stimulation, mechanical stimulation. After pathological nipple stimulation is ruled out, patients with galactorrhea should be evaluated by measurements of their serum prolactin. MRI of the brain should be performed if no other cause of hyperprolactinemia are found to rule out that it's not an idiopathic hyperprolactinemia, but with, as I mentioned, I repeated it not once, but twice maybe, about the 3 Tesla machines with 1 millimeter cellular cuts. And patients with prolactinomas are usually treated with dopamine agonists like bromocriptine or cabergoline, and it's cabergoline now, and surgery or radiation therapy is rarely and thankfully rarely required than the days when we were postgraduate students. So medications causing hyperprolactinemia should be discontinued or replaced with a medication from a similar class with low potential for causing hyperprolactinemia. And normal prolactinemic patients with idiopathic non-bothersome galactorrhea can be reassured and do not need treatment. However, those with bothersome galactorrhea, as I told you earlier, they do respond to a short course of low-dose dopamine agonists like cabergoline. Instead of 0.5 milligrams, it could be 0.25 milligrams once a week, and then half that tablet to 0.125 milligrams, and then slowly taper off. Another good read is the Evaluation and Management of Galactorrhea of 2012 in the American Family Physicians. So to summarize, diagnose the etiology of galactorrhea before initiating any treatment, control symptoms and ascertain the desire of the patient. First line of therapy is cabergoline. Bromocriptine has now become the second choice, and it's a team therapy which must involve an endocrinologist, because they will be able to guide you. They're the ones who are reading with the latest guidelines on all their endocrinological problems. It's always good to kind of tickle their brain and really use their help whenever we are kind of we are looking for some kind of benefit for our patient to the maximum. But remember, two things: patients with isolated galactorrhea and normal prolactin levels do not require treatment. If they are not bothered by galactorrhea, do not wish to conceive, and do not show evidence of hypogonadism or reduced bone density. A very, very important point. And the second one is prolactin levels are usually normal when a patient has galactorrhea and normal ovulatory cycles. I'm extremely grateful to Dr. Shanta Kumari, President of FOGSI, Dr. Rakhi Singh, the chair of the Endocrinology Committee of FOGSI, and all my respected chairpersons and senior teachers here for giving me this opportunity to speak on a clinical topic which is not often, kind of treated the way we usually should, because we always only think of hyperprolactinemia while we forget galactorrhea, taking you back to that first kind of published study which said hyperprolactinemia with normal serum prolactin actually should have been galactorrhea with normal serum prolactin. Thank you very much, and I hope in the last 15 to 20 minutes I've managed to cover most of my presentation objectives, and I'll end with a great thanks to all of you and greetings from Kolkata. Thank you very much.
Thank you, Professor Krishnendu. That was really nice, covering everything, and at the end, its attachment, the possible association with malignancy or with the prolactin. And of course, you also put in a word of caution that what are the salient features on which your treatment will be based for galactorrhea. Thank you. You covered it entirely and very practical approaches. Thanks a lot, Dr. Krishnendu, and thank you.
Thank you
Rakhi,
again. Thank you again to everyone for the opportunity.
Thank you for the opportunity, Rakhi. Thank you so much. Thanks.
Thank you, ma'am. Thank you, Krishnendu sir, for guiding and helping us to sail through with this orchestra.
Thank you. Thank you, Rakhi. Thank you again to everyone.
Thank you, Vijay Lakshmi ma'am, for chairing a wonderful session of Dr. Krishnendu Gupta sir's talk. Now, I would like to invite our next chairperson, Dr. Neelam Ori ma'am, to please introduce our next speaker. So, Dr. Neelam Ori ma'am is a fertility consultant and gynae laparoscopic surgeon, and she is a medical director at New Life Hospital and Advanced Fertility Center, Varanasi. Ma'am has a multiple publication in national journals and the various chapters written in her books. Ma'am is a recipient of Shane Kashi and the Kashi Ratna Awards. So, ma'am, please share the session for the next speaker, Dr. Archana Sehgal.
Very good afternoon to all of you. It's really nice to be here as chairperson in Orchestra of Hormones webinar. Thank you, Dr. Rakhi Singh, for inviting me. Can I have the CV of Dr. Archana Sehgal? Yes. So it's my privilege and pleasure to introduce Dr. Archana. She is director and professor and head of dermatology and STD, University College of Medical Sciences, New Delhi. And she is head of dermatology, Faculty of Medical Sciences, FMS, University of Delhi. She has a number of publications and presentations, and she has many awards, honors, and achievements. Postgraduate teacher for more than 25 years, Teacher Par Excellence Award, past president of IADVL, Delhi State Branch, founder president of Nail Society of India, awarded Cystopic Oration in 2013, Sardari Lal Memorial Award for Academic Excellence, Associate Section Editor, British Journal of Dermatology, section editor, tropical dermatology at IDOG, and her areas of interest are tropical dermatology, nail disorders, and pediatric dermatology and gynecodermatosis. So I invite Dr. Archana Singhal for her talk on cutaneous manifestations and hyperandrogenism in PCOS.
Is my slide visible?
Yes.
And am I audible?
Yes, ma'am.
Okay. A very good afternoon, and thank you, Dr. Neela Modi, for the kind introduction. I have a big shoe to fill after I heard outstanding lecture by Dr. Krishnendu. Right at the outset, I will have to extend my hearty thanks to Dr. Rakhi Singh for inviting me to play a small role in the Orchestra of Hormones, which is dominated by the beautiful gynecologists and obstetricians. And I'll be talking about dermatocosmetic therapy in PCOS. So it's not uncommon to have the patients of these kinds, who have unwanted hair on the chin or the upper lip, or who have patients who are in second or third decade but have started a bout of acne, which is unique in distribution with jawline lesions more than the forehead or the cheek lesion. And there are adult patients who are obese who present for the treatment of female pattern baldness or the alopecia. And on examination, they have these hyperpigmented, velvety lesions in all the flexures, mainly the neck or the axilla or the groins. And all these clinical manifestations can be a manifestation which can be described under the umbrella term of polycystic ovarian syndrome, which is the commonest endocrinological disorder with a worldwide prevalence of 4 to 21%. And it leads to reproductive as well as metabolic dysfunctions in women and alteration in aesthetic standards. Now, this is very important because looking good is not the domain of upper middle class or high class women. Every woman on this earth needs to look good and has its birthright. So slightest deviation from the aesthetic standards in the form of hirsutism, acne, alopecia, obesity, acanthosis nigricans, or seborrhea, put them under great stress and negatively impacts their quality of life. And so all these women should be evaluated for PCOS, and for this, a multidisciplinary approach is mandatory. Now, just a little bit of PCOS that it was described, the diagnostic criteria were described by Steen and Leventhal in 1935, but the most accepted one are the ASHRAE or the ASRAM 2012 criteria, where the patient needs to have all three criteria, that is the clinical or the biochemical evidence of hyperandrogenism, oligo or anovulatory cycles, and polycystic ovarian morphology on ultrasonography. The etiopathogenesis of PCOS is very complex, and there is a complex interplay of many factors like genetics, epigenetics, obesity, sedentary lifestyle, and other environmental factors. And together, they lead to ovarian dysregulation, dysregulation of HPA axis, and impaired insulin resistance. And all three of these can result into androgen excess, which leads to various cutaneous as well as gynecological manifestations. The cutaneous manifestations commonest being hirsutism, acne, and alopecia. And you know better than me that it's subfertility or irregular cycles. But the implications don't stop here. There are long-term implications of PCOS if left untreated, and there can be comorbidities like type 2 diabetes mellitus, endometrial hyperplasia, and cancer, and the psychiatric disorder because it's a long drawn disease. Now, coming to cutaneous manifestations in PCOS, hirsutism is defined as the excessive growth of terminal hair at the androgen dependent areas in females, and we score it in 9 areas, as you can see in this picture, on a scale of 0 to 4. So the maximum score can be 30 6 and the minimum 0, but a scale of more than 8 qualifies to be called as hirsutism, and its prevalence is 50 to 90%. So more than half of the women will present with hirsutism, and it is because of the increased activity of 5-alpha reductase and hormone, which is responsible for the conversion of testosterone to a very potent, it's 10 to 17 times more potent dihydrotestosterone. And it's a most distressing implication of PCOS. Another manifestation is acne, which is seen in more than 60% of the patient, but it should be differentiated from the acne vulgaris of the adolescent, which is more often seen on cheeks and forehead. But this PCOS-associated acne is more often seen on the jawline, as you can see in this patient, on the neck, upper back, and chest. Patient also reports of severe flare-ups before menstruation. So a patient, we take this clue a very important one, and there can be associated signs of hyperandrogenism in the form of hirsutism and baldness. And these patients fail to respond to conventional therapy of acne, to antibiotics or topical retinoids. And sometime in these patients, the testosterone is normal, but there is increased peripheral receptor sensitivity to the circulating normal androgen, and that's why they manifest as the features of hyperandrogenism. Another manifestation is acanthosis nigricans. This is a very classical, velvety and, verrucous and light brown to dark brown in color, and they're associated with obesity, insulin resistance. Insulin resistance is actually the hallmark for in any patient with acanthosis nigricans. The prevalence in PCOS is low though, but you see commonly it's described in books low, but whenever we see an obese patient with PCOS, she will have acanthosis nigricans. And this is because of the excessive binding of the serum insulin to interleukin growth factor 1 receptors, and which leads to the proliferation of keratinocytes and fibroblasts, leading to this clinical manifestation. Another manifestation is alopecia, which we also call patterned alopecia or the female pattern hair loss or androgenetic alopecia, where there is thinning at the vertex while the maintenance of the frontal hairline is there. And we score it as on the Ludwig score, 1, 2, 3. And in this, the patient has short anagen phase, which is the growing phase, and immediately goes into the telogen phase, which is the resting phase, leading to the miniaturization of the terminal hair and their transformation into vellus hair. And that's how there is this area which appears empty. Seborrhea is another manifestation of hyperandrogenism, where the patient has oily and shiny skin in the nasolabial fold, as you can see here, and there is or behind the hair, and these patients also tend to have dandruff, which does not respond to conventional therapy. Now, once you see these patients, we need to evaluate these cutaneous manifestations to confirm the diagnosis of PCOS so that there can be early intervention and prevention of long-term sequelae. So a detailed clinical history is to be taken for the duration of cutaneous manifestation, menstrual history, history of infertility, diet history, family history. And we need to clinically evaluate the patient. For example, the grading of hirsutism is to be done on a Ferriman-Galway score scale. The site of acne and the type of lesion have to be noted down. Seborrhea is to be seen. It is more common in the occipital area and the frontal area. Grading of patterned alopecia is done on Ludwig scale 1, 2, 3. And sometime when the hirsutism is like, I have seen a patient whose Ferriman FG scale was more than 29. So I had to examine, maybe there is some evidence of virilization such as clitoromegaly, which can happen secondary to adrenal tumor or ovarian tumor. And then body mass index and waist circumference and BP has to be taken. The lab in every patient where we suspect some hormonal disturbance have to be evaluated in details. Fasting blood sugar, serum insulin, and HbA1c has to be done. Serum testosterone, total and free. Now, the free testosterone is very important because this is the one which is, responsible for hyperandrogenism. Serum LH-FS ratio, which is generally raised. Now, this test is considered obliterate, and we don't even ask for it. Serum androstenedione, serum DHEA and DHEAS, to exclude adrenal cause whenever you are suspecting one. Now, to exclude, we have to exclude certain causes that mimic PCOS, and we have to run investigations for them. That's thyroid stimulating hormone to rule out hypothyroidism, where you can have all these features as a part of the metabolic syndrome. Prolactin, Dr. Krishnendu has talked about it in details. 7-hydroxyprogesterone is again important to exclude congenital adrenal hyperplasia, which is because of the 21-hydroxylase deficiency, and DEXA suppression test when you are suspecting some HPA axis suppression. Now, the management option in PCOS is to be multi-pronged, and there are 4 main heads. So lifestyle modification is one, medical therapy, then comes the cosmetic and local therapy, and last but not the least, psychological support is essential. Hand holding is extremely important for these patients because the manifestation seems benign, but the implications are pretty malignant. So the lifestyle, they lead a sedentary lifestyle. They may smoke excessively or lack of physical exercise, eating junk food has to be addressed by the lifestyle modification of dietary restriction, exercise and weight loss. Patients should need to quit smoking, and merely 5% loss of the total body weight decreases insulin resistant and testosterone levels. So such is the impact of these general instructions to the patients. And there is marked improvement in the body composition and the cardiovascular risk markers. Now, I'm very fond of this slide, and this is by my friend, Dr. Nilanjana Singh, who is a dietitian, and she has this the layout of the table, the lunch or the dinner is very important, where there are 4 portions of fruit, vegetable, proteins and grains. The grains have to be, half of it should be whole grain, and the dairy products. One should avoid oversized portions, compare sodium in different foods, and drink water instead of aerated drinks. Again, you have to cut down on the portions as shown in red and resolve to the low calorie restricted diet, low glycemic index with high omega-3 nuts, and functional food with a lot of vitamins, B6, B12, vitamin D, and other fibers. Coming to medical therapy. Now, the medical therapy, the therapeutic goal is to achieve inhibition of ovarian and androgen production and decrease their bioavailable form or the circulating form by increasing SHBG level or the sex hormone binding globulin levels, so that the free testosterones are less and they are more attached to the SHBG. Now, they fall mainly into 3 categories. Hormonal pill is usually the prescription in every. It is contraindicated of PCOS patient. Anti-androgen, again, depending on what are the manifestations, and insensitizers now in majority of the obese patient. Coming to combined oral contraceptive pills, they decrease the estrogen in oral contraceptive pills, decrease luteinizing hormone, increase SHBG, and decrease ovarian androgen production. Now, this is very oversimplified approach, and therefore they reduce the free testosterone and they limit the cutaneous manifestations like acne and hirsutism. And the progestin in OCP, like there are new progestins like norethiridrone, desogestrel, and noradjustamate. They have mild androgenic action. And you have to see which is the more suitable for the patient by balancing the efficacy, the metabolic risk profile, and the side effect profile in particular patient. I find cypertolone acetate is a more potent, as it also inhibits 5-alpha reductase, but drospirenone has an advantage of being anti-mineralocorticoid action. So whenever patient is complaining of bloating or water retention, there is evidence of water retention, you can use OCP containing drospirenone, and that's how I manage. Coming to anti-androgens, they work 2 ways. They competitively inhibit the androgen binding receptor, or they inhibit the 5-alpha reductase enzyme, which is responsible for the transformation of testosterone to 5-dehydrotestosterone. The OCP should be added with all anti-androgen in sexually active women, as there is risk of feminization of the male fetus if pregnancy occurs by chance. So spironolactone is the most effective anti-androgen, most efficacious, and I think it is the most used one by the dermatologist, including me. I use in all the patients of hirsutism primarily, but it also has effect on acne and alopecia. I start with 25 milligram per day, and you can progressively increase every week, to a maximum of 100 milligram. Majority of the patient do pretty well with even 50 milligram later on. Side effects, it's generally well tolerated. I've yet to see a patient whom I had to discontinue because of the side effect. Coming to cyproterone acetate, it inhibits the binding of testosterone and 5-alpha dihydrotestosterone to androgen receptors. And the dose is 2 milligram with 35 milligram of ethinyl estradiol to 50 to 100 milligram. So CPA is generally used with OCP, and it is more effective than the finasteride. Side effects, better than me, headache, weight gain, breast tenderness, etc. Coming to other anti-androgens like flutamide, I have never used this because its main concern is hepatotoxicity, and this reaction is idiosyncratic. So it's not even dose related, and which can be fatal. Finasteride, I use it in post-menopausal women now who complain of increased hair growth or loss of hair. A potent competitive inhibitor of type 2 isoenzyme of 5-alpha reductase, and it again blocks the conversion of testosterone to a more active form, DHT. It is used in combination with, should be used in combination with OCP in women of reproductive age group. In postmenopausal, there is no need. And this is the drug of choice for hirsutism when estrogens are contraindicated for, or patient is not able to tolerate. Now, isotretinoin is a drug which is used by almost every dermatologist for patients of acne traditionally, but if it is associated with OCP, with PCOS, acne, and patient is not able to take tolerate OCP or may refuse OCP due to adverse effect or pill scale, then isotretinoin can be given. So it is contraindicated in because OCP is contraindicated in patient with thrombophilia, migraine, or heavy patient who smoke heavily. So isotretinoin has been shown to decrease FG score, free testosterone and insulin level, and acne score and ovarian volume. So it acts on all the parameters of PCOS. So it can be used only as a second line therapy. Coming to insulin sensitizers, insulin decrease uptake of insulin cell by and result in increased level of insulins, and insulin resistance play an important role in increasing the pool of androgens, both by ovaries and adrenals, and by decreasing the synthesis of SSBG, resulting in a state of hyperandrogenism. So metformin is a drug which I always prescribe in all obese patients. I never need to go more than 500 milligram per day. I start with 250 milligram, and generally, and if patient is regularly exercising, it helps in decreasing the weight gain. So it is important to note that metformin does not cause hypoglycemia. So one should not worry, that if I'm giving 500 milligram, even in BD doses, patient may go into hypoglycemia. So that is not there. Coming to cosmetic or local therapy, now there are very many physical methods of removing hair for hirsutism, like threading, waxing, bleaching, or shaving. But all these modalities are very, very transient, give transient results. They need to be repeated. They are painful, and now generally they are not acceptable because now we have better techniques and better expertise. This electrolysis was done in 80s. I also used to do it, where we take a electrofulguration machine, put the needle at the level of the hair bulb and destroy it. So this was very time consuming and very labor intensive. And, sometime if the radio frequency is done on a higher voltage, it will lead to scarring. But we have now better machines, better techniques like laser hair reduction. It is not laser hair removal, mind you, because it does not remove the hair. It causes significant reduction in hair growth to the tune of 60 to 70%. So 30% are still there, which you need maintenance session. So laser hair reduction, we have many lasers like long pulsed ruby, diode, long pulsed alexandrite laser, long pulse ND-egg laser, and IPL devices. There is no as gold standard for LHR. So outcome depends on the laser parameters that are used. We have the spot size, the fluence, duration, skin color. Now and the color of the hair, the dark and the coarse hair respond better than the lighter hair. So if somebody is trying to remove vellus hair or white hair, it doesn't work on that, because the target is melanin, which is not there in the lighter hair. And LHR would definitely, it should be effective only after the start of anti-androgen therapy. These days, many dermatologists are starting lasers simultaneously but it is always good to give systemic therapy for first 2 to 3 months before you refer the patient for laser sessions. Generally 6 to 8 sessions are required at a monthly interval, and after that, as I told you, it causes laser hair reduction. So after that, 3 to 6 monthly maintenance laser sessions may be taken. Now, laser treatment has got, you need to sensitize patients of PCOS that a poorer than expected reduction is seen in patients with PCOS unless and until their hormonal profile is brought back to normal. Another therapy for hirsutism especially is eflornithine hydrochloride or Eflora cream, which is a FDA approved prescription cream licensed for facial hirsutism in adult women. And I'm very fond of it, especially when the patient has started on, anti-androgen therapy or OCPs, and she is waiting for the laser sessions. So if you ask the patient to apply at bedtime, there is definite reduction in the time or the increase in the interval of the period when patient needs to go for waxing or threading for the upper lip. Monotherapy is not considered to be effective, but it can be used as adjunct with medical or device-based treatment, and it helps in miniaturization of the hair follicle, so they become less coarse. Coming to chemical peels for acne and pigmentation, another, most common, simple, cost-effective, and cosmetic procedure, which is undertaken by dermatologists every now and then. So in this chemical peel, we apply chemical agent of variable strength on the skin that result in very controlled destruction of the epidermis and dermis. So this induces exfoliation, followed by dermal and epidermal regeneration, and the result in improved surface textures and appearance. Now, there are many superficial peels which are available, beta hydroxy acids and alpha hydroxy acids. There are glycolic acid peels, salicylic acid, lactic acid, mandelic acid, and combination peels. But patient selection in the peel is very important, as PI post-inflammatory hyperpigmentation is a concern in brown skin. Now, for acanthosis nigricans, weight reduction is important. Oral metformin can be given, but topically tretinoin cream can be given or keratolytics can be given. Chemical peel can be done after you have done trichloroacetic acid peel, and laser, one study has shown that laser can be effective. Platelet-rich plasma for alopecia. PRP is autologous preparation of plasma with concentrated platelets of 3 to 6 lakh per cubic millimeter. The principle of PRP is that, you reverse the RBC platelet ratio from 94 to 5% to, 96% platelet, and they contain various growth factors, cytokines, and 800 proteins, and they facilitate the tissue rejuvenation and healing. The minimum session required are 3 to 4 at 2 to 4 weekly interval, after which you can maintain it. Now, the combined medical and local therapy is very important. This is the hallmark for an adequate result. Systemic therapy to correct metabolite and endocrinological abnormalities, local therapy for symptomatic relief. For hirsutism, you can have cosmetic therapy, OCP, anti-androgen. For acne, peels, lasers can be added. And for alopecia, topical minoxidil and PRP can be added. Psychological support, as I told you, is very essential. Hand holding is extremely important because the course is long and the compliance has to be great. the take-home message is that the treatment has to be tailor-made for every patient. It's not that every patient requires anti-androgen metformin. It has to be a combined approach, and a dermatologist, gynecologist, and endocrinologist should work in tandem. There has to be genuine need to understand and diagnose this syndrome early. A holistic treatment is required. Mainstay of the management is to address the endocrine and metabolic deviations, inculcating lifestyle modifications, and do aesthetic treatment as early as possible for acne, hirsutism, and alopecia. I'm really grateful and thank you for your patience here.
Very nice, comprehensive talk by you, Dr. Archana. And very nicely you told that these cutaneous manifestations are really very high number in PCOS patient, and they jeopardize the feminine identity of the woman, and alteration of aesthetic standards are there. And very rightly you said that early intervention and prevention of long-term sequelae is really important. And very nicely you said that hand-holding strategies are required because they need long-term treatment, and the hallmark of therapy is the combination therapy. So thank you very much for the very comprehensive talk.
I'm really grateful for the opportunity.
I wanted to ask, is there any role of minoxidil in alopecia?
Yes, there is a role of minoxidil in alopecia. Usually in patient with reproductive age group, 2% minoxidil is required. But if this alopecia is in the postmenopausal, 5% minoxidil daily application is required.
Okay, thank you.
Thank you very much.
Thank you, Neelamurthy ma'am, for chairing an excellent talk. And now I would like to conclude this session to thanking all my wonderful speakers for a wonderful lecture. Now I would request Dr. Ananya Das to start the next session and the last session of today's conference. Dr. Ananya Das. Dr. Ananya is a faculty in GRIMS with 12 years of UG and the PG teaching experience, recipient of CS Dawn and the Srimati Bhagavato Devi Yamuna Singh Prize in AICOG and the Young Talent Award in the East Zone Yuva Foxy in 2013. Dr. Ananya, please start the session. Thank you, everyone.
Thank you, Dr. Anshu, for the kind introduction. Now, good afternoon, everybody. We move on to the last session of today's conference. And we have 3 talks in that. The first one will be testosterone in stimulation, and it will be by Dr. Apurva Pallam Reddy. For this, I would like to invite our chairperson, Dr. Archana Dwivedi ma'am. Can I please have a CV? Dr. Archana Dwivedi ma'am, she is a senior gynec and obstetric consultant in Sterling Hospital. She is the president of BUGS 2021-22, president VMS 2019-2020, vice president BUGS 19-20, secretary WDWIMA for 2020-2021. She's practicing
sorry
since...
to interrupt, Ananya, we can overlook that. We all know each other so well. So I think we can proceed to the session straight away.
Okay, ma'am. Then over to you, ma'am, for conducting the session.
Thank you, Ananya. And it gives me immense pleasure to introduce Apurva, my dear friend, and a very dashing diva, I would say. I have been following her with the educational videos and so many things in her kitty. She's always working for the society for the upliftment of the women, and she is editor decision making in fertility, director International Fertility Academy, editor decision making in fertility and diploma in gynec endoscopy from Kiel, Germany. And she has taken her infertility training from Brussels, Belgium. So as we all have been going through the session since morning, and I think we should be thankful to Dr. Rakhi for bringing out such important topics over here. Orchestra of Hormones, and we all know that pubertal response is a very complex thing which results into the culmination of sexual maturity and also the reproductive capability of a adult life. So here we have Apurva talking about testosterone and its role and its therapy in ART. So over to you, Apurva. I know you'll do justice to this topic and we are eager to hear it from you.
Excuse me. Since we are running late, I would request all the speakers to please stick to 10 minutes.
Yes, sure. Thank you so much for that kind introduction, Archana. And yeah, it is always a pleasure to come back to a session that has been curated by Rakhi Singh under the agents of Shantakumari ma'am. It is very uncanny that we just heard a lecture wherein we have to do everything possible to control the testosterone levels and bring down the acne and all the medications that we need to use. And now I'm going to talk about how testosterone actually can be beneficial for women in certain aspects. We know now sufficiently that ovarian reserve depletes over time, and this has been an unfair advantage for women, wherein men can continue producing sperms all their life, but women are born with a fixed number of eggs, and with age the number is only going to come down. If age only was the single factor that was concerning, then probably we wouldn't have minded it that much. But there are a whole lot of other agents which come into play. And that is the reason why even women who are younger in age, who have reasonable ovarian reserve, also sometimes give out a poor ovarian response when we stimulate them in an ART cycle. Thankfully, for the Poseidon criteria, we have been able to categorize them into 4 groups. Now, the group 4, which are older women and who have less ovarian reserve, probably these are not the group of women wherein, we can do much or intervene much. And these women probably benefit from moving on to a third-party reproduction in an earlier stage as compared to trying to salvage their own cycle. But it is this group 1, 2, and 3. These women definitely have some scope of benefit from the medical line of therapy or the treatment options we as fertility specialists have to offer to them. With the ART bill coming in, I think the options for us are narrowing down. With the decrease in ease of using a donor, we will have to really, really focus hard on how we can ensure and use the gamete of the self gametes of women and increase their fertility rate during an ART cycle. If we quickly look into the picture, there is something, the measure what we have of ovarian reserve is either with respect to AMH or with respect to the antral follicle count. Now, the antral follicle count will be assessed only after an antrum, that is a cavity filled with fluid is started, whereas the AMH can actually assess even the small preantral follicles and large preantral follicles as well. Now, if you see, there is a small sect of primordial follicles which are there. So it is possible that the woman actually has a reserve of primordial ovarian reserve, which is not manifested either by the AMH nor by the antral follicle count. And we right now with our medical therapy are trying to target in bringing out the primordial ovarian reserve into the functional ovarian pool. So yes, the whole idea is to improve the dysfunctioning of these follicles and kind of convert them into an FSH receptive zone so that we will be able to achieve follicles, mature oocytes of them. If we get into, I know that, we know a lot of medical therapies that are available for us, but before any pharma guy kind of tells you, or before any other doctor or colleague tells you that you should be using this particular drug, we need to understand what exactly is the mechanism of action for that agent in improving the outcomes. If you look at the primordial oocytes, so they do have androgen receptors as well, and FSH receptors as well that are there on the secondary follicles. Now, when the androgen receptors stimulate their with the endogenous androgens, that is when further FSH receptors are stimulated. This is what we call as the FSH and androgen synergy. So if both FSH levels and androgen levels are present, that is when we have a scope of possibility of the primordial, primary, or secondary antral follicles to kind of move into the small antral follicles or the antral follicular space. This is what we would call as the primordial follicle initiation. Now, the fact that women with PCOS who are actually hyperandrogenic, we do see that they do have a lot of antral follicles. So this in itself shows, so mind you, PCO women do not have a higher ovarian reserve. They also have the exact same ovarian reserve as any other women. It is just that because they have more androgens, they have more synergy, they have established more FSH receptors, because of which they have more follicles which are acceptable or which are ready or responsive to the gonadotrophins that we are giving them. And that in itself is a huge theory for us to kind of be proven that androgens actually have a role in the primordial follicle initiation, wherein they get converted into the primary follicle, secondary, small antral, and preantral and antral follicles subsequently to become a dominant follicle with time. Now, the endogenous androgens that we have, they are the testosterone and dihydrotestosterone, that is the bioactive form of the androgens, are actually precursors, or they are formed from the androstenedione, DHEA, and DHEA sulfate that are being produced by the ovary and the adrenal glands. So we don't have endogenous synthesis of testosterone or DHT, but they are just byproducts of the androstenedione and DHEA that is being produced by the ovary and the adrenal glands. Again, as we very well know, with time, the production of these androgens also starts to deplete. And it is because of this effect that the response of the follicles in their conversion and initiation is affected. If we have a quick look at what are all the aspects where the androgens can have an impact, from the primordial follicles to the primary follicles to even the peri-ovulatory follicles, the androgens have a response wherein they increase granulocyte proliferation, insulin-like growth factors, FSH receptors, sensitivity to FSH, reduce the apoptosis, increase the antral follicles, so on and so forth. And they even have a benefit with respect to oocyte maturation and higher ovulation rates as well. And because of this knowledge, or probably with time, it is seen that almost 40% of the clinicians actually use one or the other kind of androgens in their clinical practice. Although there is no standard of practice, it is still that almost 40% of them use, because they do see clinical results that are there. Now, let's talk specifically about testosterone. I know DHEA is the most common androgen that is used, but let's try and stick to testosterone. The most common route of administration for testosterone is as a transdermal gel or as transdermal patch, wherein 1% of androgen with a 12.5 milligrams is administered for a duration of time before the ART stimulation in order to improve. Now, this duration of time is what is very important, because for a primordial follicle to get converted into an antral or a preantral follicle, it is going to take anywhere between 40 days to sometimes even 60 to 80 days as well. So if we are giving testosterone for these women, it is important that we give them the equal duration even as we give a DHEA, and only then will we actually be able to see an impact or a result. If you're starting a stimulation in a February cycle, giving her just for about 10 days before you start the stimulation is not going to really add any advantage for you. You should be using it for a minimum duration of 40 days, and at least 20 days is going to be the bare minimum that which will give us some amount of results. If you look at the data, everybody is always asking about data. If you look at the data, we do fortunately have some randomized controlled trials that have been published way starting from 2006 to the latest, wherein the Bolognese criteria was used in 2018. And there are a whole lot of observational studies which are present that deal to understanding the role of testosterone in ART as well. And most of them have used transdermal testosterone application as well. A couple of studies have used one study has used oral testosterone and another one has used intramuscular testosterone, but the most favored one definitely is the transdermal route of application. I will just talk about one single meta-analysis that was done by about Noventa, wherein, and that was published as late as 2019, wherein almost about 457 women who fit into the criteria of poor ovarian reserve were evaluated and were administered testosterone prior to their ART cycle for a minimum duration of 20 to a maximum of going up to 65. In these, there was a significant improvement in the live birth rate. If you see the p-value, it's 0.004. That is definitely a significant value. Not just the live birth rate. Of course, live birth rate is the most important outcome, but there was increased clinical pregnancy rate, increased total number of oocytes, good quality embryos, high-grade embryos, and also there was no impact on the miscarriage rate or no effect on the female fetuses that were born after the administration of testosterone as a pre-treatment. So to conclude, I would say that I think we have sufficient evidence now to say that there is definitely a positive impact of testosterone over the ART results that we have when it is administered in the right duration, at the right time, and in the right amount. And of course, most importantly, for the right group of patients. And the minimum duration can range anywhere between 20 days to 60 days. And this is what is going to maximize the impact. It can be given in concoction with other androgens and other agents which are used for poor ovarian reserve, enhancing the response of women with poor ovarian reserve as well, because the interaction of testosterone with other agents is almost negligible. Thank you so much for the entire team of endocrinology, Rakhi Singh, for having me here today. It's an absolute pleasure.
Yeah, thank you, Apurva. Indeed, it was very good. You highlighted important points that judicious use of hormones definitely have a good say when we talk about the ART results. So thank you, Dr. Rakhi and Apurva, for letting me be here, and I really enjoying the sessions all through. Over to you, Ananya.
Thank you, Dr. Apurva, once again for the wonderful talk, and Dr. Archana ma'am for chairing the same. Now we move on to the next talk, which is role of growth hormone in stimulation by Dr. Meenu Handa, and it will be chaired by Dr. Hitendra Somani sir. He is the president of Bhavnagar Foxy Society, and he's also the director at Nirmal IVF Test Tube Baby and Advanced Laparoscopy Center, Bhavnagar. He was awarded the FICOG at AICOG 2015 Chennai Best Paper Presentation Award at Yuva Isar, Jodhpur. Divya Bhaskar 2018 Eminence Award, received Atmanirbhar Award at Gandhinagar 2021. He has many publications in national journals, presented papers as well, and attended many conferences as a faculty. His special interest is infertility in elderly patients. Over to you, sir.
Thank you, Dr. Ananya. First of all, many thanks to Dr. Rakhi Singh for giving me opportunity to be here, and many congratulations for this wonderful program. It's a pleasure to introduce Dr. Meenu Handa. She is a senior IVF consultant and clinical head of Otis Bloom IVF Gurgaon. She is also a course director of Foxy Certified Infertility Center and also a North Zone coordinator of Foxy Endocrinology Committee. She is a joint secretary of Haryana ISAR and IAG chapter. She's a winner of CS Dawn, Wonder Foxy and Award, and also Best Paper Presentation in North Zone UA Foxy 2019. Dr. Meenu Handa is MS OBGY gold medalist, and she's done fellowship in reproductive medicine from Tamil Nadu University. To her, she has several...
Right, well starts. Thank you so much, sir.
Okay,
Thank you for
over
your
to you,
time.
ma'am, for the topic, role of growth hormone in stimulation.
Thank you for your kind words. And on the onset, thank you, Dr. Rakhi Singh, for giving me this opportunity. And the topic given to me today is on role of growth hormones. Can you see my slide?
Yes.
Yes, we can hear you and see your slide.
Right. So we are talking about growth hormone in IVF, and The most important is why do we need to talk about the adjuvants? Why do we need adjuvants in the first place? And as my previous speaker, Dr. Apurva, has very nicely highlighted on the need of adjuvants and the pathophysiology, this is applicable for a very select group of patients, which are the poor responders. I think for all the ART specialists, this one group poses a great clinical challenge. And with the Poseidian classification, now we are able to group the poor responders into the 4 groups. And the role of adjuvants, why did we start talking about it only in the poor responders? Because poor responders come with special challenges. Now, the most important, one of the challenges which we tend to see is that the follicle to oocyte index is very low. Now, when we talk about follicle to oocyte index, it's actually the number of oocyte we get at the end of the retrieval to the actual antral follicular count, which we started our stimulation with. So in the normal follicle to oocyte index should be more than 50%. And in majority of the poor responders, we get a low FOI. Now, the pathogenesis can be quite, a big spectrum. It could be inherent cause, or it could be an external factor. The external factor could be, I think in the morning, we had a very good lecture on the EDC by Dr. Jaideep sir, or it could be because of a low gonadotropin starting dose, or, it could be also a technical issue regarding the trigger. But majority of the times it is a genetic or an inherent folliculogenesis impairment that the poor responders do not respond the way we want it. Now, ESHRE has also come up with the best practice guidelines on Poseidian group 1 and 2 and 3 and 4. Now, 3 and 4, the group are specific because they basically, whether they are young or old, the common part about the group 3 and 4 is that they already have less ovarian reserve. Now, that is the reason why the adjuvants play an important role in this particular group, so that we can get more number of oocytes at the end of our stimulation. So various, adjuvants along with the growth hormone has been tried and tested. It could be testosterone, it could be DHA, arginine, low dose aspirin, or aromatase inhibitors. And today I'm sticking on to the growth hormone. Now, the growth hormone, as we know, it's secreted from the pituitary gland and through the liver. The most important mechanism is that it also enhances the insulin growth factors and other growth factors as well. And then these growth factors, along with the growth hormone, will start working on the ovaries. The most important thing, if you look in this diagram, is the recruitment. And I think my previous speaker had also highlighted that, we want more primordial follicles should be recruited and going to primary follicles. And those primary follicles should then become the antral follicular counts, and which we can start recruiting in our cycle. So growth hormone will have multiple roles. It will increase the androgens, it will increase the proliferation. And as we can see that it stimulates the insulin growth factor and it will stimulate the folliculogenesis. It will increase more primordial follicles into recruitment. And that's what we want. We want more number of oocytes to be recruited. And it also increases the estrogen production. It betters the oocyte maturation. And lastly, it decreases the apoptosis. As we know, many studies have proven that as the woman is going to age, the apoptosis is higher. More number of primordial follicles are going under apoptosis. So that is what it is going to target at, and hence probably we'll get better number of oocytes. Now, this is what the theory is. But now let's concentrate on what is the evidence. We know how the growth hormone actually works, but does it really helps us? Now, this was a randomized control trial in 2016. And in this, if you look, the growth hormone as an adjuvant was used only for poor responders. And what they found out was it did increase the number of collected oocytes and the number of fertilized oocytes, but there was no significant difference in the clinical pregnancy rate. And hence a judgment or the evidence was that it should be used very judiciously. Then came another paper, which was more like a meta-analysis of randomized controlled trial in 2020. And again, they did support the use of growth hormone in poor responders, but there was very limited available evidence, and growth hormone supplementation did seem to improve the IVF outcome in poor ovarian responders, but it was concluded that a large sample size was required to clarify the effect of growth hormone adjuvant therapy in the treatment of women with poor responders. Now, as we move ahead, in the last year itself, we had a systematic review and meta-analysis on growth hormone. This was done by Cozzolino et al. And in this, randomized controlled trials were taken, and it was the primary outcome was the live birth rate, the clinical pregnancy rate, the miscarriage rates, the ongoing pregnancy rates, the number of oocytes, and the number of M2s, and the number of embryos available to transfer were considered as a secondary outcomes. Now, this was a very, very important paper, because here the number that we were talking since the last 4 to 5 years, that we didn't have a large sample size. But with this paper coming up, they took 12 randomized controlled trials, and out of which 586 women underwent the growth hormone co-treatment intervention. And these were all antigon cycles, and growth hormone co-treatment versus a conventional controlled ovarian stimulation was done. And live birth rate and clinical pregnancy rates were compared. And as you can see from the confidence interval, it clearly lied towards the growth hormone. So what was the conclusion? The conclusion was, this is a very important conclusion that came out, that growth hormone does not increase the live birth rate. It does not increases the ongoing pregnancy rate, and neither does it decrease the miscarriage rates. But what does it do? It definitely increased the clinical pregnancy rate. It increased the number of oocytes retrieved. That is, the follicle oocyte index was increased, and the number of M2s oocytes were increased. Now, this was a very, very important finding, because at the end of the day, as we spoke, that for poor responders, the most important challenge that ART specialists do face is the follicle oocyte index being very low. That means we start with a good antral follicle count or an average antral follicle count, and we get less than 50% of the oocytes. And when we increase the number of M2s and we increase the number of embryos, and with embryo pooling cycles, there was an increase in the clinical pregnancy rates. So growth hormone does have a role in poor responders as a good adjuvant therapy. So poor responders are challenges in the life of ART specialists, but we need to keep going and looking for more solutions. Thank you so much. I hope I've stuck to my time. So
thank you, Dr. Meenu, for wonderful presentation. Very clear-cut message about the role of growth hormone. Thank you very much. And once again, thank you, Dr. Rakhi.
Thank you, sir.
Thank you, Dr. Meenu, for this wonderful insight into the role of growth hormone in IVF. I also thank Dr. Hitendra Somani, sir, for chairing the talk. Now we move on to the last talk of the last session of the day, and that is on AMH in decision making. For that, it will be by Dr. Chaitanya, sir, and the chairperson for the same will be Dr. Chandrika Anand, ma'am. She is a senior consultant in Obs and Gynae with experience since 1995 and director PCOS Center, Bangalore. She is also the chief consultant at Fortis Hospital and South Zone coordinator of Endocrine Committee, FOXY 2021. She has worked as associate professor in OBG and emergency medicine at Kuppam, and she has authored and presented many research papers in national conferences. She is a patron member of PCOS Society of India. Her areas of special interest are PCOS and high-risk pregnancy. Over to you, ma'am.
Thank you so much. At the outset, thanks to Endocrine Chairperson Dr. Rakhi Singh and Shantakumari ma'am, and for a wonderful session on hormones. It was indeed an orchestra. So thanks, Ananya. And it is my pleasure to introduce Chaitanya, sir. Can I have the slide, please? So Chaitanya sir, everyone knows him. He is very popular. I met him in many webinars. He is MD and Diploma in Gynec Endoscopy, MD OBGYN, and he's a director of Pearl Women Hospital and Yesh IVF Centers in Pune, and Clinical Secretary POGS 2021 and MCM POGS 2021. He is a West Zone Coordinator. He's a colleague of mine in Endocrinology Committee of FOXY 2021. Recipient of Times Health Icon Award, written many chapters in gynec textbooks of Jeffcott and Foxy Focus, and published many papers in national and international journals. So all of us are talking about AMH, that is a new found hormone indicator of fertility.
I think we lost
Dr. Chandrika. Yeah. Okay. Can I just start?
Many use it, abuse it in many areas. That is in all women.
Hello.
Yes, sir.
Yes, Chaitanya, start.
Yeah. Thank you, Chandrika ma'am, for that kind introduction. At the outset, I would like to thank Foxy President, Dr. Shanta Kumari, Chairperson of Foxy Endocrinology Committee, Dr. Rakhi Singh, and Vice President, Dr. Basab Mukherjee, sir, for giving me this opportunity to be here today and speak on AMH in decision making. My previous speakers, Dr. Apurva and Dr. Meenu, highlighted the importance of adjuvants in poor responders, and I'm going to talk about one of the important factors which define these poor responders, on the basis of which we are categorizing these patients, and that's AMH. As we all know, AMH, it's a glycoprotein and a member of the transforming growth factor beta family. It is known for its role in male sexual differentiation. It was initially used as a biomarker for the testicular function in men during childhood. Later on, it was found that it's also present in women, and it is produced by the granulosa cells of the small growing follicles, and it has a distinct role to play in the folliculogenesis. So what is that role? Now, it is produced by the granulosa cells of the small growing follicles, which are up to 8 millimeters. Now, this production of AMH increases steadily over a period of time as the follicle grows from, say, 2 millimeters to 8 millimeters. And then there is a drastic decrease in the production of this AMH once the follicle reaches the size of 8 millimeters. So what actually AMH has a role to play in the ovarian physiology? Now, it has got an inhibitory effect, as you all know, that it's produced by the primordial follicle pool, the small preantral pool, and the large preantral pool, but not by the large antral and the pre-ovulatory. So it has got an inhibitory effect on the primordial to primary follicular transition. Therefore, higher the AMH, lesser the transition from the primordial follicle to the primary follicle. In the absence or decrease of AMH, the transition is increased from the primordial to the primary follicle, and the ovary shows more growing follicles. It reduces also the sensitivity of the cells to FSH. It also decreases the aromatase activity in the granulosa cells and thus decreasing the production of E2. And that is how probably it is responsible for maintaining that low E2 environment in the small follicles till the dominance of follicle emergence. Now, once the follicle becomes dominant, we all know that estrogen is a very important hormone to play, and its levels start increasing. Now, because these follicles don't express AMH, probably that is the reason why the E2 levels are increasing in these follicles as compared to the small growing follicles. Now, when we wanted to use AMH as the positive predictive model, we needed a model which was normative. We needed to develop a positive correlation between the AMH levels and the recruitment dynamics. Now, this work was done beautifully by Thomas Kelsey, and he published his studies in 2011. And you can see here that the AMH levels slowly increase since birth, and they reach they reach the highest point at around 24 to 25 years, and then the AMH values start decreasing. Now, he also showed that there is a positive correlation between the AMH values, decreasing AMH values after the age of 25 years, and the decreasing non-growing follicular recruitment. And therefore, as the AMH decreases, the number of follicles which are available for recruitment are also decreased. So there is a positive correlation between the AMH and the ovarian reserve, and that's how we started using AMH as one of the predictors of the ovarian reserve. So this work was done by Thomas Kelsey in 2011. So what are the clinical applications of AMH? It is used as an indirect indicator of ovarian reserve. Now, it is also used to predict the ovarian response in the stimulated cycles. To individualize, when I say to predict the ovarian response, it is used to differentiate or categorize the women into hyper responders, normo responders, and poor responders. It is also used to individualize the stimulation protocols. It is used in the assessment of ovarian damage from chemotherapy, radiotherapy, and ovarian surgery. And can it be used as a predictive model for menopausal age of a woman is something which we would look into as well. So when it comes to clinical applications of AMH, the first thing which comes in our mind, can AMH be used in IUI? Now, when we are saying about use of AMH in IUI, what it should do, it should actually identify the patients that can be benefited with IUI rather than proceeding directly to IVF. And if I have selected these patients for IUI rather than going for IVF, the next step which it should do is to identify the stimulation strategy which I should be using in these cases, and then the predict outcome. So are there any evidences to say that yes, AMH has got a decision-making role when it comes to IUI? Now, the first paper in this regard was published in 2010 by H.W.R. Lee, wherein they evaluated 243 patients which were undergoing IUI and its relationship with the AMH levels. Now, they did both first cycle in analysis as well as cumulative live birth rate analysis over a period of 3 cycles of IUI. And they found that the increase in the AMH levels is associated with increased live birth rate or increased pregnancy rates, both first cycle as well as cumulative live birth rate. So there is an association or relationship between the AMH and the first cycle and the cumulative live birth rate when it comes to IUI. So are there any other recent studies which have been published in this regard? Now, there are 2 studies which I found again published in 2015 and 2016, which compared anti-Mullerian hormone prediction in the outcome of intrauterine insemination with controlled ovarian stimulation. Now, here 195 patients evaluated. Again, the first cycle and the cumulative pregnancy rates were studied, and the conclusion drawn was AMH levels seem to have a positive correlation, and patients' age and LH levels had a negative correlation with the outcome of IUI and controlled ovarian stimulation. AMH concentration was significantly higher in patients with a clinical pregnancy after 3 cycles of IUI treatment compared with those who did not achieve pregnancy. So there was a positive correlation between the AMH values and the pregnancies after IUI. Now, this again was a paper published in 2016 wherein 276 women were included. Again, they had a conclusion that the overall pregnancy rate was 15.6%, and the multivariate analysis showed that women with serum day 3 concentration of AMH higher than 2.3 were more likely to have ongoing pregnancies as compared to those with less than 2.3 nanograms of concentration. So maybe we can think of 2.3, 2.5 nanograms as a cutoff value when it comes to AMH and prediction of pregnancies after IUI. So what about role of AMH in IVF? That's the most important area where we are using AMH to predict the women which will have hyper response, to predict women who will have poor response, and to individualize the stimulation protocols based on whether we are dealing with a hyper responsive, normo responsive, or poor responsive patient. Can AMH be used as a predictor for the pregnancy rates as well as live birth rates? That's also we are going to look into. Now, there are quite a few studies which have been published in the literature regarding the prediction of hyper response with the use of AMH in IVF. Now, I have taken two meta-analyses which compared 57 studies which compared correlation between AMH and excessive response or hyper response, and 4,786 women were included in that study, and it found that there is a positive correlation between the increased levels of AMH and hyper responsiveness in these women. So when I say it's a prediction of excessive response, are there any cutoffs which have been studied above which we can say that yes, this woman is likely to have a hyper response? And that's been studied by two papers I could find. One was from our ONC Ramchandra Mission Hospital from Chennai, and then they developed a cutoff value for AMH both in PCOS as well as non-PCOS women, and then the cutoff was 6.85 nanograms in PCOS women and 4.85 nanograms in non-PCOS women. Another study which was published in the same regard said that the possibly useful values for predicting excessive response could be around 4.89 nanograms. So anything above 4.89 nanograms in these cases, this is obviously a non-PCOS. This was a non-PCOS group which was studied, and that's where the cutoff we can take it as a cutoff for hyper responsiveness. Now, what when it comes to prediction of poor response, where again a meta-analysis which was published, which included 28 studies and 5,705 women were included. So the size was quite good, 28 studies and 5,705 women. And that also said that AMH can be used as a prediction for poor response, and we can alter our stimulation protocols based on the value of AMH in these particular women. Now, the same AMH is taken as a factor, one of the factors to define the Bologna criteria for poor ovarian response, where they say an abnormal ovarian reserve test, AMH is one of them, less than 0.5 to 1.1 nanogram. So the cutoff for poor responder taken in Bologna criteria as far as AMH is concerned is less than 1.1 nanograms. But then there had the Bologna criteria had its own flaws, and therefore a new criteria is developed nowadays, which we all are talking about, is the Poseidon criteria, by which we divide the patients into 4 groups, group 1, 2, 3, and 4. If you see, even there, AMH is one of the criteria or one of the factors considered for the categorization, and the cutoff taken is 1.2 nanograms. 2018, a Cochrane review was published in this regard, and it said that even though that the AMH value doesn't have any direct relationship with the pregnancy rate, but it does have a relationship in predicting the moderate to severe OHSS. What is the prediction of pregnancy and live birth rate? Despite good performance of AMH in predicting ovarian response, it seems to be a poor predictor for pregnancy and live birth rate. So we may use AMH for categorizing the patients, but it's a poor predictor for pregnancy and live birth rate. Now, sometimes we see a discordance in AMH and antral follicle count. High AMH, low AFC, or low AMH and high AFC. Now, that's a very tricky situation, what we should be doing in these cases. It said that intermediate dose of gonadotropins between that assigned for the high and low end seems a reasonable approach in such cases where we find discrepancy between the AMH and the AFC. So there was a predictive index which was first reported by Oliveira in 2012 and 13. It was called as an ovarian response predictive index, wherein they took AMH multiplied it by AFC, and divided it by age in years. And then they found that the ORPI values less than 0.2, they categorized it, and accordingly they were giving the or adjusting the dose of gonadotropins, and they found that a good correlation between this ORPI and the outcome. But this needs to be validated by other larger studies, and therefore it's not used quite often even today. Now the 2019-20 ISHRAE guideline also tells us that AMH is used as one of the ovarian reserve testing tests. So when should I be doing this AMH assessment? It can be done on any day of the cycle in the months preceding the stimulation cycle. There is no variation when to do the AMH. That's the most plus point or positive point of AMH assays. Now, AMH in assessing future ovarian reserve status. Now, this is something which we need to think of, that whether it predicts menopause. Yes, this was a study which was published and has had a positive correlation. They studied AMH values in girls between 9 and 12 years of age, and then they followed up and saw whether those who have got low AMH values at that age had earlier menopause, and they said that yes, low AMH at this particular age led to early menopause. We can use this as a prediction or in counseling these girls when it comes to postponing the pregnancy or when they should go for their reproductive function. Now, AMH is also used in assessing the damage after the chemotherapy, radiotherapy, and ovarian surgery. And therefore, it's a good tool to assess the loss of partial ovarian function or ovarian failure after one of these. So we should be measuring it before and we should be measuring it afterwards. But when we are using AMH, one should understand that there are variations even in a healthy individual. There are inter-individual variations in the same group of the same age. There are ethnic variations, like Asians or African Americans have got low AMH as compared to the Caucasians. BMI and AMH have got a negative or a relationship between each other. Increased BMI decreases the AMH value. Smoking decreases the AMH value. And if the woman is on oral contraceptive pills, the AMH value may decrease up to 50%. So all these things we need to keep in mind when we are interpreting the results based on the AMH values. So friends, the take-home message is AMH is a good ovarian reserve test. It is a good predictor of hyper response. It is a good predictor of poor response. It is used in defining the criteria like Bologna and the Poseidon criteria. It is a poor predictor, but it is a poor predictor of pregnancy and live birth rate. It is used to assess the damage caused by chemo, radio, and ovarian surgery. It may be used to predict the future of ovarian reserve status. Thank you so much once again, Dr. Rakhi, for giving me this opportunity.
Thank you, Chaitanya sir. That was almost complete. You covered everything about AMH. Thank you so much. Over to you, Ananya.
Thank you, Dr. Chaitanya sir, for the elaborate presentation on the role of AMH in infertility, and Chandrika ma'am for chairing the same. With this, we come to the end of the session and also the end of the CME. Now, I'd like to request Dr. Rakhi Singh ma'am for giving the vote of thanks. Over to you, ma'am.
Thank you, Ananya. At the outset, I am thankful to President Foxy, Dr. Shanta Kumari, for giving us the Endocrine Committee and the International Academic Exchange Committee the chance for doing this Orchestra of Hormones, Endocrine Our Lifeline program webinar, and thankful to all the delegates who were there. And at the outset, I would like to extend my thanks to Secretary General of Foxy, Dr. Madhuri Patel, Dr. Basab, who is the Vice President and the guide and the convener for this program with me, the Dr. Bipin Pandit, who is also again the guide and the convener for this program and the Vice President of Foxy, Dr. Professor Krishnendu Gupta sir, who's been there guiding right from the beginning till now, all through, and seeing to it that everything works well, along with Dr. Amaya Purandre, who's been coordinating and organizing the whole program with me. Thank you, Dr. Amaya. And I am thankful to the chief guest for their day, Dr. Kamal Bakshi ma'am, whom I'm always admired and seen through. And thankful to our international faculty, Dr. Raymond Lee, who's taken out his valuable time to be there with us. And thankful to all the chairpersons, Dr. Neera, Dr. Shailaja Bidri, Dr. Aruna Madam, who's been there, the joint secretary, and I would like to fondly call her Man Friday, who does everything and doesn't leaves any stone unturned. And then thank you, Dr. Aruna. And Dr. Shaila Sheikh for taking out her time for our program, and Dr. Abhay Dalvi sir, who's the president of Surgeon Society of India, for taking out his valuable time. Dr. Jaideep Tang, thankful to you. Dr. Bipin Pandit sir, Dr. Nandita ma'am, again with a passionate talk. Thank you, ma'am, for being there with us. Dr. Aditi and Dr. Sonal Parihar for doing excellent work, and thank you, both of you. I'm thankful to all the panelists for the day. Dr. Meeta, Dr. Rajiv Tukral, orthopedician, Dr. Shilpa Joshi, the dietitian, Dr. Pushpa Sethi ma'am from Delhi, again a gynecologist, and Dr. S.K. Sharma, who's taken out his time, the endocrinologist, and my co-moderator, Dr. Parikshit, who's been guiding force for this whole program along with me. And thank you to Dr. Madhuri ma'am, Dr. Krishnendu, Dr. Vijay Lakshmi ma'am for joining and being there, Dr. Archana Singhal, Dr. Neelam Ori, and my ready reckoners, Dr. Apurva, Dr. Archana Devedi, Dr. Meenu Handa, Dr. Hitendra, and Dr. Chaitanya, and Dr. Chandrika. And my whole vote of thanks won't be enough. I cannot conclude it before I thank my MOCs for the day. That is Dr. Anshu Raina, Dr. Meenu Handa, Dr. Deepti Agarwal, and Dr. Ananya Das. And again, a big thank you to Tirupati and team for being the academic partners and guiding us all through for the day and sailing this whole program nicely. Thank you, one and all. Dr. Shanta Kumari ma'am, thank you for the opportunity, and it has been a great honors for us to be there with you in this program. Thank you. Thank you, one and all.
Thank you, Raki. And
thank you, Dr. Raki.
For the excellent program.
Thank you. Thank you to all my zonal coordinators. All 4 of them did a great job. Chandrika was
a lot of hard work.
Dr. Meenu was the North Zone coordinator. Dr. Ananya being there with us, she is the East Zone coordinator, and whom I forgot.
Chaitanya sir.
Chaitanya, हाँ, सामने दिख करके भी नहीं दिख रहा है. He's the West Zone coordinator. All of them did a great job.
Thank you.
Thank you. Bye, Raki. Bye. Thank you. Thank you so much.
Thank you.
Thank you, everyone. Bye.
Bye.